This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed.
Good morning, everybody, and I now declare the meeting open to the public online. I would like to welcome our members who are participating by video conferencing today to assist with the social distancing requirements. And this morning, those are Deputy Chair Pam Cameron, Paula Bradshaw, Colin McGrath and Orlia Flynn. And thank you for that. Can I remind members about the protocols regarding the use of electronic devices? Apologies, we haven't received any apologies for this morning's meeting. Are members aware of any apologies? No, thank you. Okay. In terms of then Chairperson's business, I would just like to, on behalf of the committee, thank Alex for his work on this committee and to wish him well on any future committees that he's taken part in. We all wish you the best, Alex, in that. I also want to mention that we have a number of MLAs at this point who are self-isolating, including our own Deputy Chair, Pam Cameron, and the Minister are self-isolating as a result of having received, through the contact tracing app, notification of a close contact. I want to wish all those who are impacted by that well over the days ahead, and it's a worrying time for you all, but to wish you well, but also to just indicate that it does demonstrate the impact and the benefit of the Stop COVID app, and just to appeal to everyone who hasn't out there in the public downloaded that app to please do so, because it does help to identify when you're in contact with a close case. Moving on then, members, to the draft minutes. I refer you to the draft minutes of the meeting held on the 13th of October and the 15th, so that was both of our meetings last week, which are at tab 3.1 of the meeting pack. Are members content with those minutes? Yeah, thank you, members. There are two matters arising from the minutes. The first one is the committee agreed at last week's meeting to forward correspondence from the Committee of Finance to the Department of Health, seeking details on bids submitted to the Department of Finance. Are members content that all financial papers received by the committee be shared with the Committee for Finance to assist with their work on the review of financial processes? Agreed. Members content, thank you. Secondly, further to last week's discussion on the arrangements for providing flu vaccinations during the extended half-term break, item 4.1 in your table papers, there's a response from the Department of Education there. Are members content to note that? Yep, thank you, members. So, moving on then, members, to our committee inquiry into COVID-19 and its impact on care homes. We are receiving this morning a briefing. Our first briefing is from the independent health and care providers. We will also this morning be receiving a briefing from the Chief Nursing Officer and Chief Social Work Officer, and we have a third briefing which is... what's our third briefing, Clerk?
Chief Nursing Officer, Chief Social Worker.
Yes, but there's a third one.
RQIA.
RQIA, yes. We are also receiving a briefing from the RQIA in relation to their role. So, our first session, as I said, is from the independent healthcare providers. I refer you, members, to tab 5 of the pack and tab 5 of your table papers. And I now would like to welcome by video link Miss Pauline Shepherd, who is the Chief Executive of the Independent Health and Care Providers. And good morning, Pauline, and good to see you, and thank you for coming along to the committee this morning. Could I now invite you to go ahead and brief the committee today? Thank you.
Good morning, everybody. Thank you very much for the invite to address the Health Committee. I have followed the guidance that you'd sent out in relation to the headings and the subheadings, and have tried where possible to focus on the steps necessary to minimise infections in care homes and care for those infected, including the well-being of residents and staff. I have also included references to home care, or what's commonly called domiciliary care, on the basis we believe that that's very relevant. We see these services as being an integral part of the connected plans going forward. So I have referred throughout the briefing to home care or domiciliary care services. First topic is discharges from hospitals to care homes. Testing is required 48 hours prior to discharge from hospital to a care home, and the results of these tests are not always available on discharge, and care homes isolate all new residents for a period of 14 days. In spring, there was evidence that there was pressure on care homes to continue to support discharge pathways for older people out of hospital, and this is a concern again that there may be pressure again to do that. Not all trusts have discharge pathways to accommodate those who have tested positive for COVID and either continue to test positive or are medically fit for discharge but remain in the infected period. Some care homes are providing step-down facilities, completely separate from the main care home residents, so that there is an opportunity for patients who have tested positive to be discharged into a unique, safe environment. There is no universal approach and no safety net of retesting residents discharged after the 4 to 7 days to ensure that they have not contracted the virus in hospital. Home care services, to cover that, the hospital discharges to home care services are not tested, and we believe testing should be carried out for any discharge to a home care setting. Moving on to access to PPE. PPE continues to be supplied where necessary by health trusts, and there have been no recent concerns about availability. We have been advised that the support to supply will continue, but an assurance on the continuity of supply and how long this will last would be of benefit, particularly with the increasing pressure on the hospital settings. The cost of procuring PPE on an individual basis is significant, with prices soaring across all PPE products. We need to be mindful that any change to the PPE guidance needs to be communicated early to care homes and home care providers. A consistency of approach to these guidelines across all trusts needs to be assured. Moving on to the testing in care homes. Staff are tested every 14 days and residents every 28 days. These routine tests are carried out by care home staff using the national testing system, and there have been considerable problems with delays in results, the IT system and the courier service. In the past week, there has been an improvement in the results turnaround, but as there is more testing being carried out, there remains a concern about the capacity of the system to deliver going forward. An outbreak is 2 symptomatic cases at present, so homes can get into an outbreak before positive tests are confirmed. Repeat positive tests are also putting homes into outbreak. This stops admissions and curtails visiting. The PHA and trusts take over the testing in the case of an outbreak, with tests being carried out locally. However, recent feedback indicates that trusts are starting to struggle with their capacity to complete the repeat testing at days 4 to 7 in care homes due to resourcing issues. This is resulting in a delay in completing this repeat testing process and subsequently a delay in identifying positive cases. The Trust PCR test appears to be a more sensitive and reliable test than the national testing system. There are monitoring systems in place, but as you are aware, many of the positive tests are now from asymptomatic people. Symptom monitoring guidance from PHA needs to be revised, and we're aware of ongoing engagement around the wellness checklist, which is referenced in the care home guidance, but this needs to be progressed. There are staffing problems arising from the additional resource required to undertake these tests, and I've covered this in more detail under some of the later headings. Resident consent issues is a topic that was in the brief. Not all residents or indeed their representatives agree to testing, and IHCP has asked PHA what monitoring system is in place to quantify the number of untested people and what that risk is. As yet, we haven't had a response to that, so I can't answer that question. Footfall into care homes has increased, with allied health professionals and inspectors now accessing for visits. We have asked that any footfall into a care home should fall within the routine testing protocol. It is the sector's view that testing should be carried out weekly for staff and every 2 weeks for residents. All those professionals who interface with care homes, including RQIA, trust teams and agency workers, should be required to undertake the same mandatory testing as care home staff. As mentioned previously, discharges from hospital to home care services, or indeed the home care staff, are not included in the routine testing protocol. Home care providers are finding it very difficult accessing timely testing, and that also applies to supported living settings, where staff actually have to travel some considerable miles to get tested, and that's taken them away from an already depleted resource. Moving on to funding and increased costs for care homes, the increased resource demands have been created by the routine testing process, visiting, monitoring and supervision. This is compounded by reduced staffing levels due to isolating and no childcare due to school class closures. Grant funding has been made available for enhancing cleaning, staff sick pay and technology, but has been significantly underclaimed and underutilised due to the eligibility criteria and qualification time limits. In addition, there has been support for care homes that have been underoccupied as a result of COVID. However, not all of these payments have been processed, and there is a delay in sorting out the blockage for payment. There have been ongoing meetings with the Department of Health since July regarding funding pressures, with continued commitment for submissions to be provided to the Health Minister. Obviously, the Minister made an announcement just yesterday in relation to funding being released to support care homes, so we very much welcome that and look forward to finding out the detail about what that will translate into. So we are aware that they are considering the funding pressures. Moving on to staffing issues and levels, additional tasks have been added to current staffing levels, including those that I've already mentioned of routine testing and visiting. Other resource pressures have arisen as a result of additional monitoring, assurance, surveys, audits, assisting with virtual visits, assisting with GP consultations by videos, and those have all added to the staffing challenges. Staff shortages are a challenge to cover, and agency staff are being used at considerable additional cost. Concerns have been raised by IHCP about agency staff and, in the past, student nurses moving from care home to care home and to trusts, and the transmission that possibly could create. We are very concerned that all of the expectations of controlling footfall into care homes is left with the care provider, and other stakeholders are not being set requirements to follow or supporting solutions to cover staff gaps. Problems attracting new recruits are also occurring, with a number of our members stating that there has been a very poor response to recent recruitment campaigns. And if we look back to the first wave, there was a very low number of volunteers during the national appeal during that first wave for the independent sector. So that is becoming a critical concern for us. There has been a meeting just this week with the Department of Health to try and resolve some of the barriers to the recruitment processes. However, we are concerned that the feedback is also that the trusts obviously are facing the same pressures and will not be able to provide support to the independent sector in a similar capacity that was earlier in the first wave. Moving on to training and guidance, we very much appreciate the access to online learning, which has been opened up to care homes and home care providers via trusts and the CEC. Attendance at these sessions is important in embedding the key knowledge and learning regarding COVID, but requires releasing staff from hands-on care, which there has been no recognition for. Trusts have also been completing IPC monitoring and audit visits, which again requires resource to support. It seems there is an expectation that all of these very important and valued interventions can be delivered at a time when care homes have less resource. And again, I appreciate that the Minister has made an announcement about support for testing and visiting. However, that funding now needs to translate to actual bodies on the ground, and that's where our difficulty is of actually getting the staff to carry out the tasks. Moving on to staff pay and conditions. Staff terms and conditions vary from employer to employer. Support to top up statutory sick pay has been made available to staff in home care services, but was limited to a time-specific period for care home staff. We've sought to address the inequality between these two workforces and also the inequality of compensating those in care homes that were off in the latter part of the pandemic, but not those at the peak of the pandemic. There has been some recent movement in extending that sick pay scheme for care homes going forward. There's considerable pressure and cost to address issues such as those staff off isolating or needing to remain at home because the children are isolating and they've no childcare. Staff have been managing through particularly difficult and challenging times, and many are very tired. This is further impacted by reduced resource. Many of the staff who continue to work through the experience of losing multiple residents due to COVID are afraid of going back to that position. And those care homes that have not had that experience are afraid of being impacted with the second wave. And it's a question that I would like to put to the Health Committee and ask, is there any intention or are you actually taking evidence from frontline key workers, care workers, or actually residents themselves to assess the impact? Care home providers and staff are doing all they can to reduce the risk of COVID entering their homes. Staff changing facilities was a topic that sought some feedback on, and care homes have worked hard to ensure that the IPC measures around uniforms and PPE wearing are adhered to. This has required a review of areas in care homes where staff can safely have space to achieve good compliance. In some care homes, bedrooms have been taken out of use to accommodate donning and doffing of PPE. Other support has included the psychological support services from trusts, and that has been made available to the independent sector and is very welcome. I'm unsure of the uptake levels for that service, but I am aware that the trust psychological support teams provided additional support to the care homes that faced multiple COVID-related bereavements, and we're hoping that that support will continue going forward. However, generally I would say overall morale remains low and staff are very tired and very worried. Worried that they feel that the system is now working against them in trying to keep COVID out of care homes. And I'll move on to that in terms of visitors. There have been a range of innovative ideas to assist with family visiting, which include video, Zoom calls, garden visiting and visiting pods. However, the restrictions are putting serious pressure on residents and families, and moving into colder weather impacts on the outdoor visiting solutions. The recent visiting guidance has caused concern, particularly against the backdrop of the worrying increase in the community transmission. The care partner idea, we fully accept that there is considerable pressure on families and on residents, and that it is having a detrimental impact. The care partner idea was included in the guidance, but was not discussed with the sector, and there are many problems which were not foreseen within the policy, not least insurance and regulatory requirements. We have flagged the issues that need to be addressed in order to mitigate the risk of the increased footfall, which could be as high as 2 care partners for each resident with unlimited access. These include routine testing, that being increased in frequency, and results delivered on time, staffing issues addressed, appropriate funding, support and recognition for staff. Until these are addressed, it is unlikely to be assessed as appropriate to increase footfall into care homes while the community transmission rate increases. I've just received, I wrote to the Chief Nursing Officer a number of weeks ago in relation to the visiting guidance, and I've received a response late last evening, and I'm hoping to pick that up with the Chief Nursing Officer to follow through to see if we can get some solution to some of the problems that this has created. The wider impact of this pandemic on residents has been significant, going much further than visiting restrictions. Normal life in a care home has been greatly impacted by such things as isolation, the additional ICU requirements, services such as simple things such as podiatry. All of these have an adverse impact on people, and even for those not directly impacted by COVID itself. Moving on to regulation, the RQIA have commenced a mixed approach to inspections and have indicated that they are doing this on a pilot basis. There are concerns that the virtual visits are actually more resource intensive than on the ground because all the documents have to be scanned, uploaded onto a system and then gone through within the virtual visit. There remains a number of avenues for care homes to raise concerns. The PHA and RQIA, however, reports are that access to advice out of hours is challenging. I have been speaking regularly to Dr. Tony Stevens, head of the RQI, and raised the issue, and that there are plans within the RQIA to move to out of normal hours support. And I've also spoken to the PHA late last night, where they're trying to extend their support into out of office hours as well. There was a topic here on HSC run versus the privately run homes, and IHCP has been asking for the past many years for an independent economic review to be completed to identify the true cost of care. In addition, we have suggested that this could be supported by a financial regulator. On the basis of a full financial and economic analysis, a full comparison could be carried out between public and private provision of services, and they could be appropriately assessed. But until that's done, there is no real assessment measure. Medical care within care homes, the InReach team, support from GPs, advanced care plans. While each trust has a COVID response plan in the first surge, those differed in composition. The interface with the residents' own GPs, who know them best, was almost non-existent. These COVID response teams seem to have been stepped down in some areas, and the commitment to completing advanced care planning for all residents has not been fully achieved. Again, some trusts have advanced their plans through virtual reviews, and the Northern Health and Social Care Trust has made considerable progress in that area. On preparedness within the health and social care and care home and the future requirements, there has been a myriad of work streams on planning and reviewing, including surge planning, rapid learning, keeping COVID out of care homes, and psychological support for staff. If the care home surge plan is to be the overarching document which connects all stakeholders in a safe and effective management and delivery of care, then there needs to be an urgent commitment from the Department of Health to address the queries we have raised within the surge plan, including the requirements levied on care providers to confirm they are meeting the actions listed. We are concerned that the resourcing and funding to deliver on the surge plan is not in place across all stakeholders. IHCP has continued to emphasise the need to integrate the home care services into the reviews and forward planning. A home care surge plan is not yet in place, and there is a need to utilise the potential capacity of the home care workforce. We are seeing shifts in the landscape from the first wave to the second, and these two areas of care overlap. We're also aware that referral mechanisms to home care services remain at a virtual standstill, and we are aware that there are people in need in their own homes. IHCP members have advised that they are very concerned about the capacity to continue to deliver care, together with the expectations placed on them, facing the continued increase in COVID transmission. And in conclusion, IHCP has been observing that there is and has been significant activity within many areas of the public HSE system, and much of this has resulted in surveys, guidance which is sometimes contradicting, assurance seeking, reports, contingency plans, etc., all being targeted at care homes and home care providers. Much of this has resulted in significant work for the independent sector. Much of the work is embarked upon and then seems to fade into the distance. And in several cases, we've been urging for completion without success. This scattergun approach thus leaves the multiple lines of advice, learned best practice, contingent pandemic planning, and effective COVID-19 management fragmented. We would wish to see a more targeted, connected approach under the control of a singular body, preferably with a singular lead person on the health and social care side, which we believe would drive a more apt response and better integrate and dovetail the independent sector COVID-19 response with that of our public services, and would assure residents and citizens in Northern Ireland that sectors are inextricably linked and working efficiently for best patient outcomes. And that concludes my brief. Thank you very much.
Okay, thank you for that comprehensive brief, Pauline. And just to say, in relation to your question about our engagement with families and with workers, we have heard from workers via their unions and indeed from residents' families via an informal Zoom. And we have run a survey which has had hundreds of responses from workers, managers, families and residents. I'm just going to check quickly on the line if Paula is there with a question. Paula, do you want to go ahead with the question there?
Yes, sorry, apologies. I have to go quickly in a few minutes to meet the Communities Minister. My question was really about the attitude of your organisation towards the proposal and the guidance for the introduction of care partners. A lot of the residents that we've spoken to relatives of the residents we've spoken to were very keen to see these introduced, but when we spoke to the union representatives the other day, particularly the Royal College of Nursing, they weren't quite so keen because there isn't a regional framework, policies, etc. So it's just to see where you are in terms of that proposal, please.
Paula, we have said and confirmed that we're very supportive of trying to increase and relaxing visiting into care homes. We see the need. We see the need from residents' point of view and families, but only when it's we have the proper controls and measures in place to actually mitigate against any risks. And at the minute, there are issues that we feel need to be addressed before we could move in that direction. We have put proposals around visiting pods and having safe places where people could visit. So if all of those are moved forward, then we could move in the right direction. Part of the resistance that we've experienced so far is around insurance issues, health and safety. I think we could resolve these, but the issue was that it was more or less put into guidance with the need to have them in place by the 5th of November, and that created difficulties.
Okay, and then just as a quick follow-up then, so have the department come to you then to say, look, let's sit down and actually look at the policy and look at some of these potential barriers to having them introduced? Thank you.
We had an initial meeting a few weeks ago, and that was the letter that I referred to that Charlotte McCardle, the Chief Nursing Officer, has written to me late last night with a view to saying, can we now talk about some of these proposals and move them forward. So I'm hopeful that we might be able to, resolve some of them quickly. We do realise there's a need for families to visit. However, there's also lots of families out there who are also expressing the fact that they don't want risks increased and that they are happy with the visiting the way that it is. So I think it has to be balanced across everyone's needs and expectations.
Thank you very much.
So a couple from me, Pauline, and then I'll go to Pam Cameron, our Deputy Chair, on the phone, and Colin on the phone, and then back to Alex in the room here. So in relation to the discharge policy, Pauline, you've said there that there's no universal approach and no safety net of retesting residents discharged after 4 to 7 days. And I think it is an area of concern in relation to the discharge policy right from the very outset of the pandemic, where there was a situation where potentially very many COVID positive patients were discharged from hospitals into care homes. So given your concerns in that area, what recommendations would you be making in terms of how we might do that better in this time that we're facing into now?
Currently, if someone's discharged from hospital into a care home, they get the test 48 hours before they're discharged, but then they fall within the normal routine tests within the care home, and that would be every 28 days. What we're asking for is that care home residents are tested more regularly, and that those discharged from hospital should be tested again within a short space of time of actually coming into the care home, so that it could be identified if they'd had COVID whenever they actually came from the hospital setting, or whether they contracted it within the care home, and that would actually help identify COVID more quickly and actually identify the source more easily as well.
And in relation to managing COVID positive who have been discharged into care home settings, what's your view in terms of the preparedness of care homes to deal with COVID positive residents?
Well, there are some care homes who will not accept COVID positive residents or COVID positive discharges. There are some that have set up specific facilities to actually accept COVID patients or COVID residents into a separate and completely safe, unique system. It's something that we have also been asking around the White Abbey Hospital and the Nightingale, because that also would have been used or could be used to actually step down people with COVID and still infectious into that facility rather than actually into a care home. So care homes will not accept COVID patients unless they can do it safely and separately from the other non-COVID areas.
And are you satisfied that care homes can safely isolate within the care home, within the majority of care home settings?
Well, some of them have facilities and can manage it, but not all of them have. And that was where I was concerned previously, that care homes in the first wave were put under pressure to actually accept discharges from hospital without having even been tested. So I think we need to spend those discharge pathways between trusts and care homes need to be clarified. We need to sit down and talk about them and actually get them clear, because as the hospitals come under pressure, then the pressure will then revert to discharges into care homes, and we need to get those discharge pathways completely clear and a testing system in place that meets the requirements.
Okay, and finally for now from me, you said during your presentation the system is working against us. Can you elaborate a bit on that in terms of how the system is working against and what needs to change?
I think I expressed that as a feeling from staff and the low staff morale. Staff are so worried about COVID getting into care homes that it hasn't been in, that whenever the guidance went out on visiting, and indeed in relation to having to have care partners in place by the 5th of November, a lot of staff felt very, very worried about that and felt that all of the work they're doing to try and keep COVID out, nearly the system was working against them to say, well, you need to now increase the footfall, and therefore we are increasing the risk and telling you to increase the risk. And that's where that feeling came from.
Okay, thank you. So I'm going to go across then to the phone and the teleconferencing to Pam Cameron. Go ahead, Pam.
Thank you, Chair, and thank you, Pauline, for your attempts once again. And certainly don't envy your role in all of this, and we understand it's a very difficult time, and that there is a need to strike that balance within the care setting. So certainly you have all our thoughts around this issue, because it is a very difficult time. Just to quickly kind of touch on both Colin's and Paula's points there, and then I want to ask my own question. And you'd mentioned there Nightingale 2 at the White Abbey site, and certainly it would have been my understanding, and we'll maybe ask if the Health Committee could follow up with the department to get clarity around that, but it would have been my understanding that would have been a facility that could have been used for those purposes, to kind of in between discharge and going back to the resident's own home, which would be in a care setting. But I'm very aware too that there's a gap there for those who have maybe had a recent visit to A&E and weren't actually admitted into a ward, that there's nothing around that facility to allow a wait, and there's no facility for that period of time to allow the result to come back before actually discharge, not discharge, but letting them go back home to the care setting. So I think that is another issue. And I'm also very concerned in terms of the visitation. I have had complaints from families who have loved ones who actually have COVID or are suffering from it right now, and they, because of the pressure on the staff, they're actually unable to get answers to phone calls. I've actually tried myself from my office many times, and they can't get an answer to an email, and any responses that they do get are of the variety of, please stop calling, we don't have time to answer you. That's very, very concerning, and I don't know how you meet the need and dealing with that balance, because we do need a more compassionate care model where emotional well-being and mental health is also being cared for, and what is a very, very stressful time for residents, especially those who actually are suffering from COVID. And then my final question to you, Pauline, would be in and around the need for increased testing, and it seems pretty clear to me that the testing doesn't need to be increased for both residents and staff, and I'm aware that that is a big administrative pressure on the home too, and they may feel that they're not able to manage that. So with that in mind, would you have any concerns or worries about bringing in mutual aid in order to deal with, say, testing to take that pressure off those care settings?
I think, Pam, first on the points in relation to the visiting and the staffing, that is our main worry going forward. Our main worry is that as test results come back, staff that are tested positive, they have to leave the care home. Now, getting replacements and getting cover is getting increasingly difficult. So the amount of additional work that has been put on care homes with reducing staff is causing grave concern, and that's what I been pressing with the department to try and get some resolve to. So I fully see the pressures on families who maybe are seeing those pressures and seeing the difficulties. We need to find a solution for the visiting. And we need to find some way of actually supporting care homes. Now, I am worried that during the discussions I've had with the department, it's clear that the support that was given in the first wave appears not to be available this time around. And I have been asking questions about, well, what's going to be prioritised here? If we go back to the same situation we had earlier in the first wave, with care homes facing the real difficult end of this, where are the resource going to come from to actually support, and what other services will be stopped in order to redeploy? So my whole concern is around the redeploying of people to actually manage where this virus presents in its most difficult format to manage. So to me, those are the very difficult questions, and I don't have answers for them, and I'm not sure yet the department has. On the increase in testing, there would be. We would welcome any support that there is, but again, any support that there is that increases footfall also increases the risk in terms of transmission into a care home. I was appreciative of the Minister and the Chief Social Worker's comments yesterday in the press conference to actually make it clear to the public that it's almost impossible, and it is impossible to keep COVID out of care homes, that no matter what is done, if it's being transmitted in the community, it will get into a care home. Now, part of our issue is about having the proper data and intelligence and working with the PHA in order to identify hotspots within the community. And we're pressing the PHA to be able to advise care homes, let the care homes know if there are problems within that area so that they can take appropriate steps. But at the minute, we don't believe we're getting the appropriate intelligence and data to be able to make those informed dynamic risk assessments. Sorry, that was a long answer to your question.
No, that's good. Thank you.
Thank you. And going then to Colin McGrath. Colin, are you on the line there? You're on mute, yeah. Maybe? Yeah, go ahead, Colin. We're hear you now.
Yeah, and thank you very much to Pauline for her presentation. I suppose you're representing sector that has had a very difficult time, has been at the front line, certainly through the first wave, and very much in a defensive position now. And it's obvious from the staff and the homes that we're interacting with that is causing fatigue, it's causing stress, and that is all being heaped onto people that are meant to be working in a caring role, and that must be incredibly difficult for them. And it's something that I'm sure all members will recognise and appreciate. On a couple of the issues that you mentioned, with regard to testing, is it my understanding that correct that care home staff are not considered Pillar 1 in terms of testing? So in other words, they're not considered part of the health service, and that in some instances that can cause some additional delay in getting responses. And I think if we're to take in good faith the comments that are made by our health minister and other members of the executive, that people that work in the front line in care homes are truly part of this response to COVID, I think we need to include them in that Pillar 1 response so that we can get much quicker turnaround for their test results. I was also interested in what you had mentioned about the consistency of PPE is not the same across all the trusts. Are you finding that any particular trust is being more difficult to help secure that PPE than others? Anecdotally, from people in the sector, I'm hearing that they're only able to access PPE when they actually need it, which is probably nearly 24 hours too late, because they need it whenever they are preparing to go in and do their work, whereas they're only finding out on the ground that they actually need something, then they have to ring up for it, then they're getting it, and there's a delay. So there seems to be some sort of issue in that. But you did refer to an inconsistency across trusts. So is there a particular trust that we maybe would need to seek out and maybe try and get some help from that? And I would just reiterate the remarks about visiting. It is something that we shouldn't leave just to the care home sector to try and crack. I think it's something that the entire health and social care family need to work on, because I use that word family. There is an Article 8 in the European Convention of Rights which says there's a right to family life. And I wonder, whenever we have some of our elderly, vulnerable people that are in homes near the very end of their life, and we're not able to let their family come in and visit them, whether or not we're actually robbing them of that UN or EU right that is there in the Convention for Article 8 for a right to family life. Thank you.
Okay, Colin. Your first issue in the testing in the Pillar 1, yes, you're right. The care home staff and residents are classed as Pillar 2 and therefore go to the national testing. It's your question I've also been asking to the PHA, because I do feel if we were in Pillar 1, then we might get the test results back more quickly. However, the capacity within Pillar 1 to actually do the testing is in, that may not be there. So we may just shift the problem into Pillar 1 and the capacity's not there, and, the tests aren't. So there is the issue around the resource for actually carry out the testing, whether it's in Northern Ireland or at a national level. But yes, I agree totally. I do think that the home care as well is the critical issue, that home care, staff need to be tested as well, because why are we testing only in a care home environment and we're not testing people discharged and into their own homes? On the PPE, the inconsistency that I was referring to wasn't in relation to supply. The supply of PPE is quite, it is continuing. The inconsistency is around the guidance that's given, and that we seem to have different trusts giving different guidance of what PPE to use when. And we've had that quite right from the beginning. So we need a consistent approach about what the guidance is and when you use particular PPE equipment. So it's the guidance is the inconsistency. On your final one on the visiting, fully accept the issue in terms of the rights and the human rights. On end of life, care homes do allow visitors at end of life, and visitors will get in. Now, it may not be completely open, but yes, in these circumstances, end of life is an issue and there are other issues where visitors are allowed in for particular circumstances. So it's not a complete lockdown in terms of visits, and it may vary depending on a number of factors, being community transmission, if there's already COVID in the care home, and if it's safe that there's enough staff there to actually manage it. So there's a number of variables in that, Colin.
And just to finish with a statement rather than a question, Paul, I don't think it's fair of any of us I think it's moved almost into a space where there's blame at care homes for not providing the visiting. And I think actually care homes are trying to do what they can to provide a safe environment, and they've got concerns. And I think what we need to do is that we all, as a health and social care family, from legislators, ministers, committee, right down to providers and trusts, we need to work together to try and resolve this. And I think if we all come together, we should be able to resolve it.
I couldn't agree more, Colin.
Thank you. And going then to Alex.
Yeah, thank you for your presentation. I'm going to touch on staffing levels, but I just want to say I'm a bit concerned that patients coming from hospitals into the homes are not getting tested. And I was wondering, do you know if those who are doing inspections in the homes are getting tested? Because obviously there's quite a rise in the recent week or so in numbers in the homes, so that's a concern. But in regards to staffing levels, can you tell us about the adequacy of staff numbers in care homes presently and support coming from the Trust in that regard? Thank you.
Okay, on the first one, Alex, the testing is being carried out into care homes, but it's not being carried out where there are discharges from the hospital to someone's own home, where there would be home care, domiciliary care services, and our request is that discharges to people's own homes, where their domiciliary care support's given, those people should be tested as well. But everyone coming into a care home is tested from hospital 48 hours before, or into a care home, they would require a test from coming from their own home into a care home. So that is being carried out. In relation to the RQIA, we have been asking that any footfall into a care home, be it an allied health professional, be it an RQIA inspector, any sort of intervention at all coming into care homes, all of those people coming into a care home should fall within routine testing, and we've asked for that as well. Your final one was around the staffing and the support. Just remind me what the third one was, Alex. It was to do with...
Well, it's about your staffing numbers, and are you getting support from the trust to help with any shortfall?
There have been issues in the last few weeks, particularly over weekends, where there are test results have been reported to me coming through to care homes that have required that maybe been positive, and staff had to then go home. There is difficulty then at a weekend to actually get additional cover. They look for agency staff. If they can't get agency staff, they've sought cover from trusts. But it has been reported to me in the last few weeks that trusts are now saying that they cannot provide staff either, that they're in the same difficulty. So there are problems. There have been problems for a long, long time in terms of nurses. And I see that, continuing, that there has to be a staffing level that's set by the RQIA, then that has to be met. Now, I have mentioned to Tony Stevens the fact that inspections will be picking up around the shortage of staffing. And in my view, the RQIA then, do have an obligation to flag up where they see pressures. But I'm also being told by care homes that there is an increase in the number of non-compliance for care homes. Now, if care home managers are trying their best to get staff have had to go home because they're positive, they can't get staff. I'm asking the RQIA, what more can people do if they have sought every route possible? So I do think it's an issue for the RQIA in terms of looking at compliance with staffing.
Seems to be a big issue. Yeah.
Okay.
Thank you.
Thank you. Going then to Orlea on the phone, then I'll go to Pat and Jerry. And just to advise members that Alan has been on the line there. Alan Chambers has been on the line for some time, so I'll keep an eye out for a hand there up on the screen from Alan. But for now, I'll go back to the phones and Orlea Flynn. Orlea, are you there?
Yes, I am. Thank you, Chair, and thanks, Pauline. I'll make a comment and then I'll ask a question. I suppose the most worrying...
You're a little bit faint. You're a wee bit faint, Orlea. If you can up your volume a little.
Sorry, is that better?
Slightly. It's okay, we're getting you, yeah.
Okay, but yes, I suppose I think one of the most worrying things out of your presentation is around the issue that the trusts are starting to struggle with the repeat testing due to possible resourcing issues, and that this might be then causing a delay for residents getting tested and for identifying, residents or staff that are positive. If that's not being done, then there could be symptomatic positive people that are spreading the virus around the care home. So I think that is a worrying development if that's the case. And it has been raised to me locally, Pauline, around even some discrepancies between the Pillar 1 and Pillar 2 testing models, and we have had some difficulties, which I've raised with the PHA as well, not only just around the time, but around discrepancies between some testing positive, then testing negative on one model, and then testing positive on another. So I'm happy to share some of that correspondence with you, Pauline, outside of today's meeting. But my question is around the issue of the funding. So I was just wondering if you could describe a wee bit more how the additional funding was worked out for the care homes during the first surge of COVID-19. It's not a good sign if it was significantly underutilised. And I'm just conscious that how we can support the care homes if there is going to be further funding to support them. Is there any processes in place that can try and help the care homes with the applications? And is the biggest financial pressure around the PPE, the lower admissions coming in from the hospitals, the staff sickness? Is there one sort of area of concern there around the care homes finances, or is it a mixture of all of those things? Thank you, Pauline.
Okay, thanks, Riley, and thanks for the offer to share that information. It would be useful. On trusts struggling with testing, yes, we are seeing that the capacity in the last week or so, there have been problems with maybe there's been a number of lost tests that have had to be redone. There's certainly some cracks showing in the capacity. Obviously, this time around, although there are test results coming back positive, the feedback on that is that we are now obviously picking up asymptomatic people that are testing positive that they wouldn't have first time around. I've been pressing the PHA that we actually need to start sharing that data and that information, because when you look at the dashboard, you look at it and you think, well, there's 80 odd care homes in outbreak, but we don't have the lower level information to actually say, well, that isn't a direct comparison to 80 odd in the first wave because of the number of asymptomatic. So there's lots more data that I think would be valuable to actually share. We have struggled with the false positives and false negatives, you're right. And I do not profess to completely or in any way understand why there are false positives and false negatives. I've been asking the PHA, can they give some guidance from their virologist in terms of why that is, and try and give some guidance or understanding to care homes about false positives and negatives. We're still awaiting that. But at the minute, if you get a false positive and a false negative, the safe thing is to do is treat it as positive. So if we can iron some of those issues out. Another issue that we've some difficulty with is the actual app. And the app that's notifying people that they've come into contact with, I suppose, people that have COVID is not sophisticated enough to actually identify whether you're a member of the public or whether you're a care worker. So it may well be identifying that you've come into contact with somebody, but that's your job to come into contact with somebody. So there's nuances within the app that there are possibly people off at home because they've been notified from the app, but strictly speaking, they don't need to be because they've had full PPE. And so we've flagged that up as well. So that's causing some difficulties. Moving on to the question about the funding. The funding, there was 6.5 million, that was the first funding pot, and that was split among all of the care homes on a basis of their bed numbers, split, I think it was 20,000, 15,000 and 10,000. There was a second pot of 11.7 million, and that was separated out into 3 discrete areas. And that was for support for sick pay, for IT, and for support and technology or medical things, sort of oximeters and various things to actually help with care. And the other one was on enhanced cleaning. The difficulties, and we've flagged it up from the beginning, the difficulties around the claiming. It was a very bureaucratic. There was a lot of time restrictions in it. The eligibility was only for a set period of time. There wasn't the flexibility, for example, where we were saying, well, a care home, for example, didn't need iPads and didn't need the technology to help with visits. However, they wanted to create a different access area to their home, which required to put steps and a handrail in to be able to provide, but that wasn't eligible. So there was various things that could have been more flexible, but obviously there needs to be governance, there needs to be the controls, and people in the trust had to work within the parameters that were set for them. The Minister did mention yesterday in his briefing about actually widening out the eligibility to include possible adaptations to buildings, small changes. So they've taken on board that, and they've also taken on board that the system needs to be streamlined. So the fact that it was underspent did not at all mean that the money wasn't needed. It's just, it was impossible to claim all of it because of the system and the red tape that was put around it. And the biggest issue, I would say, in terms of the staffing and the funding is around actually paying for trying to obtain those resources, be it agency, nurses, whatever, and having to pay agencies extremely high fees for actually filling posts. And that is something that we've pressed the department and asked a few times about, is around capping or some sort of regulation in terms of agencies to actually cap those rates, because the amount of money that's gone out on agency to fill positions is astronomical.
Okay, thank you. Thank you, Pauline. And going then to Pat.
Thanks, Chair, and thank you, Pauline. Leah jumped in with the question I was going to ask you, but I want to ask you about patients who are discharged from hospital back into the home care setting. And I'm wondering, do you have any data on the percentage of domiciliary care workers who may have contracted COVID or who are self-isolating as a result of being in close contact? Thanks.
Well, I don't have the data because, I mean, although IHCP, we're a representative body, we don't have all care homes and all home cares as members. So I wouldn't have the complete data across that. The PHA would have the data, but I do know that from our home care providers, they would say that the infection rate for care workers is very low. I know that there's work being carried out at the minute on a rapid learning and surge plan for the home care, domiciliary care services, and they are looking at that data. We're trying to feed in and trying to encourage them to use Northern Ireland data rather than the UK-wide source, because we believe Northern Ireland home care performed considerably better than the broad home care services that they're looking at across the UK. So infection rates have been low within home care workers.
Thanks for that. And just a quick second one.
Yeah.
We know during the first surge that care homes were being pressurised by trusts to take patients who were COVID positive. And we know at the moment that some patients who are positive are still being discharged back into care homes. Has there been any more pressure exerted from the trusts on the care homes in that regard?
I'm aware that I have a number of members have contacted me, and this has happened at weekends, where trusts are ringing care homes in the last few weekends under serious pressure to discharge people because of the pressure of COVID within the hospitals. I'm aware that there have been late night calls to sort of say, look, we really need you to help us. And care homes do always feel that they want to help. However, they also have an obligation to keep the current residents safe. So I am worried that as that pressure increases within hospitals, the pressure will increase to actually discharge more people as the capacity in hospitals reduces. So that's currently where we are.
Okay, thank you, Chair.
Thanks, Chair. Thanks, Pauline. I suppose obviously the recommendations out of the inquiry are essential for everybody. For me, I'm quite concerned about the current system of care. And how it's formulated. I mean, obviously the term independent care is used, but it's a bit of a misnomer because the care home sector is heavily reliant on trusts and the Department of Health for staff and funding and whatnot. So I really want to ask you how safe and sustainable the current model is in your opinion, especially when we've seen in the last few weeks, Four Seasons, for example, announcing the sale of 42 of its homes.
Okay, Jerry, the first point about the independent sector being heavily reliant on I suppose trusts, and that has been there have been reliant to backfill posts and to support, but that has only been during the pandemic, and I don't see any country that would expect the normal business as usual activity and supporting care homes being able to extend their capacity to cope with the pandemic. Likewise, could relate that to, well, the health system wasn't and would not be able to cope with the pandemic. They've had to rely on stopping various services to redeploy resources. So I don't see that you can really relate that to saying that care homes are heavily reliant on resources from trusts. It has been a pandemic issue rather than an ongoing issue. In terms of various shifts in the market, IHCP has been making a proposal every year to the Health and Social Care Board around the tariff model and around the need to actually review the model, looking at the reform of adult social care, and to actually do that independent economic review to look at the model of care, to look at the funding, and actually identify, is this fit for purpose going forward? And we still are requesting that there is a need to actually sit down and look at this from the roots up. and actually do that economic and business analysis. So I agree with you, there is a need to do that. I have been saying for many years that the system has been underfunded. There's been increase in pressure in terms of the complexity of care, and I would suggest that it's only because of the pandemic in the last matter of months that now there is attention being given to actually say we accept the complexity of care in care homes is now identified, and we need to work enhancing clinical care to go into those care homes to actually support that. So that needs to be taken forward as well. So I'm glad that there's been more attention given to it. But I am concerned that it has taken a pandemic to actually identify that there's the complexity of care within a care home environment. Many years ago, or only a short number of years ago, the people that are being cared for in nursing homes would have been cared for in a hospital setting.
Yeah, Pauline, just a quick follow-up. I mean, the point I'm really emphasising or trying to emphasise is, I mean, do you have an opinion, or does the organisation have an opinion on publicly run care homes along the principles of the NHS? I mean, I'm concerned that care homes are primarily, the big ones at least, responsible to shareholders first, and that's their first protocol. And we saw places like Canada where the comparison of private care homes and deaths compared to public care homes and deaths was 4 times the amount in the private sector. So I'm concerned about that model, how it exists, and do you have any opinions on extending the NHS model for our care homes in a general sense?
I think, to be honest, Jerry, it's not an issue that we're currently or have been considering or talking about as a board of directors for ICP. We would say that the model needs to be reviewed, and it does need to be considered going forward. However, if you look at, and we've done through a Freedom of Information inquiry, if you look at the cost of running a care home, and there are care homes run within the statutory sector, and you look at those costs in comparison, you will see considerable costs, higher costs running a care home within the statutory sector than you will within the private sector. So, you've got lots of other factors that need to be considered, but that independent economic review is something that I feel should take those factors into account. Let's look at care homes that are run by the statutory sector. Let's look at the model. Let's look at the funding and do an economic analysis. And that's exactly the type of information that we've been asking for.
Okay, thank you. And I'm just going to check in with Alan there. Alan, are you on the line there, or have you a question? And just if you are coming in, ensure to take yourself off mute, Alan, please.
Okay, yeah. Can you hear me, Chair?
Yeah, we're hearing you there, Alan, loud and clear. Yeah, thank you.
I did have a question. Pat asked it, so it has been answered. So thank you very much. And sorry for coming in late this morning, but struggling a bit with the new technology, Chair.
Okay, we seem to be doing fine with it at the minute, so that's good. All right, Alan. Thank you very much. Pauline, thank you on behalf of the committee for coming in this morning and for going through such a comprehensive range of issues. We are principally focused at this stage on the care homes inquiry, but we do note your comments around the home care issues as well, and it's something that the committee would also be interested in. But your contribution to our care home inquiry is appreciated, and we want to wish you and all the people who you represent well in the time ahead, and recognise that we are coming into a very difficult period, and these are unprecedented times, and it will take a massive effort once again. So appreciate that, and thank you for your contribution today. Thank you.
Thank you very much for the opportunity. Thank you.
Okay, thank you. Okay, members, I'm going to take a very short break there just before we go into our next session with Tony and Emer. Thank you. I'll pause there.
This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound.
Okay, members, thank you. And we're now resuming with the second of our morning's briefings in relation to our committee inquiry into COVID-19 and its impact on care homes. And we are receiving this morning a briefing from the RQAA. So, members, our next briefing is from RQAA, and I remind members this is an evidence session on the care homes inquiry, and I ask that members restrict their questions to the care home issues only. There will be further opportunities to raise other issues with the RQAA at a later date. I refer members to papers at tab 6 of the pack, and the clerk's memo at tab 5 of the table papers is also relevant to this session. So I'd now like to welcome this morning Dr. Tony Stevens, who is Interim Chief Executive of the RQAA, and Ms. Emer Hopkins, Interim Director of Improvement at the RQAA. You're both very welcome to the committee here this morning, and we appreciate you appearing. And could you go ahead now and brief the committee on the RQAA issues?
Okay, well, firstly, thank you very much for the invitation and this opportunity. I hope we can provide some useful information to you as part of your inquiry into care homes. I have an opening address which is very short that I'll go through and then obviously pick up questions. I'm conscious, I suppose everybody's very conscious of the significant challenges all our people face in managing through the pandemic, particularly those who've suffered loss. The team at RQA share many of these challenges and are focused on making a positive contribution to the management of this new, and as it's increasingly becoming apparent, very distressing disease. Over the last 6 months, RQI has played its role in the wider health and social care response to the pandemic. Our contribution should not be seen in isolation. We've worked closely with partners across health and social care, both in the statutory and the non-statutory sectors. In May, my colleague Dermot Parsons gave evidence to this committee describing RQI's repurposed role to provide enhanced support to health and social care services during the pandemic. And a significant part of that work was to support the care home sector. In common with the approach across the UK and Ireland, from late March to June, RQI was directed to step down its regular inspections programme, which reduced the number of on-the-ground inspections we conducted, but these did not, in fact, stop. As part of our new role, we established a service support team. This functioned 7 days a week. We provided a single point of contact for care homes, where our inspectors and other staff, specialist staff in particular, could provide advice, direction and support, sometimes just a listening ear. And we did that for both care homes and domiciliary care services. And the advice we gave was in line with departmental and public health advice. Over the pandemic period, some 200 separate pieces of guidance have been issued to care homes, focusing on PPE, staffing, testing, medicines management, palliative care, visiting and training. On behalf of the Department of Finance, we also played an important role in providing the latest details on personal protective equipment supplies and how these could be sourced. As a regulator, we place a clear focus on enabling improvement in services. During the pandemic, RQIA's inspectors provided focused professional guidance to support good quality care provision. We had a particular focus and continue to have a particular focus on infection prevention and control. And we're doing this in partnership with the trusts, who have brought a very significant infection control resource to support care homes. During the first wave of the pandemic, our inspectors handled over 3,000, in fact 3,500 contacts with care homes. Over the summer, this tailed off, I think reflecting the reduced pressure. But we've noticed the increase in calls again. We had moved to a 5-day help desk service over the summer, but we're returning to a 7-day service and putting increased resources into that support desk. We think that has been an important aspect of the service that we can provide as part of the integrated health and care service. I note there have been a number of issues you wish to address through your inquiry, and today I will focus on those that I believe fall within the remit of RQIA. In March, we were all learning about COVID-19 and its impact. Today, as we are effectively in the second wave of the pandemic, I can talk with a little more experience about how we are applying that learning. As part of our evidence, I have provided the committee with RQI's overview report on the impact of COVID-19 on care homes in Northern Ireland from February to July. In analysing our data, we've identified common characteristics of homes that have experienced an outbreak of COVID-19. This is really important because it helps us to work both with those homes, but also to identify potential homes that may be more at risk of an outbreak in the future and provide additional support to them or help to direct trust support to them. The homes that have tended to have outbreaks in the first wave, they tended to be from the larger provider groups. They tended, in fact, to be the larger homes. Not really surprising. The more people you have, the more likely you are to have an outbreak. They tended to have experienced recent leadership change, particularly at the manager level. They were more likely to serve areas of deprivation, which I think is a really important issue. We know this is a disease that is not evenly affecting our population. But they were twice as likely to be nursing homes as compared to residential homes, again an important point. And they were more likely to have been identified as having challenges in meeting care standards. So the homes that we were more likely to be in and supporting and potentially taking enforcement action on. So I think that really important learning that we can apply to the second phase. During the summer, we engaged with service providers seeking their views on the support and guidance RQI provided during the first wave. Our daily status reports, which were submitted to RQIA from care homes, done initially through an app and now through a web portal. Our risk-based approach to inspection, which I'll talk a little bit more about in a second. Feedback on those issues were generally and almost overwhelmingly positive. And we have generally felt that the support we've provided has been well received. We have access to a wealth of information about every care home in Northern Ireland. This includes our inspectors' knowledge of the service, and I think it's very important to emphasise that our inspectors work at a local level and rely on local knowledge. The daily status updates we get, statutory notifications, intelligence through notifications from other services, contact from concerned families, whistleblowers, and indeed from trust staff, of which we've had a considerable amount of contact. In planning our work, we are refining a risk-based assurance framework. And I think, again, this would be the other thing I'd really want to emphasise to you. We're moving away from a traditional on-the-ground inspection process, which is something that we're seeing in Ireland and other jurisdictions within the United Kingdom. We're now better able to direct our resources to the areas of highest risk. This may involve support and advice, or it may require specific interventions, a comprehensive on-site inspection, a short focused on-site inspection, a remote inspection involving staff and service user interviews, contact by phone or video link, manager self-assessment, submission or materials and self-declaration, and meetings with the provider or with the trusts. I think one of the important things we've learned is that actually a remote inspection, which it seems attractive because it reduces footfall, increases the administrative burden on the nursing homes. So we're trying very hard to get a balance between avoiding putting too much pressure onto nursing homes and at the same time making absolutely certain that we know what's going on and can provide the necessary support. We see providing support as much more important than enforcement at the moment. If we have to move to enforcement, then all the other actions that the trusts, the PHA and the RQA are taking has not worked. The interventions we've taken allow us to support and require change and improvement. This blended approach may represent the future of regulation in a post-COVID world. So I suppose one of the things is it was difficult for anybody to say there may be an upside to COVID, but actually, like most of the health service, we're testing new thinking and new ideas, and may well be coming back to the Department of Health and indeed to the Health Committee to describe how we might do things differently in the future when time and the virus allows us. As I've commented earlier, and as Dermot Parsons has detailed, in the first year In the first part of the year, we significantly curtailed our inspections. However, from April to September, we have undertaken 185 on-the-ground inspections. The majority of these have taken place from July onwards. We did not waste the summer. We got out and about. We've also undertaken 22 remote inspections and a small number of inspections using a combined approach. Almost half of these inspections have been in response to concerns raised, intelligence received, or issues identified during previous inspections. So our assurance framework, our risk-based approach to doing things where we target our efforts, is paying dividends. We have 20 people in our care homes team who contribute to the process of inspections of over 480 nursing and residential homes. So there is a significant pressure on that team, and we are supplementing the people that are working in that, reflecting where our pressures and priorities are. We are, however, keeping a similar focus on supported living and domiciliary care services. Since April, we have taken formal enforcement action in relation to 8 care homes where we have identified significant concerns. On behalf of the Department of Health, PHA, Health and Social Care Board and Trusts, we coordinate the collection of daily status reports from care homes, which helps inform regional responses to issues within the sector. It allows the daily dashboard to be produced. So we have a key role in pulling together all the information and intelligence that the entire system and indeed this health committee will use. We're again providing information to the Silver Command on a daily situation report. The issues about personal protective equipment, supplies and testing arrangements have largely been resolved or addressed. There are continuing issues and questions, but they're not the major issues of the day. I think staffing remains an issue. Visiting is clearly a concern for the public and the department, and we're bringing a focus on both those issues as we go forward. I'm conscious that today there are 80 care homes dealing with an outbreak of COVID-19 or flu-like illness. It feels slightly different to the last time, and possibly the questioning may look into that. We'll continue to work with the whole system and as part of the whole system to support homes and prevent, where possible, further outbreaks. Thank you, Chair.
Thank you. Thank you, Dr. Stevens. So, in relation to the repurposing of RQIA in the first surge was a very significant issue. And I wonder, based on what you've been saying there, what you have learned from that first period of time and what you did well during that period of time and what may not have worked or what indeed failed at that period of time. And are you taking a different approach to inspections in this phase of the COVID-19 surge?
I think the issues are different. For example, the focus on PPE and on supplies generally is not the same one. The issue of funding, I think with the Executive and Minister have made significant investments into the sector. So those things have changed. Testing is bringing up a different set of challenges than the first time. The first time was to get testing in place. Now testing brings up a different set of challenges, which is about, for example, the number of staff that are sidelined. So for us, yes, we've learned from what we've done, and we are changing our approach. I think the repurposing of RQI at the beginning was the right thing to do. We couldn't in conscience allow our inspectors to continue to do their ground inspections, just to, following their normal routine, ignoring the outbreak. So the two things, so we did have to put a significant resource into our support team, which took away from our inspection process. This time around, we don't have to put the same resource in, partly because we've learned a lot of lessons, and partly and the questions we're being asked are different, and partly because the trusts are putting in a huge amount of support as well, but also because our inspectors on the ground are working at a local level. So rather than centralising everything into a central support team, we've learned we know the important issues. The inspectors are now out locally working with the homes that they're familiar with, and still providing that support. be it through telephone calls, be it through the inspection process. I think what we've also learned is that doing everything remotely actually increases the burden. It doesn't necessarily fix the problem. So getting out on the ground allows us to provide practical, real support, deal with issues that are being brought to our attention, and nip things in the bud earlier, and get a real sense of what's going on. It doesn't mean we can fix all the problems. RQI doesn't have the resource to fix all the problems. So I think their initial response and repurposing was the right thing to do. We learned from it. I think rightly in discussion with the department, we aren't pulling back as far as we did the first time. We're providing an on-the-ground, more of an on-the-ground resource, but it is still focused on support. It is still focused on trying to encourage and improve, enable homes to do the right thing. We're still trying very hard to do everything we can, along with trusts, to avoid the need for enforcement. Because once you get into enforcement, that takes a huge amount of energy. It distracts us, it distracts homes. So we did learn, and we are working slightly differently. I hope that answers your question.
Thank you. The second one from me then, while we acknowledge there are very many families who are extremely happy with the care they have received in homes, we have also taken evidence from families in recent times, very distressing at times, very emotional evidence, and we're very conscious of the need to balance protection of the home with the right of people under Article 8 to enjoy that family life. And so what role does RQIA play in monitoring the implementation of the guidance? Because we have heard of kind of a postcode lottery and homes being, families experiencing difficulties in challenging managers. So what role does RQIA play in relation to ensuring access to via multidisciplinary professionals around the visiting guidance and the introduction of care partners, etc.?
Well, firstly, I will look to Emer to maybe fill in a little of the detail on this. But firstly, obviously, the department has issued visiting guidance. It is our role to ensure that that guidance is implemented effectively. But again, we're taking very much a quality-based approach to this. I think the issue about visiting is a very challenging one. I think what we're finding is a lot of relatives and families want more access. Some actually are very anxious about access. It's balancing those different views. Some homes are, for a variety of reasons, are better able to offer visiting in a safe way, the layout of the home, whether they've got an outbreak, whether they're adequately staffed at a point in time. So, I have to declare an interest. I have an elderly relative in a home, and I've been frustrated personally by the relative lack of an ability to visit. First and foremost, not wanting to cause harm, but equally conscious that we want to provide support. And I think the thing that I and I think other people have felt in RQIA is that it's not necessarily the frequency of visiting, but the quality of visiting that is absolutely important. So in the summer, we were able to have garden visits, we were able to have window visits, not practical now in any shape or form. So can homes put in a pod? Can they have a segregated area where they can do things differently? Is the home laid out for that? The increased investment that's come in from the department, from the executive to care homes, can they use that to actually put in pods? Are they making best use of IT, iPads and such like? And the other thing I think is really important is, are people looking at other initiatives that were going on? For example, working with families, using the community and voluntary sector to work with families to produce memory boxes and such like that families can take in and have a more positive interaction. So RQI, I'm going to hand over to Emer to talk about this because she has a real focus on this at the moment. But I suppose one of the things RQI is taking a real interest in now, and we're doing a piece of work, is to look at best practice in care homes. Because our inspectors can identify where there's really good practice, and see whether or not we can encourage a spread of that rather than us trying to enforce something. It's a very difficult area to do enforcement. So I'll hand it to Emma to maybe fill in a little bit.
Yeah, I suppose to say really that RQIA inspectors, in terms of their relationship with the homes and the potential for interactions with residents and with families about the quality of visiting, inspectors can take the guidance and take the policy position and work with providers to actually make that work in practice as best as possible. By view of them visiting multiple establishments, they can then identify the best practice and share that between providers. I have met, with Pauline Shepherd and with Vivian Convey of the Patient Client Council to hear about the different perspectives from care home providers and families about how the visiting guidance is being implemented in practice. And then we can actually work through practical solutions and share that. So I think that's one area in particular where RQIA can make a very positive contribution, because it's the in-practice piece that we see, and the in-practice piece in terms of the quality of that, the applying of that policy, that our RQIA has the opportunity to influence, and our inspectors make themselves experts in every piece of guidance as it is developed.
Okay. Thank you. I'm going to go to members' questions then. I'm going to go first of all to the phones. I have in order Colin, Orlea and Paula, and then I'll come back into the room. So, Colin, are you there and have you a question?
Yes, thank you very much, Stuart. Just a quick question. I was pleased to hear the Tony detailing as to there almost like a demographic of the particular homes that were impacted the last time. And I was just wondering, is that information being taken to sort of profile potential homes at the minute? And then are there special measures that are coming in the back of that? I think you had mentioned where there had been leadership change in an area of deprivation, twice as likely to be nursing the residential, and those were causing some challenges. So is there any profiling going on there to try and target your work to be able to respond and see if that can prevent any further outbreaks during this second wave?
Again, I'm going to hand over to Emma, because she's leading on this piece of work, but the short answer is yes, absolutely. That is the great value of the intelligence that we're gathering. And I think the important thing for us is because we're targeting our resources, we've used that intelligence from the first wave to focus on those homes we think are most at risk of an outbreak. And that is paying dividends, we believe. We're not doing that alone. Remember, we're doing that with the trusts who put their own infection control teams and their own managerial support in. But Emma, do you just want to add to that?
Yeah, I mean, we identified like 6 or 7 specific characteristics by diving in detail into the data that we hold in our internal databases. And these were larger homes sometimes run by larger providers, homes with 2 or more changes of managers, homes that are identified as having more than 40 registered places in particular, and sometimes older homes that had 10 years since their registration. And you imagine maybe that the infrastructure and the state of those homes can be more challenging. And then homes with previous IPC, infection prevention control areas for improvements. So in developing this sort of profile of a home that might be more likely to experience an outbreak, we were able then to target those homes for specific offers of more detailed preparedness support by our expert inspectors. So that was one thing. The second thing we did is that as we ramped up our inspection programme for on-the-ground inspections, we were able to visit those homes first and bring them to the forefront of our programme, so that in the gap between the 2 surges, they had an opportunity to have an improvement piece of work done as part of that inspection. And what we did find was that in that first big batch of inspections during June and July, that those homes were sometimes more likely to have failure to comply notices applied to them. And for us, that was a good test of our model, because it meant that the model was actually proving reliable, and it was reliably identifying risk. Other things that we have used the data for is we have shared that with trust providers and with the Department of Health, and we have presented that to the directors of the trusts so that it could inform how plans would be targeted for the second surge response for the regional surge plan. So where we do pieces of work to dive deeply into the information we hold, it's very much sharing that and making sure we're using that collaboratively across the system, not only to target RQIA's programme of work.
Maybe just, Chair, by way of comment, I think that sounds certainly a proactive, very responsive and strategic, and I think it's a vast improvement on the updates that we got earlier in the year. So I thank Tony and Emer for that. Thank you, Chair.
Okay, thank you. And going then to Paula.
Thank you very much. Thank you for your presentation today. I just wanted to make a comment before asking my question, and I just want to put it on record how disappointing it was after the last RQIA presentation to Health Committee that we then found out that the RQIA board resigned because they were unhappy with the suspension of the inspections, and I suppose it undermined in some ways the evidence that was given. So I think this morning you have been more candid and open, and I appreciate that, but I just would like you to note how it dented confidence. My question is in relation to the guidance, and it's a particular area I'm looking into, and it's the care partners. And in many ways, I do appreciate that your inspectors are gathering a lot of evidence and understanding of how the sector works. And I'm just wondering, are you working with the department now to put in a regional framework for care partners so that this can be rolled out? Because I know a lot of relatives of the residents are very keen to see it operational. Thank you.
Do you want me to pick it up? I think I'll start, but maybe look to him. I mean, I think the Care Partners is a very important initiative, but it is, I think the early intelligence we're getting is that it is a little bit of a challenge. The care homes are throwing up issues like liability insurance, use of personal protective equipment. So we're working with, I'm aware Pauline Shepherd has given evidence this morning, we're working with Pauline and others to work out the practical issues at the moment about how we advise. But the department has issued the guidance, and we're working out effectively how practically to implement that and support it. So yes, we see it as an absolutely vital part of the overall initiative. We will work to support its implementation at the moment rather than to enforce its implementation. I think we're still very much at the sensitive stage of working out how best to make it happen. But again, Emer, have you any comment?
Yeah, I mean, in reality, Paul, I think we've had a limited involvement in the development of that framework, although we're very aware of it and very keen for as much detail as possible to be provided, because that actually makes the job of the inspectors in supporting the homes to implement it much clearer. So we await the further clarity on what that framework is going to look like. But in the meantime, the principles of the care partners, of involving families, of protecting the well-being and access to the communities under Article 8 for residents is still something that we can actively work on while that framework is being developed. And RQIA is involved in regional planning groups at the department and is attending a meeting actually this afternoon where this will be one of the issues discussed. But we are very much welcome that framework being developed and further clarity on its implementation.
Thank you. Just a quick follow-up then around the common features that you said in terms of those care homes that had the outbreaks and unfortunate deaths, and then when you started to analyse that, how much is that then feeding into the Department of Health and the Health and Social Care Board in terms of going forward for future contracts and commissioning of services? Because we don't want to necessarily penalise those care homes that try to sort out the issues, but if there are perennial and perpetual issues in certain care homes, in what way are your inspectors' reports and observations feeding into future contracts? Thank you.
Do you want to pick it up?
So I guess the contracting of care from care homes is really a responsibility for the trusts in the main, though RKIA has regular liaison with the trusts, and where we have particular issues or concerns with the quality of care across any provider groups, that's information that is transparently shared with the public as well as with the trusts. So I guess my answer would be that the contracting and commissioning of the care is a matter more for the trusts and the Health and Social Care Board.
But I think equally remember, I mean, the issues of registration lie with us.
Yeah.
And, you know, when we're dealing with groups of homes, and we will consider this as part of the registration process. And I think in the post-COVID world, Paula, when you know, assuming we reach that happy state, I think the information we're gathering now and the way we're working now will inform a different approach to driving quality in care. So I think you're asking an important question for us, which is what does regulation look like in the future? What would modern 21st century regulation look like if the purpose was to truly drive up quality rather than enforce basic standards? And if we change our approach to regulation, then it would provide that intelligence network, that basis upon which trusts could do smarter commissioning, as could the department and the PHA and board. So I think you're touching on a really important issue for us.
Thank you, Chair.
Thank you. And going then to Orlia. Have you a question there, Orlia? Flynn?
Yes, and thank you to Tony and Emer. My first question was around the different approach to the inspections, where obviously you're identifying then those homes that are high risk. How many homes would fall under that high risk model at present? And then just secondly, just to mention, we done a session earlier in the week with some of the unions, and some of their feedback was that the support was really good from RKIA in the first wave, but they did have concerns that the same level of support and contact isn't necessarily there at present. And my question was around how you can reassure them that the same levels of support will be provided coming into the winter months. And I'm just conscious, obviously, in your briefing there, you had mentioned around the 5-day service was, it was reduced to a 5-day service support over the summer, but that's going to step up to the 7-day support. Is there any other sort of practical measures or proactive steps outside of that support service team that you can put in place just to reassure the staff in the homes that the support is there? Thank you.
Okay, well, I'll maybe pick the second question up first, because it's probably the easier question to deal with. We've had the feedback that you've had, that it was valued and was useful. I think reasonably and necessarily reduced it during the summer. The message is, please can we have it back? That's the message we've had from Pauline Shepherd. I have a weekly meeting with Pauline to go through her issues. So this week we've literally taken the steps, go back to 7-day working, shift resource. We're stealing resources from a number of places to try and make sure that we don't diminish our inspection team quite to the extent we did the last time. So it is a bit of a balancing act for us. We want the support desk to be there, available, providing that advice, that friendly ear. We actually feel its role is now part mentoring. It's not merely about providing advice. It is almost a mentoring role, and we're encouraging our team on the support desk to see it as a mentoring role. But we will also be reinforcing with the inspectors who are out on the ground to take that same mentoring and supportive approach. In a previous life, I was also involved in setting up the arrangements for psychological support for healthcare workers, and we made sure that it covered the independent sector as well. And in preparation for coming today, I was just checking with colleagues in trusts who have put up the support helpline for staff, and I've been reassured that that is still there and it's still available for independent sector, non-statutory staff. So again, Ulia, we're working very hard at both the practical support but also the emotional support. So that bit will be there. I can assure you that as far as we can shift resources to support that, we will. Going back to your first question about high risk, I suppose I should say that all homes are at risk. I mean, I think it's probably wrong for us to identify, give you a short list of high-risk homes. I mean, I mentioned that we've taken enforcement action on 8 homes. If you like, that, you know, there's an obvious 8 that will be at higher risk, and they're getting a lot of our attention. I think we need to see it as a gradation of risk. Some are at higher risk than high risk. And our job is to get that risk down. So I would resist the temptation to give you a list of high risk, other than to say that, I mean, the information is entirely open about which ones have enforcement action against them. I don't know, Emer, if you want to add anything to that.
Yes, I mean, I think we don't categorise it in a binary way as high risk and low risk, but it's a dynamic thing, Orla, because the enforcement action and the status of the homes is constantly changing, so that's a dynamic level of risk that's changing in the system all the time. But I am reassured to be advised by my inspection teams that in the first number of months, in that 180 or so inspections that we've done since the pandemic started, that they have now covered those that they deem the highest risk categories, and they're moving now into scheduled inspections in the low to medium risk category. But as risk changes constantly, and any home can become a higher risk at any point in time.
Thanks, sir. Thank you.
Okay, thank you, Orlia. And going then back into the room here to Alex.
Thank you for your presentation. We've heard concerns that despite guidance to the country, some homes are refusing access to social workers, OTs and podiatrists. What can you do to address that? Is my first question. My second one is, how does the RQI engage with families when conducting inspections, and how are families informed of the outcomes?
Do you want to pick this one?
So I think it's a good, I'll take the family question first, Alex, if I may. Yeah. We are absolutely fully committed to trying strengthening how families and residents indeed can input into our inspection and have their view and experience reflected in our assurance and reports. I think we recognised, and one of our points of learning, which we didn't cover in the Chair's opening question, was around the fact that our move to support and our reduced number of inspections give us a concern that the strength of that resident voice and family voice was somewhat diminished. And indeed, we took the opportunity during several interviews to call out to the public to keep making contact with RQIA and keep if they had any concerns about care. During the inspection process itself, inspectors will engage with residents and ask them questions about their lived experience of living in their home. And indeed, we'll also engage with other partners, so we'll engage regularly with the Patient Client Council to be forwarded any intelligence that they have. We see a great opportunity in this area for RQIA, so we are currently setting up a number of projects to strengthen in future the role of our lay inspectors, and we're also looking to capitalise on the intelligence gained through initiatives such as the 10,000 Voices and the care opinion initiatives that are being run through the department. Because we think there's so much that an inspector is required to gather during a single inspection. Our view would be relying on that alone is not sufficient to accurately represent the lived experience. So we are going to undertake a number of projects to fully capitalise and exploit on all of the intelligence available to us to give a reflection of what it is like for a person living in a home.
We're particularly focusing, Alex, on the visiting issue at the moment, and this bit about seeing if we can really test innovative ideas and good practice, because we're all, I mean, the visiting issue. We're never going to meet the demands of some families. I think is always going to be a challenge. So I think working with families, working with care homes and trying to address that particular issue, I mean, by spreading good practice, will be a real focus for us.
Okay. Can I just ask a quickie? When you're doing some of your inspections, we heard on the previous presentation about staffing numbers, not being able to meet staffing numbers because of COVID, and then trusts not being able to help out because they're having the same problem.
Yeah.
Nursing homes won't get penalised if that problem does arise? Or?
I think we would all, what we are looking for is that the nursing homes are managing the problems to the best of their ability and taking every possible practical step that they can take to safeguard the residents in the home. And if that requires interventions at time from RQIA to work with trusts to help make sure that resources targeted where it's needed, we will do that, but it's not always possible, so they won't be penalised if we believe they're acting responsibly and balancing those risks to the best of their ability.
Okay, thank you.
Okay, thank you, and going into Pat.
Okay, thanks. Thanks to both of you for coming in. You've readily been able to identify the care homes that would be problematic during this pandemic, and I suppose the reason you're able to do that is because they were problematic before the pandemic, and unless there are major changes, they're going to continue to be problematic after the pandemic. And you rightly point out it's usually the larger provider groups. It's the homes where there have been frequent changes in leadership or recent changes in leadership and so on. And we know that ourselves from our engagement with our QIA, with stakeholder groups and with from our own observations. And we know that the care homes that fall into those categories are the homes where there's going to be serious problems with infection control, where there's going to be negligence of residents, where there's going to be abuse of residents, and so on. And coming back to the point you made, Tony, about what's quality improvement going to look like in the time ahead, or how do we change this system where the RQIA goes in, makes enforcement notices, the provider ups its game to reach minimum standards, and then trundles along the bottom for a period of time until it falls below again. The RQIA comes back in again, issues new enforcement notices, and we go on that same cycle. And no one really expected this pandemic. We thought epidemics of this nature and viruses of this nature were confined to Asia. It wasn't going to hit us. Now we know the world is a different place, and the weak link in our care provision is in these care homes, and particularly the ones who aren't cutting the mustard. And I suppose I'm asking you to outline in the time ahead, how are we going to change that? Because if another pandemic arises, we can't allow this same thing, the same system to continue. I mean, we have had some evidence from places like Hong Kong where there have been 0 deaths in care homes. And I'm not suggesting for a second that the situation is the same. However, they have properly trained infection controllers who regularly throughout the year have infection simulations and drills so that infection control becomes second nature to everyone in the home. So even in the context of the current pandemic, there are measures that can be taken, but I'm more interested about the future and the role that the RQA has in all of that. Thanks.
Okay, well, Pat, you raise a lot of big issues there. I suppose one of the things is very difficult. It's difficult to know how well or badly we're doing. But there are some reasons for us to be reasonably optimistic about the quality of care we're providing through this pandemic. If you look at our deaths in care homes, or more particularly, if we look at excess deaths in care homes, it's an ugly expression. I know, and the public probably will feel it an inelegant expression. But if you look at excess deaths, certainly when it's difficult to compare with Ireland, but in terms of the UK jurisdictions, Northern Ireland has probably done better than anywhere else. So it does suggest that our collective approach to supporting people in care homes has been reasonably successful. So that, everything from having a health committee at a local level that's taking an interest in it, to a Department of Health with a focus on it, to the trusts and RQIA working together with the PHA to provide advice and support and significant support around infection control. So I suppose my first answer to you is I can't comment about Hong Kong. If they've managed to have no deaths from COVID in care homes, they've done something amazing, and I must go and find out about it. But the suggestion that there is something about what we're collectively doing that has probably protected our elderly people in care homes at least as well, if not better, than other places on these islands. So what is it that we're doing, and how do we capture that going forward? So I think it's a big part of your question, and I think it is about the blended approach we're taking, which is that RQI moves away from simple enforcement. It never was just about enforcement, in fairness, but the I in RQIA becomes prominent, the improvement piece, that we're working collectively with all parts of the system to drive improvement. Seeing improvement is seeing how we can support the independent sector on an ongoing basis, and how that becomes almost a contractual part of what we're doing. So I think there is something about working in a different way. But it's not just us, it will be the trusts and the way they contract, it will be the trust in terms of the services they support, it will be about primary care, and some of the fantastic initiatives that were going on before COVID, in which we're paying dividends now, like acute care at home, and about anticipatory care initiatives in the Northern Trust area. That all of those need to be scaled up. Then I think there's a big issue, and I think that I have to put this back to you collectively as our representatives, to decide how we want to fund and contract for care for the elderly, and what proportion of our spend goes on it. And that's way beyond my pay grade, so I'll park that. But I think there is that wider strategic issue, policy issue to consider. And then for us, it is about how we can work in a more collegiate way, that it isn't about setting a contract, leaving the home to get on with delivering the contract, but it is about, it's a continuum that we can, that we work collectively as a multidisciplinary team to provide support wherever the person's living. I don't know if that's answered your question, but it's my best attempt at it.
Well, it doesn't really answer the question, but it's probably a much longer discussion that's required than we have here this morning. But could I just make one final comment? I mean, I have to say, I think there's a lack of ambition when our benchmarking is done across these islands. I mean, if we're going to benchmark against what or how Boris Johnson has dealt with the pandemic, I think we're aiming very low. And I think if we're going to benchmark, we need to use international best practice. Where are the countries that have done the best? The South Koreas, the Vietnams, the Hong Kongs, Taiwans, and so on. And learn from them. They have previous experience with other epidemics such as MERS and SARS and avian flu and all the rest of it. And yes, they were prepared for what came this time. And that's the point. So let's learn from them and what they have done rather than benchmarking just across these ends. Because it's no great encouragement to anybody that we're doing better than England did. And that's a comment, I'm not asking for it.
Thank you. And go on to Jerry, and then I'll come across Alan on the phone after we have Jerry.
Just following that point from Pat, I mean, 336 excess deaths in care homes, I don't think could be described as a good result or something positive in any sense. And as Pat sort of indicated, compared to the Tories in Britain, anything will look better. And for me, I think people who were failed before COVID were the same ones failed during it, and those figures are testament to that. Just in terms of the inspections, because effectively I know there was a bit of back and forth between Colin McGrath and the previous chair in one of the last sessions about whether it was a step down inspections or how it was described, but in all intents and purposes they effectively stopped inspections for the first 40 days at least of the outbreak. And I think more inspections done in a safe way for staff obviously would have been a better approach. So really the question I want to ask is, since Tony, you've been in your position now, how many on-site inspections have been carried out? Because we've been told about phone calls in previous correspondence between RKIA, but for me certainly, and what families are asking me is how many on-site inspections have happened, certainly since you have taken your position up.
Jerry, thank you. My mind has gone blank here, but Ema will rescue me on the numbers.
I think it's over 180, and it's in the statement, the number of on-the-ground inspections, with around 22 remote inspections and a small number of blended inspections. I think we recognise, I suppose, some of what you're saying in that we are now very focused on balance, on balancing the need for support, which you've heard this morning there's a very clear need for, and the need for the public to be assured about the quality of care, and we're seeking to strike that balance. But 180 I don't think is an insignificant number of inspections to have carried out with our workforce experiencing similar challenges that has been faced across the system. We would retain the position that we didn't stop the inspections, Jerry, if you don't mind that it was reduced. But I think the number was very small, and I would accept that. And that reduction enabled us to provide such welcome and needed support and guidance to the system, and that may have contributed in some way to how well some of the homes were able to manage in that early stages of the pandemic.
Yeah, thanks for that. And just a clarification and just one final quick question. Is that 180 separate on-site inspections? And my final question, kind of Paul alluded to it, but I want to tease it out a bit more. What is the RKIA planning to do in terms of sanctions, punishment, and I suppose any other term you want to use for care homes here repeatedly breaching infection control plans? There's repeated complaints about them, because it seems to be a bit of a merry-go-round before COVID, where care homes were complained about, but they still got contracts, they still got funding, and to me it seems to be no lessons being learned if that cycle isn't going to be broken at all. So what is the RKIA plan to do from a sanctions or punishment perspective to recommend in relation to that?
I think we should avoid the word punishment. We enforce regulation. The most severe form of enforcement would be to remove registration. We are, as I've said, there are 8 homes at the moment where we are in an enforcement stage. Our focus is still on highlighting the issues to homes and getting them to fix the problem themselves. The ultimate punishment is to close a home or deregister a home. That doesn't necessarily solve any of the problems. It creates massive disruption for very frail people who won't necessarily do well if they have to move. So everything we should be geared on, along with the trust and the board and the agency, is about actually trying to avoid getting in that situation. So I think that'd be the first point I'd make on that, Jerry. That's really where we are with that. Picking up on the other point early on, and stepping down our inspections at the beginning. I mean, there was a real reason for doing that. There was a real anxiety that us putting inspectors in was more strangers. At a time when there were issues with PPE, we didn't know how the disease was transmitted. So it wasn't just about us stopping for no other reason than we were rediverting the resources. It was actually about trying to avoid potentially making the situation worse. Now, we rapidly learned, particularly with the use of personal protective equipment, that actually the risk of our staff going in was minimal. And in fact, actually, if they're wearing all the proper protective equipment, the advice, scientific advice we have now is they don't represent a risk. So hence, we're going back in with great confidence, and the homes are much more comfortable as coming in. So, we're all learning here. Don't assume every decision we made was for a negative reason. We were trying our best. That old adage, certainly old adage in medicine, if you do nothing else, do no harm. And we were trying very, very hard to follow that advice.
Okay, thank you. So I'm going across now to Alan on the phone there. Just check that you're off mute, Alan, and go ahead with your question, please.
Thank you, Chair. Can you hear me okay?
Yeah, we're hearing you clear.
Thank you. Just for the record, Chair, in relation to deaths in care homes in Hong Kong, my recollection was that, in fact, they did have a number of deaths within the care home settings, but their big success was that none of their staff members had actually contracted COVID within the care home setting. I think that was their success story in that. And in relation to all the countries that are doing well, at the moment, I think the reason why they're doing well is because they're countries that learn from previous epidemics, and they have invested heavily in their health services, and now they're reaping the rewards of that investment. But in relation to a question, I would ask Steve, do you have a sense that care homes were in a good place in preparedness for reactive infection control prior to the outbreak of this current pandemic, with particular attention to staff training and logistics?
Yeah, just for information, actually, I think the figure that we heard from the evidence session in relation to Hong Kong was that they had 30 to 40 deaths, I think, out of a population of 7.5 million. Or I think that was so it was quite significant, and I think it does bear some examination. So, yeah, go ahead then with Alan's question, please.
The preparedness. Again, I'll start, and I'll look to Emma, who would have much more expertise on this than me. I think the point I would make is there are two aspects to this. Infection control is not something that we had to put in place for the pandemic. Good infection control, both in hospitals and at all care settings, is something that we've always been doing. And we'd be well aware that you get the winter vomiting bug and flu every year. And trying to prevent the winter vomiting bug requires good infection control practice. So our QIA, along with trusts, would have been working with care homes in the past to try and make sure there was absolutely good infection control practice around a whole range of diseases, infections that could get into a care home. So to the extent that this is something that we were already dealing with, yes, there was a preparedness. Whether that was adequate or not, I think we can explore. The issue in terms of the preparedness for the pandemic, clearly Western society wasn't ready for this. The very issue that we were scrabbling around internationally looking for personal protective equipment in sufficient supplies and the right types of personal protective equipment would give an indication of this. And the other thing I think we need to bear in mind is that dusting off, which we did do every year, our flu plans, our pandemic flu plans, wasn't sufficient. And I've been around long enough, and certainly it's long enough to go. Certainly, I was chief medical director back in 2007 when we had the swine flu, and all the work that went into preparing for that, which came to nothing, and and a couple of other scares that have come to nothing. So a huge amount of work has been done over the last 10 years on preparing for pandemic flu, preparing for the seasonal flu, running flu vaccine programs, dealing with winter vomiting bug, trying to prevent winter vomiting bug, trying to keep it out of hospitals, trying to keep it out of homes. So yes, a huge amount of work has gone on. Is it enough? Probably not. Will we learn from that in the future? I very much hope so. Are we providing a vast amount of support? Yes, we are. But again, I would take you to initiatives like the award-winning initiative that's being was pre-COVID was being rolled out in Northern Ireland, called InReach or Reach, where dedicated trust teams were going into nursing homes to skill up the staff in a whole range of issues, not just infection control, but a whole range of issues. That's been scaled up. The work that's going on with acute care at home was scaling up the support that was going into not just homes, but into not into nursing homes or residential care, but into people's personal homes. So I think an awful lot was going on. But still, the scale and scope of the coronavirus pandemic, I think, has probably tested us beyond what we were expecting. I don't know, Emer, if you want to add anything to that.
I think it's difficult to answer, Alan, whether we were prepared enough. The fact that we had over 3,500 contacts with the services would suggest that we worked together to get prepared very quickly in the early stages. And I think that's the more important question for us, is did we do the best we can with what we knew at the time, and did we respond quickly? And my view would be that RKA responded very quickly and adapted how it worked, and worked with the system and worked with the providers in a very new way. And I think that was a positive thing. And this surge feels like a very different set of challenges, and it's more adaptation and change, I think, is going to be needed, and will continue to evolve and incorporate all that learning. I think that's the best answer I can give.
Thank you.
Okay, thank you. And just a couple of things then from me as well. I had mentioned earlier that we have met with families, and I think families have expressed very clearly that they feel that their voice is not heard or involved in a very central way in terms. And I just want to run through some of the things that were raised, because I think it is important that the families' voices are part of this conversation. But some of the issues that were raised was the lack of family involvement in high-level decision-making, such as the Rapid Learning Initiative. The desire to see families represented on boards, and I think the appointment of the board following what happened with the resignation of the board was a missed opportunity to a degree. I'll come back to that in a minute. They said that no one is advocating for families when care homes don't follow the guidance. There's frustration about the lack of information and communication from care homes. There's a general feeling that complaints are often not taken seriously, and a general feeling that care homes are sometimes not being held accountable, and relatives feel helpless to challenge. So my question would be, what recourse is available to families to challenge care homes in relation to the application of the guidance?
Well, the families can raise issues with us. They can make formal complaints. They can make a complaint through to the trusts. They can use their public representatives. Long experience has told me that families have a number of routes in through their representatives. So I think families can. I mean, it's whether families feel empowered to. I think it's the routes to raise and escalate issues are there. I think the issue is, do they feel empowered to, and do they actually know how to do it? I suppose that's a question not just for RQI, but the Patient and Client Council and trusts as well. I mean, we have taken... Chair, I think we have taken that on board genuinely. I mean, there's a danger I could just sit here and give you a spiel back. I hear what you're saying. We are very sensitive to the need to find creative ways of knowing how families feel. I mean, as I said at the beginning, and I didn't say it with any lack of sincerity, I am one of those families, and I have the advantage knowing how the system works, and I still find it frustrating. So we're all in the same boat here. We all have elderly relatives. So all I can say to you is, I do hear what you're saying, and we are actively, almost daily in RQI, thinking about how we're going to reach out and think creatively about that. And certainly working with Patient and Client Council provides us one of the obvious early opportunities, using lay assessors. Again, things will be easier in a post-COVID era, because we'll be able to use lay assessors and engage with families in a more meaningful way. One of the problems at the moment is it's very hard to engage with people because it's entirely dependent. I mean, I can't sit down and have a chat with people. You can't do things we used to do. So, but all I can give you is an absolute assurance that RQI has heard this. It's directly itself and is very focused on meaningful engagement and finding creative ways during the pandemic to do that. I don't know, Emer, do you want to add to that?
Yeah, thank you. The other thing then from we have heard evidence, as you mentioned there, from Pauline Shepherd earlier, and indeed, Emer, you mentioned that there's a different set of challenges. I do have a concern from the earlier session that Pauline was flagging up the issue that she feels there may be issues where the Trust, because of those different set of challenges, will not be able to provide the same support this time around. I am also, and we're all very conscious, that we have seen almost a doubling in the care home cases over a very short period of time. So that setting is once again looking very vulnerable. So my question is, and again this goes back to the in a way unresolved or not yet fully understood events that led to the unprecedented resignation of the entire board. But do you have the independence and the rigour to hold to account the department, the trusts and the HSC and PHA or whoever else are involved to ensure that they provide the support to the care home sector to ensure that we do better in terms of protecting that sector?
I suppose, again, I'd be careful about the word holding to account. I'm not sure it is our job to hold people to account. It's our job to gather information, provide that information as widely as possible, to inspect, to regulate, to support people to improve, and where necessary to enforce change and improvement where we can't get it on a voluntary and quick basis. I certainly feel no constraints on my independence as the interim chief executive of RQIA. We have a very small interim board at the moment. I don't think our chair feels any constraints on her independence either. We are feeling our way, like everybody, into how we do our job best. I hope today we've given you some evidence that we're being flexible and creative. I think one of the questions about staffing that Emer answered, which is the worry I think from Alex about whether or not we would come down hard on employers who are struggling to staff their places, their homes. No, and we've answered that by saying no. We're looking for people to make honest endeavour, and we will support them. Colin, one RQIA is functioning properly as an independent regulator. We're working very closely with the other regulators on these islands, both in Ireland and in the rest of the UK. We have a close affiliation with Scotland and Ireland because of size, and I think because of similarity of approach. So we're learning from international practice. Our job ultimately is to take the guidance and regulation that comes from the department, from our executive, and ensure that it's implemented. We're doing that as best we can in these strange circumstances, but being flexible. One of the expressions I've used internally is we've got hard power and soft power. Our hard power is the ability to regulate, and we can take people's livelihoods away from them. We can close a home, but that is not very useful at the moment. What we've got to maximise is the use of our soft power. And that soft power comes from having credibility, being trusted, having expertise that people value, and being flexible and responsive to what people need. And I hope we've demonstrated today that we're doing that.
Okay, thank you. And I suppose a final comment from me, and I was struck by your comment earlier that you're seeking to find how you can truly drive up quality. And I think we would all support that drive. I do also take you at your word in terms of you're trying to see how you can get family voices, because I think that's actually one of the key components of driving up that quality, is to get families' voices in a meaningful way. The other leg of that, I think, is, and we have heard earlier in this inquiry from trade union representatives, and I think that's the other part of cracking that nut, is to, and there has been, I think, quite a bit of engagement with the care home sector, but I think there hasn't been the same potentially level of engagement with the staff representatives via their unions, and that is another very important piece to me of that jigsaw of truly driving up quality. So I just will make that as a comment. I do want to thank you both for coming here today and for answering all questions from the committee members, and to wish you and all your staff the very best in the very challenging and difficult times which we know we are now in and we are going to have to face over the next period of time. So thank you very much, and good luck for the period ahead.
Thank you. Can I wish you well too? Thank you.
Yeah, thank you both. Okay, members, I'm going to pause there for a quick comfort break to get the next panel on the line.
This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound.
Okay, members, thank you, and we will now resume our evidence today in relation to our COVID-19 and its impact on care homes. And we're now receiving a departmental briefing. Our last briefing is from the Chief Social Worker and the Chief Nursing Officer, and I refer members to tab 7 of your pack. And I will just declare an interest myself at this point in terms of my previous career as a social worker, and also my wife actually is a nurse as well, so we're well represented today. And I'd like to now welcome by video link Mr. Sean Holland, Chief Social Worker, Professor Charlotte McYardle, the Chief Nursing Officer, and Mr. Mark Lee. And Mark is the Director for Mental Health, Disability and Older People. So I'd now like to invite you to please go ahead and brief the committee. Thank you. We're not hearing any of you at this stage. We have you on the screen, Mark. Are you doing the briefing, Mark, or the initial briefing, or is that Sean or Charlotte? Could one of you please indicate? And don't forget to keep your phone on mute when you're not speaking, but also take it off when you're ready to contribute.
You're not hearing us.
We're not hearing any of you there at the present. Charlotte, yes, I'm hearing you now, Charlotte.
Can you hear me? Colm, I was going to start with the opening remarks, but I'm not sure if my colleagues can hear.
I can hear you clearly, Charlotte. So
Okay.
we planned, Chair, is that Charlotte would start, then I would augment her comments, and then we'd go for questions.
Thank you. Thank you. Okay, Charlotte,
Okay.
go ahead. Thank you.
So we'll try and keep our introductory remarks short to allow as much time as possible for questions and discussion, Chair. Obviously, the area of care homes illustrates more than anything else the tightrope we have to walk, balancing both the quality of life with protecting life. And of course, we want to do everything that we can to look after those most vulnerable as safely as we can. And from the very beginning of the pandemic, Minister Swan has clearly articulated that supporting the care home sector is an absolute priority, both for him and for the department and for the health and social care system. So I'd like to begin by showing my appreciation to care home staff for the tremendous work that they've done and the dedication and professionalism they've shown during the pandemic. The care home staff have played an exceptional and really essential role in looking after some of the most vulnerable people in our society, and we fully recognise the resilience of the staff working in the care home sector right from the start of this pandemic and during what can only be described as an extremely challenging time. In particular, care home nursing staff have been under unprecedented pressure posed to them by the COVID pandemic, and this has been exacerbated because of shortages of staff due to sickness and caring responsibilities. So it is important to acknowledge the personal impacts that COVID has had on staff themselves. And whilst they carry out their duties in a very professional and skilled ways, for many it's been at personal cost to them in order to protect their own safety and that of their own families. Society has recognised how important nurses and care assistants are in this sector and what a difference they've made to the lives of residents right across the sector, whether it's in older people's care, looking after acute needs, chronic needs, managing pain, looking after people with dementia, learning disabilities, and indeed mental health. And I would really like to take an opportunity to remind everybody working in are truly valued, and they are valued by the public, by their colleagues, by the system, and by the people that receive care from them. And society as a whole, I think, values the contribution that the care staff have made more than ever during 2020. And for some time now, there has been recognition that the complexity of care provided in care homes has increased greatly over the last few years, but it's been really brought to the fore, I think, by the pandemic and further highlighted both the acuity of care, but also the frailty of people that reside now in our care homes. And for this reason, we've committed to bringing forward, through co-design and co-production with the sector, a framework for enhancing clinical care across all areas of the care home sector. This will seek to examine what would enhance nursing, medical and multidisciplinary support, clinical leadership and specialist skills enable the care home sector to do, but particularly doing it in partnership with the staff themselves. This will inform our ongoing response to the virus and help us to rebuild care home provision for the longer term. Our aim is to support everyone to have the care that they need in their home, whether it is their family home or a care home. And I want to acknowledge the detrimental impact that COVID has had on residents and their loved ones. Care home residents rightly take their home as their own home, where they should be able to maintain contact with their families and those who are important to them, as well as their local communities. Probably more than any other area, we're trying to find a balance between protecting life through reducing the transmission of the virus and ensuring a good quality of life has been extremely difficult. Our care home staff have worked hard to protect the residents while maintaining their quality of life, and we want to continue to do everything that we can to keep those who are most vulnerable safe. But we also know that keeping older people and the most vulnerable people away from contact with their loved ones is hugely detrimental to them, not just their physical health, but also their mental health, their emotional well-being, and indeed their human rights. All of us understand the growing number of calls to relax the visiting restrictions, but at the same time others calling for rings of steel to be put around care homes. But locking residents away from their families and those who are important to them is not something that's sustainable or indeed at all tolerable in our system. So we have to find ways to creative ways to support the sector and people to have that contact with their family and friends, and to use virtual visiting and other innovative ways to make contact. But that isn't enough, I don't think. I think it needs to be supplemented with face-to-face visiting, particularly for older people who maybe find the virtual method more difficult. And so the visiting policy does recommend that this is happening weekly and more at the end of life, and for those who find themselves requiring palliative care. Whilst recognising that the risk of transmission will be increased, of course, if there's any rise in footfall in care homes, we are also considering a risk-based approach, a sustainable approach to support residents and loved ones to have a meaningful connection, in particularly where isolation is detrimental to residents' physical or their mental health. And many families, and I just got the tail end of your previous session with RQIA, many families have said about the detrimental effect it's having on mental health and emotional well-being. Therefore, we're working with the care sector and families to introduce the concept of care partners. Care partners will have previously played a role in supporting and attending to their relatives' physical or mental health needs and providing specific support and assistance to ensure that communication or other health and social care needs are met. Care partners will help a resident avoid significant and continued distress. While recognising that the risk of transmission will be increased with the increased footfall to care homes, we are keen to implement this on a risk-based approach, a sustainable approach to support residents and loved ones to have meaningful connections, in particular where isolation is detrimental to their physical and mental health. But in conclusion, I would like to express my sincere gratitude to the independent sector staff working at all levels. Key learning from the first surge of the pandemic is the requirement to work together in partnership with the independent sector and to ensure that the independent sector are valued and seen as equal partners in the delivery of health and social care. So I'll pass on to Sean for his opening remarks.
Thank you, Charlotte, and thank you, Chair. I won't repeat the points that Charlotte's made in relation to our gratitude to care home staff, but I'd certainly like to associate myself with Charlotte's remarks. Particularly, I'd highlight care assistants, and I'm sure we'll come to this at some point in the session today. You can't help but be struck by the fact that these are often people working on minimum wage, and they have turned up throughout the pandemic to do incredible work. So I'd like to associate myself with Charlotte's remarks. The debt of gratitude will last long after this pandemic. Unlike GB, Northern Ireland has already an integrated system of health and social care, and I think that's something that has brought us benefit as we face the challenges of COVID. And I think that certainly lay behind some of the positive points that your previous witness, Tony Stevens, highlighted. There have already been close relationships between the independent sector and providers of adult social care and trusts, and these have, through the pandemic, been built on and strengthened further. From March 2020, we've taken and continue to take a wide range of measures to help protect both staff and residents in care homes, and I'll now try and touch briefly on those. Firstly, funding initiatives, and I have to apologise, I'm conscious that since we provided draft copies of our opening remarks to the committee, the Minister has announced a substantial package of additional funding to care homes, which I'll now review. Over £27 million in new funding subject to executive agreement was announced yesterday, and this builds on the previous funding packages, including the £6.5 million announced in April and the £11.7 million for enhanced sick pay, enhanced cleaning and equipment costs that was announced in June. And those are on top of the guarantee of income that was made at a very early stage to both care homes and domiciliary care providers. £9 million of this funding will be paid to care homes to reflect the costs of the rolling programme of testing for both residents and staff, the costs of overseeing safe visiting and setting up the care partnership arrangements that you've discussed already, and the increased management time needed to oversee homes throughout this period. The remaining funds will be available to homes to bid for, and that will be to address issues such as continued enhanced sick pay arrangements, supporting enhanced cleaning levels in homes, changes to the physical infrastructure to support social distancing and safe visiting arrangements, additional staffing costs for patients who are isolating or who are acutely unwell, and the block booking of bank or agency staff to help us reduce the movement of staff between homes. We intend to continue to work closely with providers to help reduce bureaucracy and ensure a streamlined approach to making claims. We're also ensuring that trusts have the resources they need to process these claims in a timely way. Now mentioned PPE and infection prevention and control. There is ongoing provision of PPE to care home providers. So far, over 42 million items of PPE have been provided to care homes at a value of over £14 million, and that is not included in the figures that I've previously referenced. Providers are not charged for access to this PPE. In addition, we've made available training, both direct and remote training through both the Clinical Education Centre and the Northern Ireland Social Care Council, focusing particularly on infection prevention and control and PPE. In addition, there are programs from the Centre for Clinical Education Centre aimed at those staff who do not regularly look after respiratory patients and or who have limited ward or community-based experience, alongside a number of clinical skills type programs to support staff dealing with respiratory patients. The CEC programs related specifically to COVID-19 are open and free of charge to all sectors in Northern Ireland, as has been the case with the training provided remotely by the Northern Ireland Social Care Council. Now let's move on to staffing support. Trusts have stepped in to provide over 26,000 hours of staff time in care homes during the first stage of this pandemic. While continued provision of support from trusts to care homes forms part of our surge plans, we do recognise that the staffing situation in trusts is more challenging than during the first wave, and we're considering what additional measures can be taken to address likely staffing pressures, and we're in ongoing discussions with sector representatives in relation to these. There has been a significant increase in supply of staff. Figures from the Northern Ireland Social Care Council demonstrate that from between September 2019 and September 2020, an additional 4,500 care workers were added to their register. And I'd need to point out that over 3,000 of those were from the 23rd of March, where the council, along with the department and others, worked to ensure that the ease of entry to the workforce was facilitated. We're now sitting at a point where we have just under 50,000 staff registered with the council. That's precise. The figure I've got literally half an hour ago is 4,997 staff are now currently on the register, and I would welcome every single one of them. However, we know that significant workforce pressures remain, and that's particularly the case when it comes to accessing nursing staff. And I would envisage that will be one of the major challenges we face going forward. Colleagues have recently relaunched our workforce appeal, and we remain clear that trusts should consider how individuals identified through this mechanism can be placed in the independent sector, subject to all the appropriate risk assessments and considerations being in place. A key part of maintaining sufficient staffing levels will involve ensuring existing staff remain healthy and available for work. I therefore want to highlight the community pharmacy flu vaccination service, which is now available to health and social care workers from nearly 400 participating community pharmacies across Northern Ireland. Essentially, all health and social care workers aged 16 years and over are eligible for free flu vaccine from participating pharmacies. The service aims to provide an alternative route for care workers to access the vaccine, benefiting from the ease of access to community pharmacies across Northern Ireland, many of which are open in the evenings and at weekends. As Charlotte has mentioned, we're also acutely aware of the impact of dealing with COVID on staff. And I reiterate again her thanks to each and every one of them. To help with this challenge, and Tony referenced this earlier, we've made HSC Trust Psychological Support Helplines, which are staffed by psychologists and psychological therapists, available to staff in the independent sector. In addition, we've also been pleased to support the initiative to create rainbow rooms in care homes, providing space where care home staff can take some space out from the pressures that they're experiencing dealing with COVID. Now I'd like to move on to testing. One of the key measures in place to help protect homes is the rolling programme of testing for care home residents and staff. The committee will be aware that staff are being tested fortnightly and residents every 28 days. This programme will continue to play a significant role in helping to minimise the risk of COVID-19 through early identification, which enables immediate steps to be taken to prevent the spread of infection, thereby ensuring the continued safety of residents and staff. Where necessary, trust teams have been stepping in to help support care homes to complete their testing of residents. A significant proportion of outbreaks were, until very recently, asymptomatic. Outbreaks also tended to be limited, with a very small number of individuals in each home testing positive. However, we are now starting to see that change as widespread community transmission begins to have an impact. In addition, the committee will be aware that it remains the case that individuals discharged from hospital to a care home should be tested for COVID-19, ideally 48 hours before discharge and subject to 14 days isolation on arrival. And discharge is an area that we continue to consider and keep under review. We want to protect care homes from any risk of infection and ensure that residents are not held in hospital, because we need to be clear that that also entails risks for them if they stay there longer than they need to be. Now I'd like to move on to preparedness for the second stage that we are entering into. As part of preparations for the second surge, we established an adult social care governance surge planning group, which is co-chaired by myself and Charlotte. Charlotte and her team, as has been mentioned, have led on a rapid learning initiative, which has since been used to refresh the regional care home surge plan. We're taking a similar approach in other areas of social care. Actions in the regional surge plan have been assigned ownership, and the group Charlotte and I chair will oversee the progress in implementing those actions, which include the 24 actions identified in the Rapid Learning Initiative. Moving on to monitoring and reporting and support. We continue to seek feedback and input from the care home sector to make sure that we understand the challenges they face. In particular, and again, this was touched on in your earlier session, valuable data continues to be collected through the RQIA facilitated care home application. We're currently using this to provide a weekly report assessing care homes, trusts and Northern Ireland as a whole against the agreed regional surge plan. While we are currently in a green surge status, it's clear that the small number of homes in red surge status, because of the number of residents who are COVID positive or who are in acute decline, is growing. In terms of advice and support, we've continued to update and refresh the guidance we've provided to trusts, care homes and care home employees. We're currently working on further revisions, which include considering how we can make the guidance more usable for those on the front line. In addition, care homes have had expert support available to them from the RQIA, from the PHA, and from trust care home support teams. We're expecting to build on that support further to provide expert support to InReach to care homes to help them ensure their cleaning, their infection prevention control, and all the other measures that will impact on COVID-19 are as effective as they can be. Furthermore, Charlotte and her team have supported the development of leadership training leading in a crisis for both care home, trust and trust staff. In the department, we continue to look at international best practice to see what more we could be doing. While a recent international comparison has shown that Northern Ireland has fared better than other UK nations in relation to deaths in care homes, any unnecessary death is a tragedy, and we're determined to do all we can to limit the impact of COVID-19 in care homes while maintaining quality of life for residents. Chair, there's a lot more I could say in terms of a prepared statement, but I think it's probably best I stop there and we are open for questions and discussion. Thank you very much, Chair.
Okay, thank you, Sean and Charlotte, both for those presentations. And I suppose in relation to your remarks, I think the value that we now as a society place on all of those frontline health and social care workers right across the piece, from nurses, doctors, domiciliary care workers, porters, everyone, I think that is one of the things to come out of this pandemic, that it would hopefully has actually moved the dial in terms of how we provide and fund health and social care, and the value that we place on each part of that. And that's certainly a conversation that I think we will return to on very many occasions, and it is a crucial one for us. However, we will stay focused on the care home inquiry element that we're at today, and I do welcome many of the measures that have been mentioned there, such as access to the training and leadership training, things like that. I think those are very practical and very helpful steps. However, in relation to the discharge policy, the current rules remain in place that there's a requirement for a test 48 hours before discharge. However, there is no necessity to have received a negative test before the discharge is gone ahead with. We have heard evidence from the RCN in our inquiry that the need to isolate can put additional severe pressures on staffing levels within the care home sector, and that indeed some homes are not well built or well equipped to manage the isolation process. It is a fact that we don't at this point in time know statistically what the impact of that discharge policy has had on the first surge of this virus, in terms of the very severe impact that we have seen in the first surge in care homes, and indeed we're seeing very worrying statistics at the present time in relation to the doubling of cases in care homes over the past short time. So what is your assessment, either of you, in terms of how well the discharge and isolate system is working at present?
If perhaps I start and then Charlotte, I'm sure we'll want to join. Yes, you're right. There is no need for a negative test result before someone is discharged to a care home. And that reflects the fact that to maintain people in an acute environment when their needs can be met in a care home is not the best thing for them. Where people who are ready for discharge in terms of their acute medical needs, it is detrimental to their physical and emotional well-being to maintain them in hospital. And so it is recognised that they can be discharged to care homes. That can result in pressure on staffing, which is one of the reasons why the funding package, previous funding package and the additional monies that have been announced can be used to augment staffing, to reflect the additional nursing and care requirements for managing those patient residents. You also mentioned that some care homes are not well built and not suitable for meeting the criteria to isolate. And in those circumstances, a care home should not take someone for admission. And that has been the case. Care homes have declined to take discharges where they do not feel they can appropriately manage their care. And that is something that we support. This is not a case where people should be forced to accept people for whom they are not appropriately equipped or prepared to care for. I'll stop at that point and see if Charlotte would like to add to that.
Thanks, Chair. Just a couple of things that I would add to that. Firstly, none of this is ideal. Nobody wants to have these arrangements in place, but we are having to make difficult decisions. And we all know that for every day an older person stays in hospital longer than is needed has a detrimental effect on their muscle mass. So even a few days a longer stay can make their rehabilitation much more complex, and indeed often they don't get back to their previous level of independence. So it is important that people do not stay in hospital any longer than they need to be there. The social care system doesn't work in isolation from the hospital system. They're an integrated system, and the ability of one to respond to the other is important to make the whole system work well. We know there are 289 patients currently in hospital in medical beds, and as you said, community transmission is high, and we know that that's going to continue to grow very rapidly with the doubling time, somewhere between 10 and 13 days at the moment. So in some ways, while there is risk associated with going back to the care home, it is something that the care home staff can manage. It is better for the patient, it's better for the resident to go back to their own home, and it also frees up space in the hospital setting for those who need acute care. So I think we have to look at this in the round and look at both sides of the coin here. And for me, the discharge policy is working well and needs to continue. accept it's not perfect, absolutely, but under the circumstances which we all face, it is the best that we can do at this moment in time.
Okay, and I think we often talk about balance, and we do understand, I think, generally that people shouldn't be in a hospital setting any longer than they need to be. However, in the context of balance, surely 24 or 48 hours to get a test back, that period of time would be something that could be worked with. And often it may be only the 24 hours, but could the testing not be prioritised so that those test results are returned quickly in light of the fact that you're aware this person may be discharged into a vulnerable setting? Is that not something that could be done as a priority? And also, in relation to the comments around isolation and homes not being under pressure, in late April, the Permanent Secretary wrote out a letter, and he put in bold that a lack of a negative test, in bold in the letter, should not be taken as a reason not to proceed with the discharge. What was the urgency of that at that time, given that there was capacity within the hospitals at that period of time? Why was that letter sent out, and did it place undue pressure on those responsible for discharging, either in implementing the discharge or in taking people? Did that put undue pressure onto those at that time?
So I think, Chair, in response to that, I think the letter at the time in April was in the middle of the first surge, and our hospitals were under increasing pressure, as were the care homes, because of the difficult circumstances in which they were working in. And I think that we go back to the point that whatever is best for the individual, because when they're going back to the care home, they are isolating anyway, regardless of the test. So I don't see the difference between April and now. I think it's doing the right thing by the person, and getting them back to their care home environment is the important point here.
Well, I will go back and check, but my memory is that on the 27th of April, which was the date of the letter, it was clear that the surge had not been, while it was bad and horrendous in many ways, it hadn't been as bad as had been anticipated and planned for, and also there was hospital capacity at that point in time. But I will check that and come back to you. You have said there, I think it was Sean who said that the discharge policy is being kept under review. So what further steps may or are required then in relation to discharge policy, given what we've learned and given we're now in a second surge?
Chair, before I address that point, if I could go back, I mean, the point about discharging patients from secondary care in April, certainly it was important that capacity for the acute healthcare sector was maintained, but that was not the reason behind an individual discharge. As Charlotte has said very clearly, you look at the best interests of a patient, and even if you have capacity, even if you have a bed in a hospital, that doesn't mean it's the right place for an individual to be if they are fit for medical discharge. And on the basis of the discharge, the advice to care homes is that regardless of any test result, anyone being admitted should be considered as potentially having tested positive. And that's why people are isolated for 14 days. In terms of the constant review, I think all aspects of how we're responding to this pandemic need to be kept under constant review. One of the things that's been said a number of times this morning and in many other occasions is that this is an emerging situation and we're learning as we go on. So if we have evidence that there is a better way of responding to discharges, it's important that we learn and adapt and change to that as we move forward. That is inevitably going to be integrated with developments that may happen in terms of the testing regime. Yesterday at the ministerial press briefing, the Chief Scientific Advisor, Professor Ian Young, referenced the fact that they would anticipate, or he anticipates, that there will be developments in testing in the coming months, new technological developments. And when those are available, we'll need to see whether that has any bearing on not only discharge policies, but a range of other policies as well. That's why we need to keep it under continuous review.
Okay, thank you. And my second question then, or area that I want to ask a question, is in relation to staffing levels. And I did hear your interview this morning, Charlotte, but in relation to restrictions on staff movement between homes, how are those operating, and to what extent do the restrictions, have those restrictions created an impact on access to staffing levels? And I'm particularly keen to know what the impact of, as you discussed this morning, Charlotte, agency staff in relation to this, and what steps are being taken to address that issue?
Thanks, Chair. So I think that it is it's very disconcerting because the video and the sound isn't in sync. So when you stop talking, you're actually still speaking on the screen. So it takes us a minute to come back. So sorry, apologies for the delay. So your question is in relation to staff moving between care homes. So clearly that's not a good idea, and we would want to try and limit the movement of staff in care homes, or moving between any facilities, whether it's care homes or between hospital and homes or any other facility. And we have written to the agencies from the Public Health Agency back in July, asking them not to encourage that behaviour. And the Minister's announcement yesterday clearly provides funding for care homes to be able to employ temporary staff on what's called a block booking basis, where the same member of staff can cover a number of shifts to prevent the number of different staff coming into the home and sharing across homes. So it's not a good idea. It's not one that we want to promote. But there will be occasions, I think, particularly as we move through the winter, where it's a choice between a member of staff providing cover in a care home or leaving the care home with no cover. And I know on a risk assessed basis which of those options, if I were the care home manager, I would be choosing. And we have to make sure that we continue to abide by the COVID secure rules around appropriate use of PPE, good hand washing, social distancing, good respiratory hygiene, additional cleaning, all of the measures that we know will protect residents from COVID as best we can. So even if staff have to move on some occasions to provide cover over the winter period, then as long as they are adhering to the best possible procedures and practice, that is the most that we can do. It is going to be extremely challenging over the winter. As you said in Surge 1, I think it was Sean that said in his remarks, in Surge 1, Trust staff were able to provide quite a lot of additional hours, but we know in the winter they too are faced with the same challenges of staff having to self-isolate for 14 days or either through the testing process or through family members or through sickness or childcare responsibilities. So all of that rolling programme of staff being unavailable for work causes an increased pressure right across the system in both the health side and the social care side. So there is a balance to be struck about supporting the care homes. That said, Sean and I constantly take the opportunity to remind the Trust Chief Executives on our regular calls that supporting the care homes is an absolute priority.
Okay, thank you. Just finally on the staffing issue, we have heard from unions that there has been a lack of engagement and a lack of a forum to share information, share best practice or share concerns even. And I have seen there has been good evidence, I think, of engagement with the care home sector and indeed some good practical measures put in place as a result of that. But given that unions have expressed that concern, what can you tell us in terms of where the current situation in relation to working with unions and staff representatives and what's being planned to address that?
Well, clearly we can do more. We can always do more in terms of engagement, but in the current context, I think there are forums for the trade union side colleagues to engage. Both they have been involved from the Rapid Learning Initiative and into the Enhanced Clinical Career Framework or Clinical Framework for Care Homes. Both RCN and Unison are involved in that. There are regular meetings between officials and Workforce Policy Directorate and the trade unions. And Sean and I are engaged on an individual level with trade unions from our professional backgrounds. So while I accept we could do more, there are definitely forums for them to be engaged in, and they will definitely be part of the programme of work going forward in relation to care partners and the Enhanced Clinical Framework.
Okay.
If I could add to that, Chair,
yep.
I think that I fully understand the view of trade unions that they would like more formal mechanisms for engagement. I understand why that would be the case. I'd also have to say I recognise the importance of engaging with unions. I think that You referenced engagement with the sector, and I mean, I know Pauline Shepherd has given evidence to you this morning and on other occasions, and we do engage with Pauline, but we also recognise that Pauline represents care home providers. That's a very valid and legitimate voice, and it's important that we listen to that voice, but it is one leg of a three-legged stool. I think that it's important that in addition to engaging with providers and hearing their voice, we do hear the representative voice of staff who work in care homes. And as you've referenced in earlier remarks, we also need to hear the voice of residents and those who care and love for them, their families. We need to hear all of those views because they're not always aligned. The views and representatives of, for example, providers will not necessarily be the same as the views of residents and their families, or indeed staff. Now, notwithstanding the point about formal forums, we have been engaging extensively with trade unions on an individual basis. I've held meetings both with Charlotte and individually, and she has done the same with the key unions. We have very close engagement with the RCN, NIPSA, and Unison, who I think are particularly significant in relation to the care home sector. I just don't think that we could approach this without that kind of engagement. Decisions as to how that might be formalised or structures through to the future are for others to make. But certainly I would not consider it being realistic or desirable to go forward without making sure that the voice of the workforce aren't heard.
Okay, thank you. I'll go now to members, and I'll start on the teleconferencing with Orlia. Orlia Flynn, please.
Yep, thank you. Thanks, Sean and Charlotte. And I know, Sean, you had mentioned, obviously, we heard from Pauline earlier on, and in Pauline's presentation, and it was referenced there within your own, or maybe within one of your answers. We've heard twice now about the pressure that the trusts are coming under in relation to the repeat testing that they're having to carry out. And I know you had mentioned that there's ongoing discussions around that. So just on that topic, I just wanted to ask how soon you think that can be resolved, because obviously, you know what I mean, the pressure's on at the minute, so the sooner that can be resolved, the better. And then just to bring it back to the inquiry, I'd be interested to know about what control or role does the department have over the care home testing programme. So, you know, is it the department that decides, you know, which homes get tested? We heard earlier on as well about some inconsistencies across the 5 different trust areas. So, and I know, Charlotte, you had mentioned that user 10 in regularly with the CEOs. I don't know if that's something, that consistency issue is something that can get fed back into that group. And just finally, just around, we've also had a couple of conversations around the Pillar 1 and Pillar 2 testing models. And I'm wondering, has any consideration been given at a departmental level around expanding the capacity for the Pillar 1 tests to include social care staff? Thanks very much.
If maybe I start on the support for testing that we're providing to care homes, and then I'm sure Charlotte will want to come in on some of the details about the testing regime. The money that was announced yesterday, it's intended that money will be available to ease the burden on care homes in terms of participating in the testing programme. We recognise that rotas have to be organised, there's a degree of management time required, and individual care workers have to be available to be tested. And that's why that package includes financial support for easing that burden. It's also part of the arrangements that we don't think that should be an element that care homes should have to be retrospectively claiming for. We are calculating what we think is a reasonable amount of care home time to be required to support the testing regime, and we will pay on that basis. So facilitating the flow of money, the flow of support to care homes without increasing an administrative burden on them. And yes, the department does have an overview in relation to testing. The Chief Medical Officer has a group that specifically considers care homes and testing and ensures that that is the policy is developed in line with emerging scientific evidence. I'm sure Charlotte will want to join in this answer.
Thanks, Sean. Orlia, to build on what Sean has already said, the CMO, as Sean has said, has a testing group, and it's my understanding that we're now on protocol number 7, so it's been amended throughout the course of the pandemic to take account of learning and the changing and rapidly changing position. It's my understanding that all care homes are part of the testing programme, and it's done on a rolling programme of staff every 2 weeks and residents every 28 days. And the difference is between Pillar 1 and Pillar 2, and Pillar 1 obviously is managed locally through the Health and Social Care Laboratories and the Northern Ireland Scientific Advisory Consortium, and the results undertaken at Pillar 1 are usually available in 24 hours, and that's specifically for homes that are in outbreak. Pillar 2 then is the national programme, and this is managed through the Department of Health in London, and that's for the surveillance programme of regular testing. Now, there have been some issues that I think Pauline has raised about the speed at which testing has been returned, and I can tell you that in the Pillar 2 programme, which is where most of the care homes are at the moment, between the 27th of September and the 10th of October, there were 22,000 results communicated within 72 hours, which works out at about 85%, with the remaining between 72 and 96 hours. So of 22,000 results, you know, that's a significant number of tests coming back within 72 hours, and I think that's a really good performance to get 85% of the tests back within 72 hours. I understand there are still concerns in relation to some, but there will be specific reasons why it's outside the 72 hours. So I'm not sure if that fully answers your question.
Yes, no, that's useful, Charlotte. I suppose it was just, I mean, obviously it's been raised at this committee that, you know, a lot of talk around having this integrated system right across our, you know, our healthcare system, and that's why I was posing the question if it could be considered, or if it is being considered or has been considered at any stage by the department to include the social care workforce within that Pillar 1 testing, because obviously the concerns are there around the delays and the 72 hours turnaround, 85%. That 85% figure is really good. That is really positive. But I suppose it still has a knock-on impact somewhere, as opposed to the 24 hours to the 72 hours. You know, it still can make a big difference for people working in that sector.
Well, I should say that this is management information, and it does change from month to month, but I understand that within the 72 hours, obviously at 85%, 50% of them are within 48 hours, if that makes sense. So actually there's a significant number back within the 48 hours, and I think we're trying to keep Pillar 1 for outbreak situation so that we can rapidly get results back there and manage the difficulties that it causes as fast as we can, and moving, you know, 22,000 more tests, for example, into Pillar 1 would really delay Pillar 1 in terms they would not be able to meet the 24-hour turnaround. So I think it is a balance, and Pillar 2 is for me, I like to think of it as a surveillance programme. It's picking up asymptomatic staff thus far much earlier than we had been before we started this regime. Yep. So we're catching it early. And as Sean has already said, that is starting to change now with the transmission being so high. But still over 70% of those are asymptomatic staff cases.
Yep, no, thank you, Charlotte. And Sean made the point earlier on as well that we did hear that some of that detail at last week's committee around that the chief scientific advisor and the department are starting to look at hopefully other testing models, you know, more rapid testing and saliva testing. So hopefully there will be more options and, you know, quicker models that are opening up down the line. Thank you. I appreciate the response.
Thank you, Orlia. And going then to Paula. Yeah.
Thank you very much for your presentation. I forgot at the start to declare an interest. I have a family member who works in a care home, and it's and it's in the context of how hard I know that the staff work. So this is no reflection of my question, and it's some of the evidence we've taken from the relatives is that whenever they do get to see their loved ones, that they can see a decline in their condition, usually like a long-term condition, maybe like dementia. And I'm just wondering, whose responsibility is it to assess the decline in these conditions so that maybe some interventions could come in? And the second part of that really is to continue that theme around the care partners. Pauline Shepherd had indicated that she had received an invitation from yourself, Charlotte, to work with them around trying to expedite the guidance regional framework for that. So I would appreciate some timelines for that, because I know a lot of relatives would be very keen to do whatever they have to do to actually get into the care homes to provide that support. Thank you.
Sean, well, I'll start with the care partners in reverse order then, if that's okay. So in relation to care partners, we had set an initial date of the 2nd of November for implementation. I am aware of quite a bit of concern from the sector about the implementation of care partners. I'm completely committed to it. I think it's the absolutely right thing to do. And if it's the right thing to do, then we just need to find ways to make it happen safely. So in that regard, Pauline is working with us, and we are engaging with families. And I've asked the PCC to bring forward arrangements to continue to engage with families. I know she's had an initial meeting with some families, and there's a meeting planned for tomorrow with the PCC with more families. And the purpose of tomorrow is to really consider how we can continuously engage with families and get more people involved from their perspective, because equally the family's perspective is as important as the care provider's perspective here. And I've had ongoing dialogue with Pauline around some of the issues that they are raising, and I think the Minister's announcement yesterday supports us to move forward, both with visiting and with care partners, because there will be additional resource there to support the care homes to deliver that safely. So we are working still towards the 2nd of November. I don't expect there'll be full implementation on the 2nd of November, and I know that some care homes have gone ahead and have already implemented care partners, and what I'm really keen to do is to find out how they've done that and what works well, and can we transport that learning to other care homes. And that will be part of the network we have set up recently with the care home sector. The first meeting was held this week, and we would propose a layered approach to this, where it will give access to individuals working at nursing care home level as care managers. And if we work together and share the learning, I'm convinced that we can do this safely and that it is actually the right thing to do, accepting that I realise there are a number of concerns and we need to work with the sector to iron those out. Go. And in relation to care, what I would say is it's the care home manager and the registered nursing staff responsibility to assess on a continuous basis the care that they are providing and any deterioration in condition, and then to call in the appropriate supports that are needed, either by way of the GP or the care manager or whatever support is needed. That's one of the reasons that we are moving to develop an enhanced clinical care framework, because we recognise that is rapidly changing in the care home sector, and the acuity of people that we're looking after there is much higher than it was, and the care home staff need the support of a full wraparound team by way of a medical cover and also enhanced clinical support from nursing and allied health professionals to support them to deliver the best care that they can. Sean, I'm sure you want to add to that.
I just add a few points to it. I mean, the experience of relatives visiting and noting a decline is very distressing, but it's also probably inevitable. I mean, when you are suffering from a condition like dementia, with the best care possible, unfortunately, it is a progressive condition. And probably if you have had limited access to your relative, when you finally do visit and get to see them, that decline becomes visibly more marked. And that's deeply upsetting for people, but there is a degree of inevitability about that. The important thing is, as Charlotte says, that the clinical team, both within the care home and supporting from trusts, work together to try and respond appropriately to whatever decline there is. In relation to care partners, I've heard some of the concerns that have been raised by Pauline and others, and I understand it and respect it. However, like Charlotte, I really do believe that this is the right thing to do, and this is not just about COVID. I think it's important to be clear about that. I think some people have mistakenly thought this was a way of getting more hands on deck to ease staffing pressures. The care partners are not intended to substitute in any way paid staff work. That's not the intention. The intention is actually to properly recognise the knowledge and expertise that a loved one has about their individual relative and make sure that that's respected and utilised. And going back again to some of the discussion you had in your earlier session about the need to make relatives feel more empowered in dealing with care homes, I would hope that the care partnership scheme, as it moves forward, will actually be a way of empowering relatives to recognise them as a valid and a vital voice in partnership with others in meeting the care needs of individuals. The final point I'd make about it is not something we've discussed particularly openly, but it is also relevant to some of your earlier discussion. Unfortunately, we do know that occasionally care is not as it should be. And the RQIA certainly play an important role in trying to address that. And you had an extensive exchange with Dr. Stevens earlier on this. But one of the most important things in making sure that a care home is as good as it can be is making sure that the care is as transparent as it can be. And I think making sure that relatives have access to care homes and have eyes on the ground to see how well their loved one is being cared for is actually a huge protective factor in that. And I think that we shouldn't underestimate that.
Okay, thank you.
Yeah, thank you very much. It was very useful.
Thank you. I'm going then to Pat, then I'm going back on the video conference into Colin and then Jerry.
Thanks, Chair. I wanted to raise the issue of international best practice, and I said it in an earlier presentation that it's disappointing when we benchmark with the other countries across the water and say we've done better than them, and I don't think it's any great recommendation to say that, nor do I think would it be any great consolation to someone who had a loved one die in a care setting here that we performed better than the performance under Boris Johnson in England, for example. So I'm just wondering, we know that other countries have performed much better. There have been far fewer deaths in care home settings and much lower rates of transmission in places like South Korea, Vietnam, Taiwan, Hong Kong, and so on. I'm just wondering what discussions have taken place between the department and health services in countries where they have previous experience of epidemics such as SARS, MERS, swine flu, and so on, to garner learning from them about best practices for here. Where am I at?
Okay, Pat. Firstly, I have to agree with you wholeheartedly. Any discussion about numbers and relative performance is of absolutely no consolation whatsoever if you've lost your loved one. And it's one of the reasons why I think we've been reluctant to talk too much about international comparisons. This is not a competition. It's not about league tables and saying we're above someone else or below someone else. If you've lost your loved one to COVID in a care home, that doesn't matter a jot to you. But it is important that we have some awareness of where we sit internationally. And I take your point about comparison with other countries, and you've referenced England a number of times. I think it's important to note that there is an international long-term care policy network. It's hosted by the London School of Economics, and they look at the situation in care homes around the world, and they've been collating information. And I actually shared with the chair of the committee a copy of a recent report where they were looking at different performance. That report would indicate that in terms of excess deaths, which is probably the most comparable measure you can find, Northern Ireland actually performed significantly differently, not just to England, but also to Scotland and Wales. And that is an organisation that looks at international comparisons, not just comparisons between the UK countries. And it noted Northern Ireland as being in a different position in terms of their excess deaths to the other 3 UK countries, taking into account overall international performance. To say it's no consolation whatsoever to individuals, but the performance, when we say it performed better than other countries in terms of excess deaths, the International Long-Term Care Policy Network would not include Northern Ireland in the same category up to this date. And that takes us to sort of what makes the difference in other countries. Certainly, we've been using that policy network to try and benchmark measures that other countries have taken to see whether or not anyone is doing something that we're not doing. And we've been adjusting our position accordingly where we see something that is where we feel there's merit to it. Actually, we are updating the benchmarking process against their reports currently. We hope to have a report on that available in the coming days. In relation to those countries that have performed well, it is not always easy to compare different countries. There are measures that some countries have taken that would not be acceptable here. So, for example, I'm aware of a country which has in effect locked down their care homes. In terms of putting staff into hotels where they have to live, and they're not allowed access to their own families over an extended period of time. And I'll be honest, there was a point in time when we looked at that. We explored the possibility of doing that. And after an awful lot of soul-searching and consideration and consultation with trade unions and providers, we realised that that kind of complete lockdown wasn't available to us. There's no doubt that such a lockdown does make the likelihood of care home deaths less, but it has to be something that you can do in the context of your society, and that just is not possible for us to completely lock down a care home. And that takes us to probably the most significant feature in relation to deaths in care homes. Some of those countries that you've mentioned that have managed very low deaths in care homes have also managed much lower levels of community transmission, and the reality is that the two are linked. If you have really significant community transmission, you will have an increased level of deaths in care homes. If you are in a position where you have been able to perform better in terms of community transmission, be it for reasons of geographical location like New Zealand, or because you've had the experience and you were quicker off the mark like those countries in the Far East who had experience of MERS and SARS, that will feed through. And it's also one of the reasons why we've been reluctant to make too much of the fact that Northern Ireland in the first phase performed particularly well, because while undoubtedly I think that some of that performance was down to the outstanding work that health and social care staff did, I think some of it was down to the fact that we have an integrated system. Probably the biggest factor was the level of community transmission, and we're not guaranteed that that benefit will continue as we go forward. If we see very high levels of community transmission as we go forward, that position is by no means guaranteed.
Could I just come back? I accept a lot of what you're saying, Sean. What I don't accept is that some countries have introduced measures that just wouldn't be acceptable here. Many people at the outset of this pandemic told us that a lockdown similar to what had been happening in China wouldn't be acceptable here. But when the conditions demanded it, it was accepted. And I accept the point you're making that rates of community transmission are completely intertwined with rates of transmission in care settings as well. And that's why we need to be looking at international best practice. And I suppose the question I was asking was, has there been any direct discussions with any of those countries where there are low rates of transmission, both in care settings and in society in general? I'm asking about the department. Has it had any direct contact with any of those health services?
I have not had direct linkage with those countries. What I've done is rely on the international network, which gathers evidence from the different countries and identifies the different steps they're taking, and then we've benchmarked against those. In relation to the point, Pat, about sort of measures that other countries could introduce that we couldn't introduce. I think you're right. There are measures that other countries introduce that we can introduce and need to learn from, and we've been doing that. But there are instances where we have looked at things and we cannot introduce them. We previously, I think, have shared information with the committee about an initiative where we were looking in the first phase. We called it Safe at Home, and the idea was to try and pilot a complete lockdown of care homes. We were very enthusiastic about testing that. We secured financial resource to test it, but when we engaged with staff and providers, we found that we couldn't progress it, and for very understandable reasons. So I think it's not a straightforward picture, Pat, that there are measures that we need to look to other countries from and learn from, and we've been doing that. But there are some things. I mean, I don't think that we can put sort of guards around care homes, which some countries have done.
Okay, thank you. And I suppose just a comment in relation to that, and you yourself, Sean, have indicated earlier that the health and social care and the community transmission are all interlinked, and I'm conscious that we are focusing here on the care homes, but I suppose it does need to be acknowledged that the impact of not having in the first place a proper testing and tracing system in place, the impact of stopping the tracing in relation to the figures as they were in England at the time, and the impact in recent times of the contact tracing system becoming overwhelmed as a result of an underestimation of demand, all have an impact into the care home sector as well as in the community. So that's of relevance as well. So going then to Colin and then Jerry. So Colin first.
Thank you very much, Chair, and thank you to the panel for their presentation. Just two very quick questions. One, in our presentation this morning, there was reference made to an inconsistency in the guidelines for the use of PPE within care homes across the various trusts. And I was just wondering, is that something that maybe would be better to examine and ensure that there's a consistency of approach right across all the care homes in the north? And then just a second point, just following up in terms of the visiting and trying to do everything that we can to ensure that visiting can take place, not least for the fact of that human right for residents in care homes to a family life. I understand that there wasn't a great uptake in the original amount of funding for care homes to try and deliver additional capital projects that would be required for care homes, and is there any way of trying to encourage people, if there is new funding, to pick up on that funding and to deliver it, so that we can try and encourage as much visiting in homes as possible in a safe manner?
And if I could just ask the panel to be, as we are coming quite close to our time, so if panellists and members could just be as succinct as possible, please.
Okay, very quickly, all care homes and all trusts operate under the same regional guidance in relation to PPE. If there are inconsistencies that people are aware of how that's being applied, both Charlotte and myself will be very happy to hear about those inconsistencies, and we will troubleshoot to make sure that the guidelines are being applied appropriately. I have to say, sometimes I've heard commentators make statements in public forums about certain issues, and we've proactively contacted them and said, please give us the information so we can follow up. And sometimes it's turned out that what they've described hasn't actually been the situation we found when we've explored that. But there should be consistency in the application of guidelines, and certainly any provider or representative or family member or member of staff who experiences a lack of that consistency will respond to that. In relation to the uptake on funding, I'm actually going to ask Mark to come in, if that's okay, because Mark is the person who's been doing an awful lot of work in terms of the funding support, both the original 6.5 million, then the 11.7 million, and the announcement yesterday. And so he's been looking at the deployment of those funds. So I'll hand over to Mark, and then I'm sure Charlotte will want to come in again on the visiting point.
Thank you.
Yeah, so just to say very quickly, I think we were ambitious in the amounts we made available, so that's an important piece of context. Actually, the uptake around the money that was available for equipment, including iPads and things to support visiting, was probably stronger than on the couple of other legs that we were providing funding for. But we have also listened to some of the feedback. I think you heard from Pauline earlier about the need for physical changes in the building as well, and we're looking to support that as we go again and make more money available. So we're ambitious in the first place, that there was kind of reasonable take up, but we're listening and learning from the feedback and thinking about the eligibility criteria to look to do more.
Thank you, Mark. And
so
Charlotte?
just to finish Colin's point on the visiting, so we did get feedback that uptake was poor in relation to funds that were available, and that was, I think, people felt that they didn't need virtual visiting equipment, iPads, etc., that they had that there, and in some cases it wasn't always a popular choice, particularly for older people. But I would encourage care homes to be as creative as they can in relation to the visiting policy, and now that we have a network call-in across the independent sector and a much closer working relationship through the Enhanced Clinical Care Group, that will be the forum for which I will continue to support care homes to utilise the visiting money, and a percentage of that is going directly to care homes, as Sean has said, so it's there for them to use, and the rest of it can be drawn down on evidence that they're using it effectively to support visiting.
Okay.
Another issue will be about enhanced cleaning and providing like a visitor champion in homes that will work with the families and the residents to make sure that that is all carried out safely.
Thank you. Thank you, Colin. And Jerry.
Thanks, Chair. Thanks, panel. 2 quick points. Maybe Sean should answer this one. Do you have any concern about care home providers who have had complaints about them in the past, complaints during COVID, still being in charge of the care of a lot of our elderly population, and potentially getting support through PPE and other financial measures? My other point is obviously previously, Sean, you were indicating sort of support or positive indications maybe towards publicly run care homes under an NHS type model. Given the situation with Four Seasons, a few weeks ago said they want to sell 42 of their care homes. Have you made any recommendations or views towards the Minister about the department or trusts maybe taking a role in the provision of those care homes?
Okay, Jerry. First on the financial support to care homes. It's not quite the question you asked, but I'm going to make a point and then address the specific one. I think that certainly if a care home is not particularly well run, it is going to be a greater risk of an outbreak. However, it's also really important to emphasise that some excellently run care homes, really, really outstanding facilities that would be examples of best practice, have had outbreaks and they've had deaths. So it's wrong to assume that if a care home has had an outbreak, they're a bad care home. That is not the truth. It's not borne out by any analysis or facts.
With respect, Sean, that wasn't
absolutely.
With respect, sorry, Sean, that wasn't my question. I said there's been examples of complaints in care homes prior and during COVID, and there's been concerns raised and investigations into some of those as well. So I'd appreciate if you had responded.
No, I accept that, Jerry. I think I was trying to make a point that probably relates to the earlier panel here, and please forgive me for that. In relation to where there have been concerns raised about care homes and now they're accessing financial support, do we have any concerns? It's one of the reasons why you have this tension between wanting to get financial support to care homes quickly so that it can be deployed, but at the same time making sure that there's good governance and probity. People often talk about bureaucracy always in negative terms. The reality is that some bureaucracy is necessary to try and make sure that where a care home provider isn't behaving appropriately, that we can make sure that the support is being used as it should be. In relation to the balance of provision between public and private provision, I have to be careful. This ultimately is a political decision, and I'm a civil servant, I'm not a politician, but I don't think that when the policy was set, which is now many, many years ago, where we talked about a mixed economy of care, it was envisaged that the mix would be 99% private and only 1% within the statutory sector as that relates to nursing homes. It's slightly different, but not much different in relation to residential units. I think that there is a recognition that a mixed economy of care probably requires a greater footprint from statutory providers in this sector. And I make that as a general point because I talk to colleagues in England, Scotland and Wales, and they are all reflecting that point as well. And it's starting to be reflected in practice. Certainly trusts here are expressing an interest in taking on some more direct provision in this sector. And I know local authorities, certainly in Scotland and Wales, are increasingly looking at their own direct provision and considering whether or not they've got the balance right. I think that what this has highlighted for us is that trusts or local authorities, whoever's providing the service, probably need to have greater experience of directly running care homes if they're going to be able to properly support the independent sector under this kind of stress. That would be my professional view, but we need policy decisions on that. In relation to Four Seasons, I think first thing I'd say is we would anticipate that change of ownership of Four Seasons should be achieved without any disruption to the continuity of care to those people who are living in those homes. And the standards that will be expected of care are the same regardless of who the provider is. But there is an issue, I think, about Four Seasons. I don't mean Four Seasons specifically, but the model whereby some large care home provider groups became incredibly complex financial arrangements with offshore shell companies, and it could become really difficult to work out who actually owned a care home. And I'm not sure that that's the best model going forward, but I'm probably overstepping the mark where I should go with that, Jerry.
Okay, thank you. So we're really tight for time now. I'm going to check with Pam, Cameron, who has rejoined the meeting, and then we're going to check in with Alan to see if he's good. But really two very quick questions, please, now, members. So we'll go back. I'll go to Pam there. Yeah, go ahead, Pam.
Can you hear me?
Hearing you, Pam. Yeah, go ahead.
Okay, good stuff. Apologies that I missed all your presentations from both Charlotte and Sean. I was away having a nasty test. I wanted to ask around, and apologies if it's already been asked, if anyone would be able to clarify what the use of the Nightingale 2 at White Abbey will be. So will it be available as a step-down facility for discharge before a test result or on a positive? And would there be a provision for those residents leaving care homes, maybe they have to attend A&E for falls, for example?
Pam, the Nightingale 2 will be available for step-down accommodation for all patients and residents coming out of secondary care for enhanced rehabilitation with a maximum length of stay of 14 days. The clinical pathways are still being worked up and developed, but we would anticipate that the same discharge arrangements would be in place, and this is one of the issues we did actually address earlier. The current discharge protocol is that patients will be tested 48 hours prior to discharge, and that where possible they should have that result in place, but where it's not in place, it shouldn't impede the discharge, and where they are transferred to another area of care, isolation will be maintained for 14 days, and those arrangements will be continued in the White Abbey Nightingale, and that's being planned for in the capital works that's being done at the moment and in the clinical pathways that's being developed.
Okay, so does that include visits to A&E where you're not actually admitted?
So visits to A&E means you should go back to the care home, directly back to the care home.
Okay, that would be where my concern was. I mean, certainly I had a constituent contact me about a parent who had taken a fall and had to go to A&E, and while they were in A&E, they had a test, and they got a positive result when she was back in the home. So that was my concern.
I'm happy to follow those up outside of the meeting, and certainly because we have the independent network now available, some of those issues we can deal with directly through the network.
Okay, thank you. And just to concur with Pam, I'm aware of cases where people have been discharged back in, then got a positive, then were informed of a positive test, and I am aware of at least one case where there's now an outbreak in the unit where that person was. So this is an issue, I think. I'll go then just to check with Alan. Alan, do you have a question there? short question, please, Alan, if you have. You're on mute, Alan. Just take yourself off mute, please.
Thank you, Chair. No, I have no question, but just show my appreciation for a very informative presentation from the team. Thank you.
Thank you, Alan. And thank you, and I would also concur with Alan in that respect. It has been, I'd like to thank you on behalf of the committee, Charlotte, Mark and Sean, for attending this morning, for giving us your briefings and for hearing the issues and your responses to some of them. And we will obviously be continuing with factoring in all of these responses and the different perspectives on all of this in relation to our care home inquiry. But thank you very much. We want to send our best wishes to everyone who you represent, who is out there on the front line in what is, once again, a very, very worrying period of time. And we want to wish you all the best in the time ahead. Thank you.
Chair, thank you very much for that. And can we also wish all MLAs who might find themselves in the situation of self-isolating and waiting on test results, like everyone else, the very, very best. It's a difficult time for everyone, and MLAs aren't exempt from that.
Okay, thank you. Thank you. Okay, members. Just by way of a wrap-up in all of that, is there anything that members want to say by way of comment or by way of any further actions? Jerry?
Yeah, and it's hard to kind of tease it out, Chair, just because in the time, but appreciate Sean's comments towards the end about the sort of offshore companies and shareholders running some of these care homes, and to me that just emphasises the point for me exactly, that there needs to be a fundamental work, and he says it's political, it is, around requiring these homes for public ownership to extend them as part of the NHS. So that was quite interesting, but I think a lot of the stuff was interesting and quite useful presentations from Sean and Charlotte and everybody today.
Yeah. Members, any other quick points given the... Paula, are you looking in there?
No, I just thought the way it flowed this morning was excellent, and the quality of the submissions was very good, and I think we've got, like the last few sessions, it's just going to really contribute to this inquiry. I mean, I'm just really appreciative of the clerk and the staff at the committee there for pulling it together. I think it worked very well.
Yeah, I agree with that. And Pam, are you looking in on that? Yeah. Okay, I don't think... Yeah, go ahead, Pam.
No, I'm fine. Obviously, I missed most of that.
Okay.
The last presentation, but I'll hopefully be able to listen back at some stage.
Okay. No, I thought they were all very good sessions. I think there's a lot of information there to digest, and I think that's the key part of it now, is to look at how those pieces all interact with each other and how we feed that into potential recommendations. One of the areas for me, actually, I was a wee bit still unsure about this issue about around the end of April in terms of where we were, and could we have been more flexible around discharge in relation to the letter that was written by the Permanent Secretary. And Charlotte had said that we were in the middle, still in the height of that surge. My memory was that it was actually starting to come out the other side of it. But I think it would be useful if we got a kind of a rationale, maybe from the Permanent Secretary, as to what the situation was at that time and what was informing his decision. Would members be happy enough if we seek that further information? Yeah. Okay. Thank you, members. I will move on then to our next session of our meeting today. The next three items are statutory instruments in respect of which the Minister has indicated his wish for the North to be included. These are statutory instruments that are being brought in Westminster. And the Minister has indicated his wish for us to be included within those. Before we go into discussing them in detail, is there anything in general that the members want to factor in at this stage in relation to the SAs before we go through them individually? No, I think we had asked for a rationale, and that rationale has been, in each of these, has been provided to some extent. I suppose it would be, to me, I'd be keen, I'm not sure how we actually do this, but that the Minister is proofing all of these, that there's no unforeseen consequences as a result of some of these down the line. But in relation to the sense of some of them, they do seem to make sort of a logical sense to some degree. But I'll go through them now just quickly then. So number 8 is the reciprocal and cross-border healthcare amendment, etc., EU Exit Regulations 2020, and I refer members to pages at tab 8 of the pack. The Department of Health advises that this is a technical statutory instrument which will remove redundant no-deal provisions designed to apply if no transition period had been agreed. So are members content to note that SA?
Right.
Yeah, content, thank you. Item number 9 is the Tobacco Products and Nicotine Inhaling Products Amendment EU Exit Regulations 2020, and I refer members to pages at tab 9 of your pack. The Department of Health advises this is a technical SA to ensure that the North continues to comply with the EU Tobacco Products Directive in compliance with the Ireland NI Protocol. One thing that did sort of concern me in relation to that was there's a line at the very end of that on page 178 of the briefing or of the pack. Since Britain will no longer be required to comply with the TPD, it is possible there will be some deregulation, particularly of e-cigarettes, following such a review. However, it's likely the overall approach towards tobacco and vaping products will remain highly regulated given the public health implications. I thought it might be useful to get some more information in relation to does that indicate there may be deregulation here and how that would be, or does that apply to Britain? Clerk, do you have
just initially, obviously we are bound by the Northern Ireland Protocol, and that's what this is doing, is to make sure that Northern Ireland continues to adhere. So deregulation possibilities are restricted here by the protocol. Okay. And we'll hear more. The members may recall we've scheduled an overarching briefing on Brexit developments on the 19th of November, and so we can follow up around some of that at that point. Okay, thank you. Yeah, so then in that case, the Department of Health advises it's a technical SA. So in that case, and given that we can use the opportunity on the 19th of November to make further inquiries, but for now, are members content to note the SA? Yeah, members content. Number 10 then is Electronic Commerce Directive, Adoption and Children Amendment, etc., EU Exit Regulations 2020. I refer members to pages of tab 10 of your pack. The Department of Health advises that this SA is technical also. It's designed to remove EU-wide arrangements so that companies based in Britain that breach advertising rules in an EEA country in relation to adoption will no longer be treated as if they committed the offences in Britain. Persons who are not registered adoption agencies will continue to be prohibited from advertising in relation to adoption. Are members content to note that SA? Content. Yeah, thank you, members. Okay, turning then to correspondence, can I refer members to correspondence at tab 11 of the pack and to the correspondence memo at tab 11.1. And I'd like to draw members' attention to a few items here. So first of all, item 11.2 is from the Minister regarding engagement and consultation on rebuilding services. Any issues members want to raise in relation to that? And are members therefore content to note pending further engagement with the Minister in relation to rebuilding, which we have indicated previously we would like to do? Yeah, thank you. Item 11.1 is from an individual regarding Assembly control in relation to legislation on coronavirus restrictions. So it relates to quite technical matters, that piece of correspondence, members. Would you be content that we forward it to the Examiner of Statutory Rules for her consideration? Members content with that approach? Thank you. Okay. Item 11.14 is from the Association of Anaesthetists regarding future design service. Any comment from members in relation to that? Or would members be content to note pending, as I previously mentioned, there are ongoing and further consideration of rebuilding services? Okay, thank you, members. So are members otherwise content to note with the actions as outlined in the correspondence list at tab 11.1 for the main pack? Are members content to note those? Yep. Moving on to table papers, there are 3 other items of additional correspondence in the table pack. Item 11.15 is from the Minister regarding a forthcoming legislative consent motion on the Medicines and Medical Devices Bill. Have members any comments in relation to that? No. So are members therefore content to notify the Committee for Agriculture, Environment and Rural Affairs of the forthcoming LCM? Yeah, members content, thank you. Item 11.16 is a letter from the Minister providing a link to the recently published report on exercise sickness. Do members have any comments in relation to that?
and members content to note, and I know I certainly look forward to looking into that in some more detail, so members are content to note that for now. Thank you. Item 11.17 is from the Minister in relation to gender identity services. So, have members any comments? And I do note that Jerry Carroll is planning an informal session with the committee with the people impacted by this. So, Jerry, have you any comments?
Yeah, Chair, just a reminder, that's going to be on Tuesday at 1 o'clock, and I'll send an email invitation out this afternoon, and obviously consider the detail of the letter.
Okay, and thank you, Jerry, for coordinating that meeting with that sector on behalf of the committee. Moving on then, members, to the Forward Work Programme, item 12. So I refer members to the draft Forward Work Programme at tab 12.1 of your pack. Are members content to note the Forward Work Programme? Yeah, members content, thank you. Any other business then, members? Do members of any other business today? Jerry?
Sure,
and bear in mind,
thanks.
Jerry, we need out for 1:30.
I'll try, but it may not be in my control. But I think obviously the comments last week from the DAERA Minister, I think were very offensive and dangerous for all sorts of reasons, especially pertaining to the virus, which could and effectively try to blame one section of the community for it. So I want to suggest that we write to him saying we as a committee disassociate ourselves from the comments and call for him to reconsider his position in light of what he said last week.
Members' views on that?
Chair,
Alex?
the Minister explained yesterday, and he didn't. Everything was taken out of context, and I just think Jerry's just stern, to be honest with you, and I wouldn't be accepting any letters from my point of view. Thank you.
Okay, Paula.
Thank you. I certainly agree with them that they were very, very unhelpful this week, and I suppose it's been played out in the media a lot. I think my concern is that we have tried at this Health Committee to be very collegiate and work together to fight this pandemic, and I suppose it really undermines the Assembly and this Health Committee whenever the sectarianism and stuff like that starts feeding in. So very much concur with what Jerry's saying, but I think that we have to really stay very focused on our body of work here and allow some of those comments to be reserved for the actual Assembly chamber.
Thank you. Any other comments in relation to that? I also think the comments were unhelpful. I have to say they were inaccurate, and I don't think they were certainly extremely hurtful, and I think they were very, very ill judged in that sense. But I do think that in terms of a committee position, I think we've noted them here today, and if members are content, we should leave it at that. Members content?
I would like to propose a Chair, but I appreciate if nobody seconds it that I may not be able to carry through. But just to say, Chair, we spent a lot of time talking about previous ministers at funerals and their approach, and I think this is definitely the consideration of the Health Committee, considering it was an attempt to appropriate blame on one section of the community for a virus that is spreading everywhere. So I do think it's relevant to what we're discussing today.
Well, I understand. I'll bring you in a minute. I do understand your point. My approach to all of that has been at every stage that we are the Committee for Health, and that's who we should be scrutinising. And you know, I do think it's important that we retain a sort of a focus in terms of where we are at the minute with COVID-19. Colin.
Yeah, sure. I'm just saying, I mean, if Jerry was happy, I would be happy to second the proposal if we can maybe focus it more on just that the Minister needs to be very careful of the remarks he makes and needs to think how they may or may not be taken out of context if that's his explanation, but that the comments were unhelpful, that they have gone down very badly with the community, and they had the potential to undermine the public health message, not least by suggesting that maybe in unionist areas people were safer and therefore may have been a bit more relaxed about the rules and the guidelines, because the suggestion and inference from the remarks that he made was that it was only in nationalist areas at a 6-to-1 ratio where people were getting the virus. So I think maybe a letter just to remind the good work that we're doing, and that how he needs to be very careful with his comments should they be taken out of context. But I would be happy to second that.
Jerry, would you be happy if that's the framework?
That seems to be where it's going. Obviously, it seems to be my proposal isn't supported in that sense. But in light of that, I'm happy to kind of take Colin's amended version, if you will.
Okay, so are members content that the clerk will draft a letter and that we will send a letter to the Minister along those lines that Colin has outlined there?
Yes, thank you.
Yeah.
Chair.
Pam?
Yeah, thank you. I see Alan indicating trying to get into. I think you just haven't seen him, Chair. Obviously, I wouldn't be supportive of either of those proposals, and I think it's wrong not to be referring to the statement of clarification that Evelyn Fitzpatrick made very recently. And I think that the matter has been put to bed and it should be left there, quite frankly.
Okay, and Alan?
Yeah, Chair, certainly. Can you hear me?
Yes, we can hear you.
Thank you. Certainly my party is on record as making comments that the Minister's comments were unhelpful at best, and that would continue to be our position. I think it has been well exercised in the Assembly chamber, and no doubt maybe going forward it will be mentioned again. I think that is the place where it should be dealt with. I don't think we should be getting down to committees of the Assembly getting involved in an issue like this. And certainly, if there is a consensus that a letter is prepared, I would certainly like to have access to that letter before clearance would be given for it to be sent to anyone. Thank you.
Okay, but I will note that we have obviously issued letters in relation to matters that have been extensively, other matters that have been discussed in the Assembly. However, we are out of time in terms of this room, so we will need to reconvene this meeting back in room 21 to make a decision, and I think we're going to need to go to a division on it, given the views that members are expressing.
Could we not go for?
Yes, well, let's do that now. So I'm going to put it to a vote then. So in relation to,
I just need to clarity on exactly what the motion is to record for the vote.
I thought you were taking notes in relation to Jerry Collins' wording.
I wouldn't be able to summarise it all as quickly as that to be
okay.
accurate, unless Colin wishes to re-summarise.
Colin, can you re-summarise that just quickly for us there, please? The wording that you had come up with there.
Writing to the Minister to say that his remarks may have compromised the public health messaging and that he needs to take great care in his remarks in case they should be misinterpreted.
Okay, members content that that's the proposal. So I'm going to put that now to a vote. Members in support of that proposal. So Colin, Jerry, Colin McGrath, Paula. That's 4. Yeah. And members opposed to that proposal? Alex, Alan and Pam. Okay, the proposal is carried. Thank you, members. Okay, members, moving on then to date, time and place of next meeting. Our next meeting will be held on Thursday, the 5th of November 2020 at 9:30 a.m. here in the Senate Chamber. Thank you, members.
Senate Chamber, programme sound. This is the Northern Ireland Assembly Senate Chamber, programme sound. This is the Northern Ireland Assembly Senate Chamber, programme sound. This is the Northern Ireland Assembly Senate Chamber, programme sound. This is the Northern Ireland Assembly Senate Chamber, programme sound. This is the Northern Ireland Assembly Senate Chamber, programme sound. This is the Northern Ireland Assembly Senate Chamber, programme sound. This is the Northern Ireland Assembly Senate Chamber, programme sound. This is the Northern Ireland Assembly Senate Chamber, programme sound. This is the Northern Ireland Assembly Senate Chamber, programme sound. This is the Northern Ireland Assembly Senate Chamber, programme sound. This is the Northern Ireland Assembly Senate Chamber, programme sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed. This is the Northern Ireland Assembly Senate Chamber programme signed.
Okay, members, you're all welcome to a meeting of the Justice Committee, and you're welcome to use your electronic devices if you can do the needful so that it doesn't interfere. That would be appreciated. And if you're content, we will record the oral evidence sessions today by Hansard. And at this stage, if there's any declarations of interest, financial or otherwise, now's the time to declare it relating to any business of today. If not, then we will move on. I don't think we have any apologies. We've got Gemma, Emma and Sinead all joining us on the Starleaf facility, and everybody else is here. So is there any delegation of votes, Christine?
Yes, Gemma Dolan and Emma Rogan have delegated their votes to the Deputy Chairperson, Linda Dillon, in the event that the Starleaf connection is lost.
Okay, thank you. Draft minutes then of the meeting that were held on the 15th of October. If members are content that they're a true reflection of proceedings, then I'll sign them accordingly.
Agreed.
A couple of items and under matters arising. There was additional written evidence received from the Dulce Vitae project. Forgive me if I haven't pronounced that right. But there's just some information in respect to parental alienation around the Domestic Abuse and Family Proceedings Bill, and that information was received after the committee report on the bill had been agreed, and members are asked to note that information. Again, just to advise members that the organisation will be advised that the information has been provided to members. However, it's not included in the committee report on the bill as it was agreed before the information was received. The report does, however, cover the issue that has been raised, and the department has indicated that parental alienation could fall within the domestic abuse offence, depending on the individual circumstances of the case. Another item then, page 3 to 11 of your table pack, the Minister's advised that she's taken the decision to recommence the COVID-19 Public Health Emergency Temporary Release Scheme for prisoners under the provisions of Rule 27 of the Prison and Young Offenders Centre rules. The scheme had been paused in August. It provides for the early release of certain prisoners in the last 3 months of their sentence, and having consulted with the Director General of the Prison Service, the Minister has concluded that recommencing the scheme is a proportionate measure at this time. The scheme will be subject to further review at the end of November. The Minister has also agreed to put in place a revised overtime payment scheme for prison staff during November and December, similarly to the scheme that ran from March to August of 2020, and this will be reviewed at the end of December, taking account of the situation that at the time. So members are asked to note the information in terms of the update from the Minister. I don't intend to elaborate on it, but it's just for the purposes of the minute. I'm opposed to the decision that the Minister has taken to recommence this scheme, and I made those comments previously, so I'm not going to repeat them, but I don't agree with the decision that she has taken on that particular issue. In terms of the other item around counter-terrorism, the Sentencing Release Bill, the Minister has responded to the Committee's request for confirmation that she intends to lay a memorandum before the Assembly explaining why an LCM is not being sought in relation to the counter-terrorism bill. The Minister has advised that she plans to lay a memorandum in accordance with the Assembly Standing Order 42A in order to ensure that other members of the Assembly have sight of her position and rationale. So members are asked to note that. There is a letter been circulated round where I'm seeking clarity as to what the UK Government intends to do in response to that. So I think we're clearing that hopefully for issue later today once members are content with its contents. And I would intend to revisit this when we get a response from the UK Government indicating what they plan to do. Linda?
That's the letter that the committee are going to clear?
Yes, yeah. It just asks, it's the factual one.
Yeah, no, that's fair.
So whenever we get a response to that, I think may have further discussion on it. Okay, agenda item 5. Sorry. Yes, Mr. Free.
Is there a time restriction on us or pressure on us with regards to waiting for that reply, that response, and the actions of the Minister in laying that memorandum? Because that was a question for Paul.
Well, it's when the Westminster legislation gets laid, you see. So as Westminster proceeds with this, LCMs need to be laid in a timely way in which it can then be reflected in Westminster's proceedings and the bill extended to cover the areas that it had wanted. So what they're going to do now, that's a decision for them as to whether or not they're going to include Northern Ireland or not. So I've no indication at this stage that there's a clock ticking in respect to it.
Thank you.
Okay. Item 5 then, the new legal framework for personal injury discount rate, a summary of the consultation response and proposed way forward. We're going to have an oral evidence session today on this. So we've got departmental officials attending via the Starleaf facility to provide an outline to the committee in respect of the consultation and the department's proposed way forward. So pages 122 to 175 of the meeting pack, and that includes a memo from the clerk which you'll see on pages 125 and 126, and that could be helpful to members in terms of some of the issues to consider. So hopefully I am in a position to welcome officials from the department. Once that comes up on my screen, yes, thank you. So should have in the room there Lorraine McAlpine, Deputy Director, Civil Justice Policy Division, Ms Jane Maguire, Assistant Deputy Director, Family Courts and Tribunals Justice Branch, and Mr Martin Moore, Head of Branch Family Courts and Tribunals, all from DOJ. So you're all very welcome to the meeting. It'll be recorded by Hansard, a transcript of which will be published in due course. So Ms McAlpine, I think I'm handing over to you at this stage.
Thank you very much, Chairman and members of the committee, for this opportunity to brief you on the Department's consultation on changing the framework for setting the personal injury discount rate. As our paper to the committee has indicated, the Minister has a conflict of interest in relation to this matter on account of her husband's membership of a medical defence union. So the Permanent Secretary has taken the key policy decisions. So by way of background, the discount rate is a percentage rate currently set at 2.5%, which is applied to adjust a lump sum award of damages for future losses and expenses in a personal injury case. And this adjustment is intended to reflect the amount that can be earned from investing the lump sum, and is to give effect to the legal principle that an injured person should be fully compensated for their losses, but no more and no less. And this is known as the 100% rule. Although the rate is small in percentage terms, when applied to the investment of a large personal injury award over many years, even more likely decades, it can equate to a very substantial sum of money. The power to prescribe the rate in Northern Ireland under the Damages Act sits with the Department of Justice after consultation with the Government Actuary and the Department of Finance. And the current basis for setting the rate is under the case of Wells and Wales, which effectively means setting it with reference to index-linked gilts. Our recent consultation took into account concerns that this does not reflect how claimants are actually investing their damages, and likely resulting in a discount rate which does not in fact give effect to the 100% rule. 28 responses were received to our consultation and are summarised in the Summary of Responses document, which I believe you have. That document also sets out the department's conclusions about next steps. The key outcome is that we intend to seek executive agreement to bring forward a bill early in the new year to provide for a new statutory framework which will be very similar to the framework which applies in Scotland. This will involve setting the rate according to a notional portfolio of diversified low-risk investments with prescribed downward adjustments to take account of certain expenses and a further deduction which might be called a margin of prudence to guard against the risk of claimants being undercompensated. We believe that setting the notional portfolio in legislation offers upfront transparency and clarity. The Scottish model also means that the rate will be set by the government actuary rather than by the minister. This reflects that once the principles and the legal parameters are established in the legislation, setting the rate is really an actuarial rather than a political exercise. The other main feature of the new model will be a regular review at least every 5 years to ensure that the rate reflects market conditions while allowing reasonable periods of stability in between. As well as consulting on a new legal framework, the Department also undertook a review of the rate under the existing Wells and Wells framework and consulted the Government Actuary and the Department of Finance. We have considered that review very carefully and concluded that, on balance, it would be best not to proceed to change the rate at this time under the existing legal framework. This is in view of the decision to legislate for a new framework as soon as possible and under which a new rate would then be set. With this in mind, the Minister intends to ask for an accelerated passage for the bill to set the new framework. Against that broad background, we're happy to take any questions that the committee might have.
Okay, thank you. I suppose there's a couple of questions around the substance of what it is that we're considering here, but if I can deal with the two procedural areas in the first point. The Minister's conflict of interest, and she's allocated the Permanent Secretary to take the policy decisions on this. How rare is it for a Minister to remove themselves from taking policy decisions? And is it the job of a Permanent Secretary, who is accountable for how taxpayers' money is spent and implementing policy, to be given this authority?
Well, during the suspension of the Assembly, Permanent Secretaries did take certain decisions, but as far as we are aware, when there is a Minister in post, there has been no other case of a Permanent Secretary taking such decisions. The difficulty is that there's really no alternative, because the Minister does have a very real conflict of interest, and asking the Permanent Secretary to do this is the only plausible alternative. We did take legal advice on the issue, and from that we understand there's no legal obstacle to what is proposed.
Okay, so herein lies the question. Who is going to come before this committee? Who's going to go into the Assembly chamber if the Minister has now had to abdicate her responsibility on this? Who's going to speak on the Minister's behalf?
We don't see any difficulty with the Minister taking the bill through the Assembly, because the policy decisions will have been taken and framed in the legislation. I mean, granted, she will have to speak to the bill in the Assembly, and those are policy decisions which will have been taken by the Permanent Secretary, and if there are any amendments or questions, we recognise there may be another role for the Permanent Secretary in dealing with those questions, but we don't see any difficulty with the Minister standing up in the Assembly and moving the bill.
Would it not be the normal practice when you, as Assembly members would do, you declare an interest, you identify what that conflict of interest is, and so long as that's well documented as to what it is, that then doesn't preclude you from actually taking decisions, so long as you're transparent in terms of revealing your interest. It seems strange to have now removed the Minister from any policy decisions around this.
I think the decisions which could be taken would be so advantageous to the medical, or disadvantageous to the Medical Defence Union, which the Minister's husband belongs to, that it really would be quite difficult for her to take those decisions, and she might be criticised for doing so.
Okay, so in that context, the consultation, the majority of responses disagree with your proposals to go down the Scottish model. I'm not commenting as to whether or not I support the Scottish model or not, but the department's then seeking accelerated passage to take this through. So you have a minister declaring an interest, not taking the policy decisions. The permanent secretary is going to take those decisions, and this committee is being asked to relinquish its scrutiny mechanism to have a consideration stage. Does that not strike the department as something that exposes itself to all levels of risks that shouldn't be necessary? And what's the justification for accelerated passage?
Well, the department has a very ambitious legislative programme, and we're trying to get 5 bills through before the end of the mandate. Having decided to go for the Scottish model, the bill would be largely technical. I mean, that said, of course, we absolutely recognise that accelerated passage is very much against the norm, and we wouldn't be suggesting that, except that speeding up the legislative process will sooner remove the uncertainty around the discount rate, which can only be to the advantage of claimants and defendants. And I know that colleagues who are in charge of the overall legislative programme have a concern that if we don't get accelerated passage for this bill, then we're likely to lose the miscellaneous provisions bill.
Well, with the greatest respect, that's not the fault of this committee, and we have a job to do, so I'm sure the committee will consider that as the justification for making the request for accelerated passage. I'm not sure it'll hold much water. In terms of the Scottish model, what are the levels of political accountability in that model when it comes to the striking of the rate?
I think the main political accountability comes in the legislation, which sets the principles which are to apply governing the portfolio, and in agreeing the portfolio on the face of the legislation, and in respect of the deductions which are to be made. Once those decisions are made by the Assembly, then it is really just for the government actuary to apply them. It's also the case that before there is any review under the legislation, then the Scottish ministers in their jurisdiction are to satisfy themselves that the portfolio is still appropriate.
Okay, I'll bring in some other members just at this stage. Linda Dillon.
So, in terms then of bringing this through accelerated passage, what exactly is the minister's biggest concern if we don't use accelerated passage? Is it only the issue around the miscellaneous provisions bill? And then I suppose a question to both yourselves and the chair and indeed the staff here. If we were not to give accelerated passage, how quickly could we do something? It's a fairly tight piece of legislation with, I suppose, a small stakeholder group in one sense. I'm not saying that there's a large group of them, but they're mostly going to be coming at this from the one view. It's not something like the domestic abuse bill or stalking legislation. It's quite different. So, what kind of time frame could we do something like this in? And what is the main concern? Is it around the miscellaneous provisions bill? Because obviously, I mean, the members in this committee have concerns. We all want to see some of the things that we've been told are going to come through in that bill come before this committee and go through before this mandate ends. So, you know, we are considering it from both angles. We just need the best, most accurate information to make a decision on something around this, because you've said it yourselves, accelerated passage is not the norm. It's not something we would want to do as a committee or to agree to. You know, we've just discussed LCMs. We don't like them either. Anything that doesn't allow us our role as a scrutiny committee is not a good way to go. However, based on the information, I suppose we can make the right decision. So I just would like a wee bit more information around that. Is that the only issue? Is it just around the miscellaneous provisions?
The main priority is to get the new legislation into place as soon as possible. And if we have accelerated passage, the plan would be to introduce the bill January, February, Royal Assent in September. If we don't have accelerated passage, then we might not be able to introduce the bill until September, because the committee stages for this bill would then clash with committee stages for other bills which are also in the pipeline. So, I mean, I would need to consult with colleagues in charge of the legislative programme, and they seem to think the miscellaneous provisions bill would then fall off the end. But from my point of view, it's about getting the statutory discount rate onto the statute book as soon as possible. It is a technical bill. It's about investment products and percentage of investment products and how percentage points should be expressed, and it's not the government actuary doing it, it's a deputy government actuary. I'm not saying, of course, that there isn't room for the committee, obviously, to contribute to the bill, but we need to balance that against the desirability of getting the legislation into place as quickly as possible. And we don't underestimate at all, you know, the implications of an accelerated passage, and it reduces the role of the committee. I think before this could happen, the Minister actually has to come to the committee and speak to the matter herself.
Yeah, Chair, I accept that. I mean, we have had some conversations before. You're right, the committee has quite a heavy legislative timetable in this mandate, but I think that as a committee that wouldn't preclude us from looking at other legislation, or even from looking at a number of pieces of legislation at the same time. So, and I'm not saying that it's absolutely ruled out, because I don't speak for the committee, but I'm still not absolutely clear as to why it has to be accelerated passage in order to get it onto the books quickly, because I agree with you, there may well be reasons that it has to get on the books quickly. I'm still not really clear on that either, why it absolutely has to be on the books quickly. So maybe, and you've said that you want it on as quickly as possible, and that, you know, that's the desire, but why? What is the imperative?
Until claimants and defendants know what the statutory discount rate is going to be, it creates an awful lot of uncertainty for them, for their lawyers, in trying to settle cases, because they don't know what the rate's going to be. So until they know that, cases will be delayed and may just back up in the court system, or they'll be trying to settle cases somewhere between the current prescribed rate and what they think the rate might be under the Scottish model. And we're really just very anxious to give claimants and defendants as much certainty as possible in order to allow, I mean, those people who have suffered significant personal injuries to have their claims disposed of and to get the compensation to which they are entitled just as quickly as possible. If we can't introduce it in January, February under the accelerated passage, it may be September before we can introduce it, which would push back Royal Assent until early the following year, which isn't desirable, we think, from the view of any parties to litigation.
I'll bring in other members here, but I'm seriously struggling to understand how you can introduce this bill in January if you're going to get it through accelerated passage. So therefore, the legislation will be drafted, it can be introduced, but if we don't give you accelerated passage, you're then going to sit on it until September. Like, it's not the department, with respect, it's not the department's job to tell this committee how it carries out its work. So there's no reason why the department can't allow us as a committee to manage these pressures. So, you know, if you're saying that you have to wait for the miscellaneous provisions bill to be dealt with, that you can't then put through the accelerated passage, that's a decision by the department. It's not a procedural issue for this committee. It would be your department deciding that, not the committee. So explain to me why you can't allow us to do our job on this bill, and you would need to sit on it until September. Who's took that decision?
Well, we do have an indicative programme for all 5 bills, which envisage the committee dealing with committee stages of bills sort of in a sequential manner. If the committee is open to taking a committee stage of more than one bill at a time, then I expect colleagues will be willing to relook at the legislative programme. It's not that we will be waiting for the miscellaneous provisions bill before we introduce this. We think the miscellaneous provisions bill will just not be possible.
Well, the department's planning to introduce the committal reform bill within the next couple of weeks. Subsequent to that, it's going to introduce the stalking bill. They're going to overlap. So it's not as though the department has decided, let's do committal reform and leave it for 6 months and then we'll introduce stalking. So the department has already decided to give this committee 2 bills. So I'm struggling to understand the justification for this request for accelerated passage. And this debate around it is actually taking away from wanting to get into whether the Scottish model is the right one or not, because the majority of respondents have actually said that they don't believe that it is. So I'll bring in Paul Frew.
Yes, thank you. It's good to hear the officials concerned about the welfare of the committee with regards to our workload. But when you say that the bill would be technical in matter, does that mean that we wouldn't understand it?
No, I'm sure that's not the case at all. You will understand it, or else it won't have been well drafted, which I'm sure won't be the case. It's just going to deal with technical issues, which we will all understand, but maybe, for example, on the notional portfolio, there is a list of investment products and how the percentage which a lump sum should be invested in each of those products. So it's like 5% in gilts and 10% in index-linked gilts and 30% in overseas equities or something like that. I personally would not be able to contribute to a discussion on whether, it shouldn't be 30% for overseas equities, it should be some other percentage.
Okay, so I know this might be awkward for officials to talk in regards to the interest that the Minister has declared, but it seems to me, if I heard correctly, that the Minister's interests will be disadvantaged by this bill. So if that is the case, and that's what I heard, is this the Minister washing her hands of this bill?
No, she's not washing her hands of it at all, because she would be the person having to move it in the Assembly, and I'm not sure that I would agree that the bill is not in the interests of the Medical Defence Union to which her husband belongs. I think that group did prefer the English and Wales model, but I think the fact that we are legislating to move away from the Wells and Wales model would by and large be seen as being in the interests of insurance companies and unions who support or provide insurance for private medical practitioners.
You say that the accelerated passage is because of, one, it's a technical bill, and two, because of the time pressure and of course the workload of this committee, which is very commendable. But can I say, if the Permanent Secretary has moved this policy, what would What stopped the department doing it over the last 3 years?
Well, as soon as the Assembly returned, we issued a consultation paper on reviewing the rate under the current Wells and Wells model, but we couldn't really legislate for a new framework in the absence of an Assembly. We were working with MOJ and Scottish departments over a number of years prior to this on what to do about the statutory discount rate, so it wasn't as if we just suddenly picked it up in January or February, but we felt there was only so far that we could take this without a minister.
The divergence in hourly rates has been a subject of discussion for many years. I can recall the last Justice Committee dealing with it, and I can remember PAC reports on it with regards to managing legal aid. I think that was way back in 2016. Yet here we are in 2020, and now you're asking for accelerated passage. Does it not seem strange to you that we would be asked to do this so quickly?
I'm not sure. In fact, I'm quite sure the statutory discount rate doesn't have any bearing on legal aid. This is a...
So with regards to the sequence of bills that the department has, not the committee,
Yeah.
can I offer, speaking not on behalf of the committee, but giving you some reassurance that this committee and its members are quite thorough, are quite professional at what we do, and it has a staff that is top-notch and on top of their game. And we will accept as many bills as you could throw at us in the time left to us in this term. Thank you, Chair.
Okay, thank you, Paul. Doug Beattie.
Thank you, Chair, and thank you for answering these questions. I guess, by just the questions that are coming at you, you can see how this is not just a technical bill, but it is a complex bill. And I just want to and I don't know if you did answer this, and apologies if you did, but I just wanted to raise something that the Chair raised, and that is that the majority of the respondents said they preferred the English and Welsh model. So why did you then say, no, we're going to go with the Scottish model? What was the rationale behind that?
Well, I mean, the consultation isn't, I'm sure the committee will agree, just a numbers game. I think most importantly that the principles in the English and Scottish legislation are very similar, and they both assume that a claimant will invest in a diversified mix of low-risk investments, and both models are consistent with the principle of achieving 100% compensation, ensuring that money is available to meet expenses as they arise, and that it will be exhausted at the end of the period of the award. In Scotland, though, those principles are discharged on the face of the legislation, which prescribes in a table the notional portfolio, the investments that a claimant is presumed to make, and the prescribed deductions that are to be made, and then the rate is then set on that basis by the government actuary. In England and Wales, it's for the Lord Chancellor to set the rate, taking these principles into account and on the advice of a panel of experts whom he is to appoint. He's also to have regard to the actual investments being made by claimants and make allowances for expenses such as he thinks appropriate. So I would have thought that the English model is just that little bit more opaque than the Scottish model. If the Assembly legislates to describe the notional portfolio, then everyone knows what they're dealing with up front, and that will be a role for the legislature. The legislature will also determine the deductions that are to be made, rather than those, as would be the case under the English model, something for the Minister to take into account just on the advice of a panel of experts. And I have to say, in 2015, I think it was, the Ministry of Justice commissioned a panel of experts to look at issues around the statutory discount rate, and they couldn't reach a consensus. So the role for the panel of experts in England and Wales, even under their own model, is untested as yet. I think we should have confidence in the government actuary to carry out this role, and for him to carry out the role on the basis of the legislation which the Assembly will have put in place.
And that's a fair one, and you're absolutely right. Consultations are not about numbers, but it's important enough to be in the consultation and ask the question in the first place. And if it wasn't, it wouldn't be in there. So can I just ask then, I mean, a lot of this is about what is the projected cost to the public purse. Do we know what the projected cost to the public purse difference would be between staying as we are in the Wales and Wales model, or adopting the English and Welsh model, or adopting the Scottish model? But is there a projected cost to the public purse to either of these?
It's almost impossible to give a projected cost for it, because that would require us to know the value of all personal injury claims which are currently pending against all government departments and trusts, and what is the pecuniary loss element of that claim, and what is the anticipated lifespan of the claimant. It's only when you have that information that you know what figure you're applying the statutory discount rate to. And we haven't gone to trusts to say, tell us all of the claims pending against you, or to any other government department saying, well, what are the value of all the claims pending against you. In broad terms, we can say, I mean, Wales and Wales is currently at 2.5%. If we applied that rate now, it would go down to minus 1.75, maybe minus 2, and that would be very significantly more expensive for the health service and for insurers. But this isn't really about cost. It's about fairness to both defendants and claimants, and what is the right model in order to ensure 100% compensation rule.
Yeah, and again, you're absolutely right, and it is about the claimants and making sure they get 100%, but there is a cost to the public purse in one way or another, and where you cannot look to the future, you can look back to get an understanding of what that would be. So the modelling you would take from the previous years to have a better understanding of what the difference would be in staying where we are now, to what the difference would be if we adopted the Scottish model. And I guess the reason I'm asking questions like that, even though it's a pretty broad brush question and it's not pointed, because that goes into this part about accelerated passage. There are so many questions that need to be asked and for us to winkle out that I'm sitting here at this moment in time and I don't even know the right question to ask. I need to be able to delve into this more to understand the very nature of the questions I need to be asking. I mean, I think this is an incredibly important bill going on in the future, and therefore I'm in no doubt it does need the scrutiny that this committee will give it. So that's my concern, is that I just think we need to dig into this a little bit more than we are at the moment.
Okay, thank you. Rachel Woods, and then I'll bring in Sinead Bradley. Not sure where that's coming from.
Fire alarm.
Investigate.
Okay, thank you.
I
don't want you being stuck in the building if you need to vacate it.
This committee is very important.
Somebody save them.
So what's your actions on the fire? Well, we just go investigate.
Okay, no problem. You're okay.
Conspiracy theory. Because we were asking too many questions.
It's always whenever we chime in.
Yeah, we can move on to our next part of the agenda. So this committee staff will get in touch and see if we can get this started again in the next half hour, hopefully, or hour. I can't hear what you say.
Deep state.
Okay, take care. Okay, members. If the broadcasting folks can cancel that, thank you.
Deep state.
Sorry about that, members. One of those things, when something happens, and hopefully there isn't. Hopefully there isn't actually a genuine problem.
Hopefully not.
Fair to them,
not.
so.
Yeah.
But there's maybe some more questions members are going to want to tease out with them on. I know today the committee is going to be asked to give a view as to whether or not we support accelerated passage, and so members are going to need to come to a view on that. I'm clear on my view based upon the answers that I've got as to how we should be dealing with this. But maybe rather than going over that, we'll move into the next evidence session straight away, and then we'll come back to this, hopefully, if we can recommence it. Apologies, Sinead, I know you had been trying to get in there, but I'll come back to this item, and we'll just move straight into item 6 to keep things moving. Hopefully they're here. Yeah. So members, just as officials are taking their place, this is around simplifying the legal aid approval process for engagement of expert witnesses in family proceedings in the magistrate courts, and it's a summary of consultation responses and proposed way forward. So the department is here today to outline the results of the consultation on a proposed pilot scheme that will allow psychiatrists and psychologists to be instructed in public law proceedings in the family proceedings court without having to get prior authority from the Legal Services Agency, provided they work within a fixed hourly rate and within a certain number of hours, and the department's proposed way forward. So the relevant papers are at pages 177 through to 234. So can I welcome Stephen Martin, Deputy Director of Enabling Access to Justice Division in the Department of Justice, and John Bradley, Head of the branch, Civil Legal Aid Reform Branch within DOJ, to the meeting. You're both very welcome. It will be recorded by Hansard, a transcript of which published in due course. So, Mr. Martin, I think I'm going to hand over to you at this stage.
Great, thank you, Chair. And thank you for the opportunity to be here today to brief the committee on the consultation on improving the way expert witnesses are appointed in public family law cases in the Family Proceedings Court. Public family law cases involve important decisions about the care and welfare of children deemed by social services to be at potential risk of harm. Expert psychologists and psychiatrists are used in around 20% of cases in the Family Proceedings Court, and the purpose of the changes we're looking to introduce are about, firstly, reducing potential delay in these important proceedings by streamlining the approach for appointing experts, and secondly, improving transparency and value for money by standardising the amounts experts are paid. The changes we propose to make are based on the best available evidence, and we will plan to test the approach in a year-long pilot. If this is successful, we will look for opportunities to roll out similar approaches to other types of experts used in other types of cases. The pilot will also be used to iron out any operational issues that arise and create a sustainable operational model that can be used more widely within the Legal Services Agency in terms of other expert appointments. The consultation was well received, and additional evidence came to the fore, which has helped to shape our final proposals. These are set out in the post-consultation report. There are areas that have changed as a result of the consultation, and those are set out in the briefing note. The two main changes relate to the hourly rate for psychologists and the cap on hours within the general authority. So in terms of next steps, our plan is to launch the pilot for a year from the 1st of January and to return to the committee early in 2022 with an evaluation report and an outline of our next steps. I hope this short briefing, Chair, has been helpful, and we look forward to your questions.
Okay, thank you. Sinead, you have your hand up. I'm not sure if it's to come in on this. No, it's from a previous one. That's okay, no problem. Linda Dillon.
That's an excellent briefing. If only they could all be as succinct as that. First of all, I suppose to say we as a party didn't respond to the consultation simply because we wanted to see what the interested bodies and those who understood this best would what their responses would be, and then we could, I suppose, take a position from that. Just a couple of small questions. The first one is just in relation to that change. Why was there a distinction between psychiatrists and psychologists in the first place? So I suppose I'm just trying to reassure myself that it wasn't a case of a lot of psychologists saying we should be getting the same as them, and I'm fairly certain that's not going to be the case. And then just following the conclusion of the consultation, have DOJ worked with any practitioners in relation to working out the new time cap and around the exceptional circumstances, to consider specialisms? What will it mean in what will it mean in practice? What are specialisms, I suppose, and is my main question there. I mean, to me this looks good, obviously, and I think even the fact that obviously this will mean a reduction for some people in their hourly rate, but £100 an hour is a substantial rate.
Yes, absolutely.
And I think anybody in that field that's really interested in what they're doing, really cares about what they're doing in terms of family courts, will be more than content to be getting £100 an hour. So, I mean, I do think that it is hopefully going to be a positive move, and I do think even having this as a pilot and looking to it then as to how it can be rolled out, because it's one of the issues that I always have, pilot, but never any plan to roll it out. So a plan to roll it out for me is one of the vital elements of this. So I would suppose congratulate you on that element of it as well. But just those few wee questions.
Yes, certainly. Perhaps if I start and then John can pick up.
Yeah.
So in terms of your first question, we struck the original rates because we looked at the NHS salaries for consultant psychiatrists and consultant psychologists, and therefore we struck the 90 and the 100. But actually the evidence that came back was that we'd forgotten about certain things in terms of psychologists, so we hadn't taken some things into account. And there was also an issue about the rates that they were currently getting were perhaps significantly higher, so many of them would not have been ever working for that kind of rate. So that's why we came from the 90 to the 100, and it's broadly in line with what is in place in neighbouring jurisdictions. So we felt that was probably a fairer rate and more likely to get a good body of psychologists that would be prepared to do that work. In terms then of the time allowed then, John, and the other point around the exceptional circumstances, do you want to cover those?
Yes, one of the things that's been beneficial for us in terms of focusing this pilot narrowly on psychologists and psychiatrists, it has enabled us to work closely with professionals in the field, so to go and talk directly to the people who are involved in producing these reports for us, and to get a much richer understanding of the work that's typically involved in meeting with the people involved in the cases, conducting psychological assessments and report writing, and the other work that goes into the compilation of a report. So we've been able to construct a cap on the hours that fully takes into account what we've been told from people working in the field, reflects their real life experience of conducting these cases. With both the cap and with both the hourly rate and the cap on the number of hours, what we've done is pitch it at a level which we believe will cover a reasonable number of the cases to make the standardisation process worthwhile. But that has some degree of conservatism built in, and the intention will be to test how that works in operation through this pilot phase. What we're not going to do is launch it, run it for a year, and then look back at the end and see what happens. We've built an evaluation system that'll give us real-time live information on what sorts of applications are coming in for these certificates, how they're being assessed by the agency, and what that's resulting in terms of outcomes, in terms of the case, whether they're running more quickly or what have you, on a live basis. We'll look at it. We've timetabled ourselves to look at it every 3 months during the 12-month period, but we'll also get live reports should any issues emerge during that time. In terms of the test for going beyond the cap or going beyond the hourly rate, we had representation that there are occasions where, perhaps especially in respect of psychiatrists, but to some degree also in respect of psychologists, where the issues that the children or the family are facing are so particular or so specialised that there are very few people who have the necessary expertise and the necessary experience to provide those reports. And in those circumstances, it can be necessary to increase the rate that's available to attract those people in to do it. We're working with the Legal Services Agency currently so that they'll have a robust mechanism for identifying where those criteria are met, and to ensure that we don't provide a barrier to the appointment of the necessary expert, but also that we don't create so many exceptions that it undermines the purpose of the general authority in the first place.
Thank you.
Okay, thank you, Linda. Rachel Woods.
Thank you. I just have a few questions on this. In terms, just following on from Linda's question about specialism, said there about flexibility in terms of the pay, but is there flexibility in terms of the hours then as well, if it's a specialist case?
Yes, indeed. So, as I say, the cap on hours that we've set, it's different for psychologists and psychiatrists, and it's based on our understanding, based on conversations with the two professions, about the work that's typically involved in the sorts of reports that are seen at this level. There is some variability within that. Some of the variability comes from reading time. So if there's a great deal of documentary material that the experts got to read before they can produce their report, that can have an effect on the hours, and we've set the reading time therefore outside of the cap. So the cap on hours is for work done directly with assessing clients, and for report writing. The reading time is set separately from that, and so we shouldn't give rise to a need for large numbers of prior authorities. But there will be times when perhaps there are a large number of children, perhaps there are children with complex needs, perhaps other prevailing circumstances dictate more work is required, and there will again be flexibility around that, and we're working with the LSA just to identify the correct criteria that will apply in those circumstances too.
In terms of judging whether or not this pilot has been a success, what do you mean by success?
Yes, we've got, what we're trying to do for all of our projects is set out very clear evaluation criteria at the start. So the two main benefits we're trying to achieve are reducing delay in these proceedings, because they involve the future care of children. So the quicker decisions can be made, the better it is for the children. So that's a key criteria. And then there's another set of key criteria around value for money. So the evaluation criteria we've developed are really based around those two things. And then there's a third, I suppose, around operational issues, how it operates in terms of legal services agency and the checking regime and the information generation and that kind of thing. But for each of our projects now, we're trying to have quite a clear set of evaluation criteria clearly linked to the benefits that we're trying to achieve.
And just in terms of the hourly rate, you'd said that it's broadly in line with other jurisdictions. Do you happen to have the actual rates in the other jurisdictions?
I think off the top of my head, I think in England and Wales it's £94 an hour for psychologists and 108 for psychiatrists. So we're broadly in the same ballpark.
Finally, just in terms of the respondents, obviously the proposals have been changed since there was consultation. Have you gone back to the respondents to detail the proposed changes?
That's what we're hoping to do. I should have said that at the start. Hoping to do after this session is to publish the post-consultation report, including any comments that the committee wish to make in that, and then that will let consultees know what our plans are and our next steps.
Okay, thank you. Emma Rogan and then Gordon Dunn. So I'll bring Emma in just for the next question. Thank you, Emma.
Thanks, Chair. Look, thanks for the presentation this afternoon. Obviously, saving money and value for money, as you said, is a positive thing. But can the department give us assurances that these new hourly rates and time caps will not have a negative impact on those vulnerable witnesses that are mainly children who are in receipt of legal aid, and considering that the estimated annual saving is 23,000, it's not that high?
Yeah, it's 23,000 out of a spend of about 150. So it's a fairly large proportion, but I take your point. I mean, that's one of the things that we're going to be looking at, and as John said, we're not just going to leave the evaluation to the end. We're going to have real-time information. So if, for example, we find that we can't get expert witnesses appointed at those rates, then there's an opportunity to intervene earlier. But we think, based on best available evidence, that there should be a good proportion of experts who are prepared to work for that level. And in criminal cases, the rate is £100 an hour for psychologists and psychiatrists, so we're reasonably confident there will be a good pool. But as I said, we've got the ability to act before the end of the year if we find there are particular problems.
Might be just worth mentioning as well, Stephen, part of the evaluation methodology will involve not just gathering data through applications and so forth through the LSA, but we're also going to look to gather qualitative information from people involved directly in the running of these cases. So from the judges in the FPC court, from members of the family bar, from solicitors involved in these cases, and from NIGALA and others, on how, if at all, this is affecting the operation of the courts and therefore how it's affecting the children involved. So we won't be sitting in a civil service office looking at numbers of applications coming in and judging success purely in those terms. We'll also look as best we can at the impact on, as you say, the children and families who are, after all, at the centre of these proceedings.
Thank you.
Okay, thank you, Emma. And Gordon Dunn.
Thanks, Chair, and thanks, gentlemen, for your information. Would it be fair to assume that a report will cost roughly £2,200? If you take 8 hours for assessment, 8 hours for writing, say say 2 children, you're up to 2,200. Roughly, would that be the average cost?
It's not unreasonable.
Yeah. What about witnesses going, if they go to court or go to other hearings? What sort of rate are they on then, the expert witnesses?
Oh, so if the expert witness is called as a witness in the courtroom, I think that typical rates are something like £500 a day or £250 for a half day, is roughly the sort of fees and payment.
You're not sure on it?
I haven't the precise figure in front of me. I can get back to that. With that,
no, I think that's the figure. At the moment, it's a little bit. It's a mixed picture. But what we're moving to is a standard fee of £250 for half a day and £500 for a full day. So that's the fee that they would get if they had to appear. In many instances, they don't have to appear because their report is sufficient. And talking to some of the family judges, they're very keen that those reports are kept focused and a little less lengthy. So they won't necessarily always need to be called, but if they are, those are the rates: £250 half a day and £500 for a full day.
Yeah. Okay, Chair. Just following on that, the Northern Ireland Audit Office report of 2016 put quite a bit of an emphasis on the use of expert witnesses and the need for reform. Is this part of that, or have we not really tackled all of those issues? It mentioned in the report of 2016 there is no set fee structure for this type of work. Fees payable under the General Authority have not been reviewed since 1992 and have an upper limit of £120 per hour. And it talked about, we've examined a number of legal aid case files and found that different experts charge different rates for reading and constructing reports.
Yes, so this project is part of that reform. On the criminal side, their standard fees have been in place for some time, and it's £100 an hour for these experts in criminal proceedings. On the civil side, there are a much wider range of experts used, and some of them not very often. So engineers, for example, in road traffic accident cases and so on. So this is the first part of our reform on the civil side. Now, there have been changes since that report in terms of how the Legal Services Agency operate expert witnesses and the controls that they put in place. But in terms of changing the policy on the civil side, this is the project that we're hoping that will initiate that change. And if successful, then we would hope to roll that out to a wider range of experts right across the civil law.
Is there general support within the legal world to progress this?
I mean, we got quite a positive response to this consultation, and I think in large part because people see it as addressing delay. I think as long as, I think Emma Rogan's point was a really important one. I think as long as whatever we do does not add to the length of time taken in cases, we'll have support from the legal profession. And I think the consultation was well received because it was genuinely open and transparent, and we engaged with the right people. So I think as long as we take those principles forward into any further reform, then I think it will be reasonably well supported.
But it is important that the public out there are assured that legal aid is under control. And you know, I know there's been some effort made, and I believe the total expenditure has been reduced. Are you aware of the last year's spending on legal aid? Can you verify it?
Yes, the 1920 year, the audited accounts haven't yet been produced, and the Controller and Auditor General is currently completing his audit, so I don't have that figure. The report will be published, I believe, by the 15th of November, and that will have the 1920 figure. The figure for 18-19, I think, was 84 million in terms of legal aid. There's about 3.5 million of that is on expert fees right across all of the types of cases, criminal and civil.
So you're giving us assurance that there is an increase in confidence and control of legal aid?
I mean, there definitely is. We're in a much stronger position than we were in 2016, and I think one of the things this particular consultation has benefited from is the introduction of the legal aid management system, because pre the introduction
of that... That's an IT-based system?
It's an IT system, it's a case management system, and that is giving us much richer information to develop our policy from, and it's giving the LSA much better information and a system to manage cases. So that certainly has been a major improvement.
Okay, thanks very much. Thanks, Chair.
Okay, thank you, Gordon. Members, any other questions? No, okay, just to finish on this, Stephen, I know this deals with some of the experts, but obviously there was the PAC recommendations back in 2016 regarding all of the experts. Are you able just to update us in the context of this, where the department's at in addressing that report?
Yes, so in terms of that report overall, Chair, progress has been made in a number of recommendations. So we will be producing we'll be briefing you through a written briefing in November around the statutory registration scheme and the contracting review scoping study. We'll give you an update on that. In terms of remuneration reform, I think we're in a reasonably good place. We're taking forward, in fact, John is leading on this project, standardisation of family fees. And we are currently in the research phase. We've rescoped that project and narrowed the scope. Very happy to give you a briefing about that at perhaps post that research phase. And we are doing further work then in terms of the Crown Court review that was done in 2016. We're doing a further review. That was the review that led to the legal aid strike. So we're looking back at that and seeing if we can sort of develop further improvements. So there's a lot of work to do, Chair, but we're not in a bad place now, and we've certainly got that work well planned, and are focusing our resources as best we can to address those priorities.
Okay, and I know probably for members of the public they'll look at these rates of fees and think this is incredibly high. You know, I understand the context though in which you're operating and professional people, and you need to be able to strike a rate that actually gets what you need. I suppose from public perspective is whenever you commission for expert advice, that decision to commission it is a robust assessment before you decide to actually engage in experts. So it's kind of a separate issue. You have to pay the rate that's going to attract the experts, but we need to ensure that there's a robust decision making before you commission what some will regard as very expensive expert fees.
Absolutely, Chair, and we aren't involved in the decision as to whether an expert is needed. That's an issue for the judge. But talking to some of the senior family judges, they're very keen only to use experts where experts are absolutely needed. In these cases, because we're really engaging human rights in terms of the right to family life and the future of children, there will be cases where experts are absolutely needed. But I know the judiciary are very, very keen to make sure that experts are only used when they're absolutely required.
Okay, no, thank you for that. Okay, members, then, if you're content, then we can thank both of you for coming to the committee today. Much appreciated.
Thank you. Thanks very much.
Okay, members, so if members are content then with the department's proposals that the revised general authority will take effect from the 1st of January 2021. That'll be a year-long pilot, and we can then indicate as such, unless there's any more information members need, then we'll proceed with that course. Okay. Okay, thank you. Okay, members, I'm going to keep going through the item, the rest of the paper. The officials, as I understand it, are making their way up to Parliament buildings and will be joining us. But because of the procedures, there will need to be a short recess to clean the surfaces before they actually come in to the room, just to keep ourselves right. So I'm going to move through though and I'm going to complete the rest of the paper before we go back to that item. So item number 7 is around the maximum number of judges. So it's pages 236 to 240. The department proposes to make a stat rule under the powers conferred to it through the relevant legislation. This will increase the statutory limit on the number of High Court judges from 10 to 15. This will allow future appointment of part-time judges, which may add to the pool of applicants and potentially increase diversity at that tier. It will also allow headroom for the addition of judges required due to unforeseen pressures. The President of the Historical Institutional Abuse Redress Board and the Victims Payment Board, for example, are all members of the High Court bench, which has decreased the number of judges to deal with High Court business. The Department has advised that the change to the statutory limit would be cost neutral and that individual business cases will be required to increase the actual complement from the current limit of 10, taking account of the overall volume of High Court business, while ensuring that funding is available for the additional salaries and pensions. The Department intends to lay the regulations as soon as possible with the aim of having provision in place by December 2020. The statutory rule will be subject to the affirmative resolution procedure. So members, if we're able to indicate that we're content with the proposed statutory rule, then we can proceed on that basis. Members are content. Item 8, the Chemicals, Health, Safety and Genetically Modified Organisms Regulations 2020. At our meeting on the 1st of October, the committee noted that the Speaker had written all chairs providing a copy of a letter from FMDFM, which included the Northern Ireland Civil Service Administrative Guidance for EU Exit Transition Period Statutory Instruments. Members were advised that further information regarding the role of committees in relation to SIs would be provided by committee staff. The paper has been provided on pages 242 to 244 of your meeting pack. It notes that unless a Parent Act makes specific provision in relation to the Assembly, statutory instruments will not be subject to Assembly procedures, even where they relate to devolved matters. Scrutiny of a statutory instrument is a matter for Westminster. However, UK Government Ministers will not normally make statutory instruments relating to devolved matters without the agreement of the relevant Northern Ireland Minister, and where the Minister proposes agreement, it is appropriate that the Department engages with their committee. The committee should consider if the proposed change is necessary, and if so, why the statutory instrument is the appropriate legislative vehicle rather than a statutory rule, which would be subject to Assembly proceedings. The guidance explains that a high volume of EU exit legislation is required before the end of transition period, and it indicates departments may wish to engage early with their committees, agreeing an approach to consideration of each SI. There will be varying levels of engagement depending on whether the SIs address minor technical issues, more substantive technical issues, and or minor policy changes, or indeed more substantive policy changes. There are 2 SIs on the agenda for the consideration of this committee today that the Minister proposes to agree or has agreed, both of which the Department has described as being technical in nature. The letter for the first SI was only provided to the committee 2 days prior to being laid in Westminster. The second was provided 6 days before it was laid. So if members are content, we're going to ask the Department why the committee could not be notified sooner when the Minister proposes to agree a request that a UK government is taking forward an SI that relates to a devolved matter, and to clarify how many SIs relating to EU exit are anticipated for justice-related matters, and whether these are expected to be technical amendments or if they cover more substantive changes. If members are content, first of all, with that, we will raise that issue, and then I'm just going to highlight what the 2 SIs are that we've got today. But Linda, you wanted to come in there?
Just a very sure of the same issue, obviously, with the SIs, I have with the LCMs, and anything else that removes our ability to scrutinise legislation that impacts here. I don't like it, to say the least. I agree the time in which this has come is very short, and I would like clarity, because I'd like the clarity is that Does that fault lie with the department, or does that fault lie with the British government? Because we're in such time constraints, is that where this has come from? So I agree with asking those questions. Thank you.
Okay. So in terms of the first two of the SIs on the agenda today, the Chemicals, Health and Safety and Genetically Modified Organisms, Regulations 2020, this SI will reverse amendments that were made by the Chemicals and Genetically Modified Organisms Regulations 2016 to ensure Northern Ireland's continued alignment with EU law in accordance with Annex 2 of the Northern Ireland Protocol. The Department has advised that the amendments are minor, they're technical in nature and don't represent changes in policy or place an additional burden on industry, and it was considered practical to allow the Health and Safety Executive in Great Britain to take this forward, so the SI was led in Westminster on the 15th of October. So I think, notwithstanding Linda Dillon's comments, which I would agree with, and we'll put that on record, that we are content to note the position in respect of this SI, but indicate that we're not happy with the time frame, and we want an explanation as to why we were given such late notice in respect of it. So members content then that we note this SI. Content then Law Enforcement and Security Amendment Regulations, the second of the SIs. This will reverse amendments to the Firearms Northern Ireland Order 2004, which were taken forward by the Home Office in the UK-wide Law Enforcement and Security Regulations 2019. It ensures that Northern Ireland remains in alignment with the Weapons Directive, which allows for the retention of the European Firearms Pass. It will also ensure that no deal amendments to Commission implementing regulation will not extend to Northern Ireland, so that the regulatory framework will remain compliant with the Weapons Directive as required by the Northern Ireland Protocol. The Department has advised that the amendments do not represent any change in policy, but reverse no-deal amendments, and it's proposed that the SI is being laid in Westminster today. So again, members are content then that we'll note this SI subject to the same comments around the length of time that we were given due notice of. Members content.
Right.
Item 10, Community Safety Board, the framework overview. It's a written briefing paper, and it's from the Multi-Agency Community Safety Board and framework, which aims to link the strategic and operational response to community safety issues and embed and build on the strategic direction of travel provided for by the 2012-17 Community Safety Strategy for Northern Ireland. The framework, the terms of reference for the board, and a diagram illustrating how the Community Safety Board fits with the PSNI vision for community safety are all included in your meeting papers. Community Safety Board has agreed to focus its work along the three broad themes of people, place and powers, including best practice and performance. So if members are content to note the information that's been provided by the Department on the Community Safety Board and framework, or whether you require any more information. Rachel Woods.
Thanks, Chair. No, I have loads of questions on this, and I appreciate they're not here to, in person. But when I was on PCSP and Council, this is the same membership as the PCSP, is the DOJ, PSNI, Education Authority, Housing Executive. And I know they're saying that they're not trying to duplicate existing work plans and associated actions, but this reads to me exactly like a PCSP. Another thing that annoyed me at PCSP is that the housing associations were not members of it. So we're dealing with issues brought by constituents or community groups or communities talking about issues that involve a housing association. And because the DOJ have said that it's only NIHE, we can't communicate with them. So I wonder why that membership has been chosen. I would like to know what the difference is between this Community Safety Board and the PCSP, which we already fund. And if there's something wrong with the PCSP, fix that rather than, maybe there's something fundamentally different. And in terms of then the relationship with the PCSPs, which have the same membership, how's that going to, how does that work fit in? And finally then, in terms of the Community Safety Board requesting the response group to be stood up to consider a specific issue, how does that happen? If there's a specific issue that's going on in a community, does somebody have to phone them? Or, I just don't know how this works out in practice. So those are my questions on that, but maybe they're due for a different time whenever we have them in front of us.
No, well, listen, I'm happy for these points to be raised, and we can raise them with the department. Linda?
Yeah, no, I agree with Rachel. Obviously, there is nobody here to respond to these issues today. I know that this was something that the Chief Constable was very keen on, and I suppose I'm not going to answer for them. I think they should come and answer for themselves, but I'm only thinking that in terms of PCSP, where that's a local level, this is that level above that. So my concern around that is then where's the connection with the community, because, you know, everything should come bottom up. It's the only way it works. Where it comes from bottom up, where it comes from the communities up to that, and they might well have devised a mechanism for doing that. So I suppose I'd like the information around that. So at some point, and for me, it's not something that has to happen. We have quite a heavy workload in the short term, but I do think that it would be valuable for us to get that detail at some point, and I agree with Rachel in relation to that.
Okay, well, listen, let's raise it with the department in writing in the first instance. You know, I think there are issues about potential duplication or indeed displacement of the work of PCSPs, and getting reassurance about that. So let's in the first instance see what the response is, and then the committee can take it forward. If we need to have them come up, we can bring them up in respect of that. But we'll write to them in the first instance. Okay. Item 11 then. Pages 286 to 306, the Department has provided information on a proposed private family law early resolution action plan that it's progressing jointly with the Department of Health. The aim of the plan is to improve outcomes for children and families by diverting parental disputes which do not require judicial adjudication away from court, and supporting the early resolution of parental disputes which do come before the courts. The plan is envisaged as an evolutionary exercise with early actions informing decisions on how the departments might best support separating parents in the future. The department has stated that initial actions are fairly modest but will be critical to the development of an evidence base in an area on which existing data is limited. Initial actions are focused on increasing awareness of options for resolving disputes and trialling tools to support the dispute resolution process. So the Justice and Health Ministers intend to launch the action plan before Christmas. The Department has indicated that it will engage further with the Committee on substantive actions such as the education programme and the mediation pilot emerging from the action plan. So again, members, if we're content to note the proposed private family law early resolution action plan, unless there's more information needed, we'll note it. Noted. It's not a sore throat, members, it's all those particles of disinfectant that's now floating around the room, so maybe that's good for you. If you listen to Mr. Trump, he recommends that you take some of these things. I'm not so sure. Item 12, the 5-year problem-solving justice strategy, pages 309 to 331. The Department has provided a copy of its 5-year problem-solving justice strategic plan, which it has developed to facilitate decisions regarding the rollout of those initiatives shown to be effective and determine the costs. The plan has been reviewed and updated to take account of the impact of COVID-19. The Department has highlighted that in light of the uncertainty around future budgets, it's too early to determine if the required funding will be available, and it recognises that there will be a need to prioritise what can be delivered. One of the initiatives in the plan is support hubs, which the committee has recently written to the Department about in the context of funding ceasing to be provided. The plan indicates that support hubs are operating in 10 out of 11 operational areas, and a scoping study is underway for the final area, which is Belfast, and a support hub steering group is also being set up according to the plan. Based on feedback from stakeholders and the relatively small costs involved, it's recommended that support hubs should continue, and an evaluation should be carried out in 2020-21 to inform a review of services and the operation of funding and the funding model. This appears to be contrary to the decision to cease funding from the 30th of September that was outlined in correspondence by the Head of Community Safety Vision and correspondence to Mid and East Antrim Borough Council. So, members, it's there for noting, unless there's more information that needs to be raised. Rachel Woods.
Yes, Chair, thank you. I picked up on the sport hubs and just wanted to confirm that it is the same support hubs that we were discussing not too long ago. So is one arm of DOJ cutting the funding and the other is saying that it's a priority? So I think we need to get some clarity on exactly what's happening with the support hubs, and why it would be something that would be in an initiative here but not elsewhere. And certainly I think they should be rolled out further and not left to the councils to pick up the funding for. Everyone will know the dire situation that the councils are facing because of COVID, and certainly if DOJ have been funding them so far at a minimal cost, I think they should continue.
Linda?
I would concur with what Rachel Woods has just said. I also just want to make the point that there is plenty of evidence to show that problem-solving justice interventions produce better outcomes and in the medium and long term create savings. So on the back of what Rachel's saying, I would just like to clarify that the department does intend to put funding where there is evidence to show that it works. It works not only in saving money, but actually in better outcomes for the individuals themselves and for the wider community. So that's what we're supposed to be about. And I want to ensure that the department gives us some commitment around funding those problem-solving rounded problem-solving justice. I just would like some reassurance that there will be funding put in that direction, because it has been proven that it works and that there are good outcomes for everybody involved. So I'd like some reassurance around that.
Okay, well,
said also.
I agree, and to me there's clearly a contradiction here within the department's position that they stopped funding on the 30th of September, but they're recommending that this is actually worthwhile and minimal. So let's raise this with the department, and we'll question that and also ask for details on the assessment of the cost-benefit analysis on each project in respect of this issue as well. If members are happy, then we'll do that. Item 13, pages 333 to 359. The department has provided a copy of the Court and Tribunal Service Business Plan 2021, which was originally put on hold during the COVID-19 outbreak but has now been agreed. The plan is dependent on the current situation and, if necessary, subject to further review and amendment throughout the year. So members, if we're content, we'll note the Northern Ireland Courts and Tribunal Service Business Plan for 2020-21. Item 14, Draft Forward Work Programme. It's pages 361 to 371 of the meeting pack. As the relevant papers, the department has provided a list of items of business that it would like the committee to consider at the meetings in November. The department is not yet in a position to confirm whether the evidence session on the committal bill will take place at our meeting on the 5th of November, or whether it may need to be deferred until the meeting on the 12th of November. So if not deferred, currently there is no oral evidence session scheduled for the 12th of November, but we do have 2 written papers. I know the executive was meeting today, so there may have been progress in respect of the committal reform bill. The Minister did indicate to the Deputy Chair and I earlier this week that she had been seeking to advance that through the executive, so there might be a more up-to-date position as a result of that. So the Minister is unable to attend the committee, as we have been asking to have some more engagement with the Minister, but because the executive meets on a Thursday afternoon, then that's proven difficult. So arrangements have then been made for her to attend meetings on, and I know it's not ideal for members, but it's Tuesday the 3rd of November from 12:30 until 2 p.m. and on Tuesday the 15th of December the same time. So there's been a number of issues previously identified by members that wish to discuss with the Minister, and they're on pages 16 and 17 of the tabled pack. So those meetings are being scheduled in advance of them, particularly the one on Tuesday the 3rd of November, just so that we have a complete kind of list. Members should indicate then to the clerk if there's anything more that we want to be discussing, and we'll try and space that out over those 2 proposed meeting dates. Okay, so if members are content, we'll schedule the work items that have been requested by the department for the meetings in November, and Again, members, the department will be asked to provide an update on the position regarding those items on the list that it previously provided and had intended to bring to the committee between September and December to enable the work programme to be finalised up to the Christmas recess. So if we don't have the committal briefing bill oral that's scheduled, then I think the committee, we do need to have an informal discussion on our own committee work priorities. So if the committal bill oral session does take place, then we'll go ahead as planned on the 12th. If it doesn't, I was going to suggest that we can have a more strategic conversation with ourselves about the committee's priorities before we're burdened down again with more legislation. So we'll make provisional arrangement for that on the 12th of November, subject to what happens the committal bill. Correspondence, 6 items of correspondence, and I'll draw attention just to one of those items, and it was item 4. The response from the Minister of Justice providing further information on the protest in Maghaberry and Ash House Women's Prison, which has now come to an end. The Minister has indicated that the protest had no impact on the running of either establishment or any member of prison staff, and the prison service is not aware of any detriment caused to the health of the prisoners involved. So members are asked to note the response from the Minister unless any more information is required. Noted. And then just one item in the table pack, and the Minister has responded to the committee's request for further information in respect of the 2 deaths of prisoners in Maghaberry that took place on the 18th and 20th of September. The Minister has outlined the protocol followed in relation to deaths in custody and has advised that given both are now subject to investigation, it isn't appropriate to provide any further information at this time. The Minister also advises that the wishes of the family of the deceased and their right to privacy will remain the prison service primary consideration in deciding how and when individual deaths should be communicated to the committee, and states that it was regrettable that this information was placed on social media. The committee has written to the Minister to clarify the criteria used by the department to determine when information should be provided to the committee, and to explore an approach or protocol for informing the committee of incidents and important matters in a timely manner. So members were waiting on that response. We have written to the Minister in respect of that. That is issued, so we can pick that up whenever we get a response then from the Minister. So if members are content, we'll action then the other items of correspondence as set out in the cover sheet. Okay. And we're going to come into this session again because we're on to Chairman's business, but I and the Deputy Chair had met with the Minister on Tuesday. She had asked to meet with us just to discuss their legislative programme for the rest of the mandate. And the Minister is still, she has told us, intending to bring forward the committal reform bill in November, the stalking bill before Christmas, and the miscellaneous provisions bill around March, April of next year. And as we're now going to discuss again, the personal injury discount rate bill as well to the Assembly. So that's all of my Chairman's business. Is there any other business members want to raise, and we can deal with AOB? If not, then...
Chair, just one thing, the COVID within the prisons. Do we have an update on the management of the COVID-19 within prisons, or what is the latest on that? Perhaps we could ask for an update on that, please.
Yeah, the Minister had kept us updated, I suppose, whenever there was the initial increases within the medical team of the South Eastern Trusts, and we got regular updates. So we haven't had one of late, so we could ask for that.
Okay. Right, thank you.
Okay, members, so that's all of the items on the agenda complete for today's business, but we do want to go back then just to complete the evidence session that we had earlier. AOB. Oh yeah. So if members just want to refer back then to your papers, it was pages 122 to 175. From memory, Sinead Bradley had indicated that she wanted to come in, but can I first thank the officials for making your way up? Hopefully there was nothing too dramatic taking place down at your your buildings there, but we appreciate you coming up here. Now let's just hope the alarm bells don't start ringing in this building.
Well, exactly.
So members, thank you. So I'm going to bring in Sinead Bradley and then I'll bring in Rachel Woods.
Thank you, Chair. I hope you can hear me okay.
We can.
And thank you for coming, not just your earlier presentation, but for going to the effort of coming back up. I really do appreciate it. I suppose when I looked at this agenda item today, there's a few things that maybe in of themselves are not a red flag, but it's the cumulative effect of a lot of things that certainly do raise a flag in my mind in terms of our scrutiny role. So when you start with the conflict that the Minister declared, which is the right thing to do if there's a conflict there, but then the irregular step in of the Permanent Secretary, adding to that then a proposal to go against the mainstream of what the response to the consultation said, compounds it further. Then there's a further compounding when you talk about accelerated passage, removing that scrutiny role from the committee, all on the basis of urgency. And I presume that's what this meeting is for today, is to communicate to us members what that urgency is to justify the need for that accelerated passage. But what I don't want this to be is some sort of hurried attempt at us to try and grapple with the detail that I don't expect we're going to possibly get into in terms of weighing up the merits of the proposals one against the other. I just don't think it would do it credit to try to do that today. So really my two questions are this. I suppose at this stage I still don't feel I personally understand fully the urgency question, because you did refer to that there could be a backlog in the judiciary system, and you refer to the current rate that is being struck. Well, I presume that would continue until a commencement date of any new statutory discount rate is struck. So I don't understand why that wouldn't keep happening until a new commencement date happened, and I've no understanding of what the anticipated numbers are when you talk about backlog in the system. And the other question I have to ask, I appreciate that the department obviously want to work with the committee on all issues, but certainly in terms of bringing forward legislation in particular. But whilst you seek the consent of the committee, I want to know, is it a requirement? Thank you.
Maybe if I could address the question first about why there would be a backlog, since there is a current statutory discount rate. The current rate is 2.5%, which I think everyone, even insurance companies, would recognise as being a bit on the high side. Therefore, if you are a claimant in a personal injury case, you will not want your case disposed of with a statutory discount rate of 2.5%. That would be to your material financial disadvantage. So you're going to want to wait to see what is the final settled rate, either a reviewed rate under Wells and Wells or a new rate set under a new legal framework. So you won't want to settle your case. Lawyers are unlikely to push cases into court until they know what the new rate is going to be. I can't honestly speak to the numbers of backlog. I know in 2019 there was something like 2,700 personal injury writs issued, but that's not to say there's going to be 2,700 cases backlog, because those would be cases at the sort of very early stages of proceedings. But that just gives an indication of the number of sort of personal injury cases that would be taken out in the High Court on an annual basis. And parties will either try and settle the case at something below the 2.5%, or else they will wait to see what the new rate is going to be. Because if you have a large personal injury case, if you have suffered some sort of catastrophic injury and it looks likely that you will live for maybe 20, 30, 40 years, the personal injury rate will have a significant effect on the amount of your damages. So you're not going to want to take a
a higher rate than you might have to if it is altered. So people are just waiting to see, you know, where this ends up.
Okay, thank you, Sinead. Thank you, Lorraine. Rachel Woods.
Thank you, and thank you for coming up today. It's much appreciated. This is a new area for me, I have to say, and it's taken a while to get my head around it, and I can't say, in all honesty, that I understand everything that's in that report, which is why I think that scrutiny time is quite important for me personally. But whatever happens, it has to be in the best interests of those who are entitled to the compensation, ensuring they get what they deserve. So that needs to be front and centre. I'm not a fan of accelerated passage at all. I think we've made that clear throughout this last sort of 6 months. It's been a common feature since February, unfortunately, from the executive, and I've removed scrutiny time, and as a non-executive party, it's very important for me to get adequate time on legislation. But you'd said about accelerated passage, and if granted, it could be laid in January, February, and in place by September. But why the 78 months? Because accelerated passage can be done within 10 days. So I'm just wondering if that, because that's where we've had accelerated passage from the executive ministers before this year. So why the 78 months? I understand that in certain circumstances, like urgent and emergency situations, accelerated passage could be justified. But understanding the urgency in this situation, and I appreciate your answers to earlier on, I'm not too sure what the exact urgency is. So is there a legal urgency? Does this not coming through in accelerated passage open the department up to a legal challenge, for example? Has there been any legal advice taken on that? And then I have another question just about the rates, but those are my first two.
Well, even when there's accelerated passage, a bill's still going to have to go through the normal other assembly procedures, so consideration and further consideration. I know our colleagues in charge of the legislative programme have assumed that if it's introduced January, February, it would still take to royal assent, would take until September. But we can give you more detail on that and just actually the breakdown of the individual stages on the accelerated passage route.
I certainly would appreciate that, because it is my understanding that 10 days is the minimum that accelerated passage can be brought in. I'm just reading it off the Assembly website as well. So if there is, why 78, no, maybe it's because the legislative timetable is already booked out, or whatever that is, but it says under accelerated passage procedure, a bill can pass all stages in as little as 10 days, but in no less time. The process skips committee stage. Accelerated passage procedure requires cross-community support within the meaning of the Act. So I would certainly welcome a wee bit more information about why it could take up to 8 months if it was laid in January.
Yeah, we can write to you about that.
Just sorry for interrupting, but what you're saying is that the accelerated passage aspect of it, even though once the Assembly has approved this and completes final stage, you're saying that it's going to take until September for royal assent to be given to a bill that this Assembly passes in January?
It would be introduced at the end of January or February, so it would still have to go through the other Assembly stages.
But those are all dealt with within the space of 10 days. That's the purpose of accelerated passage, so that a bill is introduced, it gets...
I think 10 days is the minimum possible time for accelerated passage, but that in this case we're still envisaging that we would go through the full other procedures, the second stage, consideration stage, further consideration stage, and that has been planned out by our colleagues on the legislative programme.
So you're going to introduce the bill in January, February, remove the committee scrutiny period, which we could take up to 6 months, but actually take longer than 6 months to complete final stage in September?
But if the committee stage was in, then it would be an additional 6 months, and it's trying to manage that with the other bills.
Additional to what, sorry?
If we have the committee stage, which would be up to 6 months, then we need to factor that in from the introduction in January, February to royal assent in September. That's accelerated passage. It doesn't take any account of 6 months for committee scrutiny.
That's not accurate. You're wrong. Who's advising you guys on the procedures of the Assembly?
We will write to the committee on the way we thought this bill would be staged under accelerated passage and how we think it would be staged if accelerated passage wasn't available. But we were trying to take into account the other legislation which would be before the committee.
Okay, but really interested to get the advice that you're being given within the department as to the procedures of this Assembly and where the committee fits into that, because what you're telling us just isn't accurate. That's not the way that the Assembly operates. Rachel, sorry, you maybe hadn't finished.
Okay. Sorry, just that sort of, it's feeding into my question, to part of the question in terms of accelerated passage and the 10 days. That's 5 working weeks with 2 plenary days in my head, but maybe I'm getting confused now as well, but that was my understanding between introduction and royal assent. So definitely a wee bit more clarity on that, and also would welcome whatever advice in terms of that. But our committee stage, yes, could be up to 6 months, but we've seen with the domestic abuse bill that we have done that in we did an immense amount of scrutiny in a very short space of time. So I understand that you might not have to factor up to 6 months in, but we can also do a committee stage in half that on a huge bill, with, as Linda was saying earlier on, a array of different aspects to it. So in terms of just the legal advice, if there isn't, because I'm trying to figure out to see if there's another aspect of getting accelerated passage, is there any legal challenge? Could there be any legal challenge for not putting this through in this time?
We're not aware of any legal challenge, but there's always the risk of a legal challenge, bearing in mind that the discount rate has been at the current level since 2001.
So there could be legal challenge. So has the department got any legal advice on this?
We have taken legal advice during the course of this process.
And maybe I can't get that answer, but has the legal advice brought you to this conclusion?
I think in the round, we think it is much preferable to have the new legislative framework in place as soon as possible in order to let a rate be set under the new framework.
Chair, I don't know if this is procedure, if we're allowed to do a procedure. Can the committee request legal advice?
It can, yeah.
That's all my questions on procedure. I just have a question on the rate itself. I was trying to get my head around it. Where did the minus 1.75 come from? Scotland is minus 0.75. So if we're going down the Scottish model, where did the extra percentage point come from? And if possible, can someone explain this to me in layman's terms about what this actually does?
Well, the reason our proposal for a change under the existing legal framework was minus 1.75 is because it's a different framework from the framework which applies in England and Wales and in Scotland. So in Northern Ireland, under the Wells and Wells case, the assumption is that a person would invest in index-linked gilts, which is a type of government bond, and it doesn't give a particularly good rate of return. But our legal framework requires us to assume that claimants are very risk-averse and therefore will invest in index-linked gilts. They are not performing well, and it actually means although they're protected against inflation, you're not getting a good return on your money. So there's a rate of minus 1.75% in order to make sure your lump sum award retains its value for the life of the award. Scotland and England and Wales have set up different arrangements so that the assumption is not that you invest solely in index-linked gilts, but that you will invest in a low-risk, diversified portfolio. So the Scottish portfolio, for example, assumes you will only invest 10% in index-linked gilts, and you'll invest other percentages of your reward in different investment products. And when the government actually applies that portfolio, it comes out, along with certain deductions for expenses and so on, it comes out at 0.75.
I need to look up what an index.
England and Wales, it's minus 0.25.
Okay. And just I suppose in a practical term, so the investing in these in index-linked gilt, that is a mouthful. Do claimants have to invest in that? Is that part of whenever they get compensation?
No. I mean that's part of the problem. The statutory discount rate is based on the assumption that claimants will invest all of their reward in index-linked gilts, but there is no evidence that that is what is happening in reality. And the government actuary has said, just look, it's unlikely that anyone would invest all of their reward in index-linked gilts.
So, sorry, this might be very stupid questions, but this change is being proposed for something that in reality doesn't happen?
We have to set the discount rate on the assumption that people are investing in index-linked gilts, because that meets the criteria in the Wells and Wells case. And what we want to do is move to a legal framework which we think is probably a more accurate reflection of how claimants properly advised would invest, and that would be over a more diversified portfolio, and that is what they have done in England and Wales and Scotland, which is why they have different discount rates from us.
Thank you.
Okay, thank you, Rachel. Paul through, and then Sinead Bradley's wanting to come back in, and then Linda.
Chair, basically just to lighten the mood and to offer sincere apologies to the officials. I threw you a curveball of a question earlier on. I'm sorry, I don't know how I ended up on the wrong list. So apologies for that, because you're good, but you're not that good to answer a question like that. So apologies.
Thank you, Paul. You're going soft.
Yeah.
Sinead Bradley.
I'm glad that's recorded.
Hands up.
Thank you, Chair. Chair, I would love, like Rachel, I'd love to go into that detail of all these assumptions that are made about, what's invested and how wisely people might use their money or not use their money, and when it's spent up, it becomes an extra cost to the public purse, and we want certainty for people who have an entitlement, certainly under this. But what I still don't understand, and forgive me for going back over this, because I think the question in front of us today as a committee is, do we agree to accelerated passage? And the argument that I've heard so far that there is this, that the reason for accelerated passage is that there's this building backlog within the system of people who are hesitant to settle their claim because there's uncertainty around this issue, and that's why we need to do this. But when I ask the question then about numbers or how big is that, within the system, there doesn't appear to be any evidence how our scale of the size. And also I want to go back to the question, is it a requirement? I said that the Minister would love to work with the committee. I don't doubt that. And I don't doubt everybody on this committee would want to ensure anybody who's due compensation gets it swiftly and at a fair rate. But I need to understand why the urgency to do this.
Well, I do have a letter from the Association of Personal Injury Lawyers who would represent personal injury claimants, and they have said that settlements in the majority are on hold. Now, I don't have numbers. I don't know if I could get numbers from April, but it stands to reason that if you were a personal injury claimant, you would want the most advantageous statutory discount rate apply to your settlement, and you would know all of this debate is going on, and there is a lot of interest in, are we going to legislate, or are we going to change the rate, or what are we going to do? So people are really waiting for the music to stop before they decide whether to settle their case or run it or whatever. The other issue, as was mentioned, is the impact this might have on other bills within the legislative programme, particularly the miscellaneous provisions bill. But I've heard what the committee says about the programming of legislation, and we'll go back to colleagues and see have we got the formulation correct.
Okay, thanks Sinead.
Right.
Linda? No, sorry, Sinead.
And the requirement, well, I know they're looking the consent of the committee for accelerated passage. Can the Minister continue without it?
So I can answer that for you, Sinead. And no, under the relevant standing order 42, the Minister would need to get cross-community support in the Assembly to proceed through accelerated passage route. So this isn't in the gift in the Minister if she decided to take that route.
I think the Minister has to come to this committee as well. It's not a decision I think the committee's been asked to make today.
No, no, that's right. It requires, under that standing order, where exceptionally a bill is thought to require accelerated passage, which shall exclude any committee stage, the member in charge of the bill, in this case it would be the Minister, shall before introduction of the bill in the Assembly explain to the appropriate committee the reasons for, and it then indicates that before second stage in the Assembly chamber, the member in charge shall move a motion that the bill proceed under accelerated passage procedure. So the Minister would need to come to this committee to provide an explanation. The committee still at that stage doesn't have a veto in that respect, but it then goes into the Assembly chamber, and then Assembly members would decide whether or not to grant accelerated passage. That would be a decision ultimately that the Minister could take. But yes, it's for members to vote on it eventually. Linda?
Thank you, Chair. I suppose just to agree actions going forward, I think that we should get some detail, to be fair, from procedures rather than from DOJ, because the procedures in the Assembly is not the speciality of the officials in DOJ, but we need to know. We need that information. And then I would just say to, I suppose, to yourselves as the officials going back to the department, and I think the Chair has said this, but just to be clear, and I think I'm speaking on behalf of the committee, and if I'm not, you've made dissent quickly. Work out what the department can do in terms of bringing the legislation to us. We'll work out what we can do. The department doesn't need to worry about the committee. We'll work that out, and we'll be straight with you as how timely can we bring it through. But I would say that if accelerated passage is not the route, that this committee would certainly endeavour, I believe, to make it as speedy a process as possible. It is a very narrow piece of legislation, and therefore I think that we would just, and I'm not sure whether, I just wanted to respond to a question that Rachel had actually asked. So around the discount rate, whether they invest or not, the discount happens. So that's why the rate needs to be looked at, because I have struggled with this, I can tell you. This has been in committee papers for on a number of occasions now, and it's probably only this time that I've fully got to grips with it, to be fair. So it is difficult to get our heads around it, but the rate, I suppose, is not our concern, but the framework is.
It is, yeah. And that's all of the arguments that we've heard. There is an immediacy about this. I know from a constituent who has been left paralysed, is waiting and has been asking, when's this rate getting changed? And I don't think the rate is currently fair. I have to set that aside, because once this framework's in, that's the framework, and that'll be the decision as to how you get the rate, and that'll then for future years. So there is an immediacy to this, but there's also a medium to long term implication. Can I just ask, the Scottish model, they indicated what they believed the cost to be, but has there been an analysis of what they believed the costs would be and what it is now transpired to be?
in Scotland?
Yes.
I don't know. I honestly, I can't
The-
answer that.
the-
I don't think.
The issues to consider in all of this, one is the victim that requires to have fair compensation. The other is then medical practitioners, dentist practices, which obviously is where the minister's conflict is, all need to be able to get adequate insurance. And if you have a departure from the insurance industry of people that are going to provide cover, then that's going to increase the costs to public sector when it comes to the Department of Health. So that's the kind of rounded view that people are trying to struggle with, because obviously if you push up premiums, then you're going to potentially drive people out of providing services, and then that isn't beneficial to the wider public. So I accept all of this is quite difficult, and there needs to be a considered view taken on it, and that's just why I'm struggling to identify the need for the accelerated passage route. But I've teased the issue out enough in my own mind just at this stage. In terms of any further questions, I don't have any more. Has anyone else any further questions just of the folks here? No. Well, listen. Thank you for coming up from down below.
You're very welcome.
I appreciate that. So thank you.
Thank you. You had to get out and you didn't take it for a few days.
Yeah. Okay, members, we'll just discuss this in a moment and then that'll conclude. All right, thank you.
Thank you.
All the best.
Okay, members. So, from a procedural point of view, it is for the minister to decide if she wants to take accelerated passage, and that would then come as the relevant standing order indicates. The minister coming to this committee to explain that, but ultimately it would go into the Assembly. Now, I know members of the Finance Committee are probably more used to what accelerated passage means, and it's not something I actually ever had to deal with as an MLA on a committee that I sat on, because it was usually only ever the preserve of very few committees, finance usually being one of them. So it's not something that I'm overly familiar with in my 10 years of being in this place. So members aren't being asked at this stage to indicate, I suppose, whether or not you agree with accelerated passage, but we can flag up to the department if there's a number of concerns. I would like to find the evidence or what advice has been given to the minister that she has had to recuse herself to this extent, that she's now handed over the policy decision-making process to the Permanent Secretary, because under questioning, this is the first time that's happened. Mm-hmm. You know, there hasn't been another example. So a precedent is being set, and I think it's always important when a precedent is set by a minister that we understand what the basis of that is, and the advice that has been given to the minister in respect of that. So I would want in the letter that will go to the department that we get all of the information that has came to the conclusion reached by the minister that she's had to do this, and the issues raised about the Permanent Secretary, and if this is an appropriate role for the Permanent Secretary to have, what other alternatives were there? You know, was this something that another minister in another department should now be given the responsibility for? I suspect that's not legally something that's possible, but and it's not fair to compare it to a minister that can't appear in the chamber to ask questions another minister could answer. You know, but that's the kind of thing that happens in this place, that other ministers can deputise. Was this something that should have been considered legally to give out the responsibility for to another minister? So there's questions around that, and the other issue here, this was meant to be in the miscellaneous provisions bill, so this was going to be subject to proper legislative scrutiny whenever that bill came forward. They now want to take this out of it as a separate bill, but then use accelerated passage. in order to do it, but based on their own time frame, actually not have it finalised until after potentially the miscellaneous provisions bill could have been dealt with if they introduced that in March. So there's a lot of questions as to why they have taken it out of that process and then don't want to give this committee its scrutiny role that I'm still not convinced about. Urgency is the other one members have struggled to understand. And yes, there's always a potential legal challenge, and I'm no legal expert, but usually courts are very reluctant to interfere when a legislature is in the process of actually addressing a problem, because there's ongoing deliberation, and a court, and that's usually a very strong defence for a department and a government to say, we are now seeking to remedy the issue that we are being challenged upon. And courts very rarely ever will intervene in that stage. It's only at the point of a decision.
That was a question I was going to ask, but I knew it was unfair to ask it of them because they wouldn't be able to give that kind of information. But I agree, and I think that any judge would be looking at it and considering how long would it take for the legal process and how long is it going to take for the legislation to be completed. And I mean, they'd have to weigh that up and say, is this, particularly if it was somebody who was getting legal aid?
Yeah.
I'd have to weigh that up and say, is this value for money? Is this good for the public purse? I mean, all of those things would have to be taken into consideration.
So if members are content around those points, we'll write back and we'll indicate that at this stage the committee hasn't been convinced of the merits of the accelerated passage route, and then ask these questions that we'll seek answers to. Sinead Bradley.
Yes. Sorry, Chair. Yeah, just to support a lot of what you said there, but I really want to get a better measure of how proportionate is this. You know, accelerated passage is quite an extreme tool for any minister to reach to use, but to do it under such circumstances where she knows she has to delegate. And again, and I take your point about your constituent, and I do know of cases, but with all due respect, we have to measure what is the weight of those cases. Of course, everybody wants anybody who has an entitlement to receive that and to receive a fair one. But is there such a significant number within the system at this point in time to justify it being proportionate for a minister to use accelerated passage?
Yeah, and I suppose...
Just on the back of Sinead's point, I would also like to be sure that this is about the injured parties and not about their legal representatives, who obviously are paid on the basis of what their client gets. So I think that, you know, it's generally a percentage of what their client gets. So I would have concerns around that, because I wonder in reality how many injured parties actually know anything about, or even if they did understand what this rate is about or what it means. Their legal representatives would absolutely understand it, but do they? I'm not so sure.
Yeah, and just to complete on that point, I'm not sure which member it was that raised it, but what we're being asked to do is change the legal framework that sets the rate. This committee doesn't set the rate, so we need to be satisfied that the legal framework and the systems are appropriate. What the actual rate is not a matter for this committee, but there's nothing stopping the department from changing the rate under current legal framework. What they're saying is that the interim rate that they could use, they're not going to use because they want to change the legal framework. So if there was such an imperative to deal with the current cases, the department could change the rate now and introduce an interim rate. It's choosing not to do that because it wants to change the legal framework. So that's why I'm not convinced about the argument that we need to move through this process in order to address the issue on behalf of victims, because the department could take that unilateral action if that was the driving force. Okay, so members, we'll raise these issues then with the department. It'd be interesting just to see how they come back to it. And we can take advice then subsequent to that. I know Rachel had mentioned getting her own independent legal advice. That's always available to us from the Assembly's legal services team, but I don't think we're at that point yet. There's a very clear procedural route that's outlined in standing orders that need to be followed, and the role of MLAs to consent or otherwise to that. But let's hear back from the department in respect to the issues then that we're going to raise. Okay, so members, there's nothing else because that's the business concluded. We're due to meet again on the 5th of November, 2 o'clock in room 30. Meeting adjourned.
Thank you.
Programme signed. This is the Northern Ireland Assembly Senate Chamber Programme signed. This is the Northern Ireland Assembly Senate Chamber Programme signed. This is the Northern Ireland Assembly Senate Chamber Programme signed.